he he, hello, hello, check, check one, he, hello, hello, mic testing, check one, he, hello, check, check, he, he, hello, hello, mic testing, check one, he, hello, check, check one, mic testing, hello, hello, check, 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 hello, check, 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 hello, check, check, hello, check, mic check, check, mic check, What? Mic testing, check one, hello, hello, check, check, hello, hello, mic testing, check one, hello, check, 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 hello, mic testing, check one, check, mic testing, check one, hello, hello, check, 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 mic testing, check one, hello, hello, mic test, hello, hello, check, check one, mic testing, check one, hey, mic testing, check one, hello, hello, check, 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 he, he. Dale, va de तो dale por nena. he, check, he, mic testing, check one, he, he, check, check one, mic testing, Kalau nak naik saja sendiri. Check, hello, mic test, check, mic testing, check one, hello, check, check, hello, mic testing, check one, hey, mic testing, check one, hello, test, hello, mic testing, check one, hey, hello, mic testing, check one, hey, mic testing, check 1, 2, 3, 4, mic test, hello, mic testing, check one, hello, check one, mic testing, check one,
Check. Hey.
check, check, mic check,
Check this. 1, 1, 2. Hey. Check 1, 1, 1. Hey. Check. Check this. 1, 2. Hey. Check this. Check 1, 1, 1, 2. Check 1, 1. Hey. Check this. 1, 1, 2. Hello. Check. Mic testing. 1, 2. Hey. Check. Check 1, 1, 2. Hey. Check this. 1, 2. Check 1, 1, 1, 2. Hey. Check this. 1, 1, 2. Hello. Check. Hey. Check. Check 1, 1, 1, 2. Hey. Check. Check this. 1, 2. Check this. 1, 1, 2.
testing, check one. Hey, hey, check, mic testing. Hey, hey, hello, check. Check. Hey, mic testing, check one. Hey, hello, check one, mic testing. Hey, hello, hey, check. Hey, check, delay. Check. Hey, mic testing, check one. Hey, check one. Mic testing, check. Hey, hey, check, check one. Mic testing. Hey, hello, check. Hey, बाकी याचा होल्डर चेंज करायचा आहे ना, दुसरा नवीन काढ एक बॉक्स मधून. ये इथे कॅरेट मध्ये. Check. Mic testing, check one. Hey, hello, check. Hey, hello, hey, hello.
Welcome to the high quality sound check. Keep quiet and feel the trapper. Trapper test completed. Now feel the bass. Bass test completed. Now close your eyes and feel the vocal.
Must be a million boys down, 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 all around searching. I know he's out there waiting for me. Somebody. Be a million boys living in a great big city. I know it's just right. I look up. I know he's out there waiting for me. I know somewhere somebody belongs to somebody. I know that one. Empty earth, waiting when you love me mine. Finally happy.
वक्रतुण्डमहाकाय सूर्यकोटिसमप्रभ वक्रतुण्डमहाकाय सूर्यकोटिसमप्रभ वक्रतुण्डमहाकाय सूर्यकोटिसमप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्डमहाकाय सूर्यकोटिसमप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्डमहाकाय सूर्यकोटिसमप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
A very good morning to one and all present here. Welcome to the Breakthrough Type 1 Diabetes Mellitus DRS Symposium. We're thrilled to bring together a community of dedicated healthcare professionals, researchers, and advocates united by a shared passion for improving the lives of those affected by type 1 diabetes. Let's connect, collaborate, and break through the brighter future for type 1 diabetes management. We welcome on the chair Dr. Purvi Chawla and Dr. Sanjay Agrawal.
Good morning, everyone. Welcome you to day 2 of DR's WCPD. And it's a great pleasure and honor actually to have collaborated with Breakthrough Type 1, earlier called as JDRF. And for this very symposium, it's been planned by Dr. Partha Kar, who is here from the UK. And our first speaker for the day is none other than Dr. Banshi Sabu, sir. He's the Chief Diabetologist and Chairman, Diabetes Care and Hormone Clinic, Ahmedabad, Chair-elect IDF Southeast Asia, Vice President Diabetes in Asia Study Group, Secretary of Diabetes India and the Indian Academy of Diabetes, and the list goes on and on. Who doesn't know the game changer in the field of diabetes here? So without much ado, let me welcome Dr. Banshi Sabu sir to kickstart this wonderful symposium and a very relevant one in today's times.
Thank you, Purvi. Thank you for kind words. Thanks, Manoj and Purvi, for kind introduction. What I'm going to talk, what investigation we should do to confirm the diagnosis in a young people, diabetes in the young. I have no financial disclosure for this particular talk. The scenario is changing, and that's the reason we should investigate to confirm the diagnosis. Although type 1 is more common among the children and adolescents, but incidence of type 2 diabetes increasing. Type 2 diabetes, earlier it used to be considered a disease of middle age or the people who are older one, but now we are getting even a type 2 in adolescents and children also. And there are many more types of diabetes in young population. There are some less common, like monogenic or latent autoimmune diabetes in young, latent autoimmune diabetes of adults. We have to have a very detailed history and physical examination, and that's very important before we perform few of the investigation which is required. So this very important slide. In diabetes in a young adult, suppose you have a 12 to 30, and that's most confusing. So most of the time, why it is not coming? Sorry. Hello. I was thinking it is there. It was there? Okay. No issue.
Sir, so let me take the opportunity to ask you, how important is it for this breakthrough type 1 and RSSDI collaboration?
boy or girl presented with diabetic ketoacidosis, it's fine that you consider her or himself as a type 1 diabetes, and lifelong you have to treat. And then it was in a discussion that we told that why not we should have a debate on it. And that's how, this today talk is that we should have a diagnosis by some investigation. It's once in a lifetime. So as I told you already, the diabetes, the scenario is changing. Now in young children does not mean that all of them are type 1 only. This is like what I told. Oh, again, this is not coming. I don't know.
Team Alex.
You have done it from here only. This laptop is only projected. But still it is not. Good. So let us have a discussion directly. So there are three types of scenario. Like you have a 7-year-old female presented with one young girl who had come to me when she was intern. She was at that time 22 years. She had a history of diabetes since last 5 years when she was in MBBS first year. And she had come to my clinic for 3 months. She was having interest in diabetes. After 1.5 months, she told that she herself is a diabetes. So I asked first question, I had never seen you taking injection or insulin injection in clinic. Are you not taking the basal bolus therapy? And then she told me, no, I occasionally take or not regularly taking. Then my second question was, how was your diagnosis? So, we are forgetting the origin, duration, and progress. That is what for any clinical history when we take, we have to take ODP. That what how you were diagnosed with diabetes, what was in last 5 years, how it was, origin was in progress, And in this duration, have you developed any complication, anytime hospitalization? So to my surprise, she was not diagnosed with the history of diabetic ketoacidosis. Neither she had any weight loss at the time of diagnosis of the diabetes. No investigation was done, and she was put on an insulin therapy, which she was also not regular. Even her sugar was very, very high. So on that day, we got her investigation. It was C-peptide was after 5 years of diagnosis of diabetes. Her sugar was very high with the C-peptide was low. So I was showing you this slide that in a diabetes in a young adult, suppose someone who is below the age of 12, the maximum chance is the type 1 diabetes. But still, there is a maturity onset of diabetes in young is possibility, and there is one more condition which is malnutrition modulated diabetes, MMDM, which may not be there in the western part but western world, but we have that diabetes too. Type 2 diabetes normally between 15 to 30, and there are some couple of patients from India also, which is the youngest patient, which was published in our JAPI by Dr. Mohan, is a 11-year-old. But as per the textbook, mostly below the age of 12, you will not find typical type 2 diabetes in a very young population. Mostly it is above the age of 12, but one of the youngest female, which is published as a case article by Dr. Mohan, is a 11-year-old girl who was diagnosed as a type 2 diabetes. But this is what the age of diagnosis is also very important, and how patient has been diagnosed, that also give you some of the information. So this is an algorithm long back published in Pediatric Diabetes, again a SPAD official journal, the algorithm for differential diagnosis of diabetes in youth. And the diabetes in young, if family history of diabetes is very positive, it's been strongly positive, maybe for 2-3 generations, you have to think of either it could be Modi or it could be a type 2 diabetes also. So I mean strong family history, but with obesity, they go more with the type 2 diabetes. If ketonuria negative, C-peptide is good, they may respond to the sulfonylurea. Mostly you are dealing with a monogenic diabetes, and you classify them subtype with genotyping. And now in India, we have this genotyping which is available. Even some of the tertiary care center also do it. And ICMR Advanced Center, which is with at Dr. Mohan's clinic, you can get your patient genotyping free of charge for your patients. If there is a ketonuria, present is not there, and ketonuria is negative, but C-peptide is good, but patient is obese, the possibility of early onset type 2 diabetes. And typical type 2 diabetes in a young children or in a pediatric age group, you will see all the signs of secondary, all insulin resistance like acanthosis nigricans, or you can see even the liver is enlarged. So they are the early onset type 2 diabetic patients. Family history is negative, they are ketonuria positive. You may get with the C-peptide if autoantibody is not possible at your center. Maybe the cost may be an issue, and it can be typical type 1 diabetes. Ketonuria is negative. C-peptide is also poor. There is a history of pancreatitis, or they have history of chronic pancreatitis, or we have the abdominal X-ray where pancreatic calculi is present. It is FCPD. Again, not very common in the western part of India, and in Europe, it may not be there, but in India, we have this very common in eastern part of India. That's a secondary diabetes, or we call it FCPD. There could be other endocrine disorders which can be present. There can be secondary diabetes, which is a endocrine defects, or endocrine diabetes, or genetic defects, which is responsible for genetic disorder of diabetes. This is a paper in Diabetes Care, which was type 1 diabetes in children and adolescents, a position statement. And what they have done, typically most of them are type 1 below the age of 19. Type 2 diabetes, you may have 12%. They had put around 1 to 4% maybe Modi. Atypical diabetes, more with the African American people. They have also done the insulin level, that is C-peptide, that is with the decrease in the type 1 diabetes, and autoantibodies will be positive in type 1 diabetes, which will not be there for type 2 diabetes. But definitely obesity is one of them, a prerequisite sort of thing for a type 2 diabetes in a young children. This is ICMR Young Registry. ICMR had started a young registry across the country. There are 5-7 centers, and then they have sub-centers. I am also the part of it. The maximum were again type 1 diabetes, and there were some type 2 diabetes below the age of 25, which was also there across the country. So this what we have. Then we were having also the Modi, we were having MMDM, GDM, drug-induced diabetes, chronic pancreatitis, secondary diabetes. So you can understand that even in a young registry in India also, we have a different varieties of diabetes, and that's the reason a confirmatory diagnosis for a person with diabetes is must, because it is once only, your investment only once in a lifetime, and then you can confirm the diagnosis for that. The testing protocol is very clear. With the type 2 diabetes, as I told you, is overweight, C-peptide is normally very high, while those who have type 1, it will be less or it will be very less. Fasting lipid profile also can be given a indirect evidence because of hypertriglycemia. It is also possible that you can diagnose, or the clinically you can see the acanthosis in a young boy. This is like a 14-year-old boy with type 2 diabetes. Patient is presented to us, and you can see here, this was in a Unnikershan they had published also in their small book. The monogenic diabetes syndrome, they are diagnosed within first 6 months of life or within 25 years. A strong family history, not typical of type 2 diabetes. They will not have the history of weight loss. They are negative autoantibodies, no signs of insulin resistance, and no obesity. So these are typical of MODY or monogenic diabetes. Diagnostic criteria for them is they must be having diabetes when one parent and ideally a grandparent. So, 2 or 3 generation you will find. You have to take the history that how grandparents and how the parent were diagnosed with diabetes, and you will find that they are also diabetes diagnosed in either young age, maybe below the age of 25. Mostly we have either glucokinase mutation or transcription factor mutation. So 75% of our MODY patients will be this, which is HNF, 1 alpha, 1 beta, and 4 alpha. They are normally diagnosed in their adolescents or young adults. They have progressive hyperglycemia. So 1/3 of them may be controlled with diet only. So sometimes you may find their mother or grandmother was having diabetes, but only during pregnancy she was diagnosed. And later on she was saying that I don't have the diabetes. But actually she is a patient of a MODY which was in below the age of 25, diagnosed during pregnancy as a GDM, wrongly diagnosed, but then she may have mild hyperglycemia, why it be controlling without medication throughout the lifetime. Other 1/3 of them may be on OHA, like the normally used in our country sulfonylurea so often. Even in combination, you may use only sulfonylurea, but they might be on sulfonylurea, metformin, other combination. They may have good control, and then 1/3 of the patients may require, with a long-standing diabetes, may be on insulin therapy too. So the genetics at present we have for 13 different MODY, where we can do the gene sequencing. We can do this an ICMR advanced center. This is a Mohan slide with a patient with MODY. They have mild and severe fasting hyperglycemia and postprandial glucose. They respond well to sulfonylurea agent, while the patient with a GCK, that's MODY2, they have very mild fasting hyperglycemia, and less than 50% of carrier have overt diabetes, and microvascular complications in these patients are rare. And that's the reason the MODY2, sometimes they even don't take the treatment, and they may be just controlled with the patients with only on diet therapy too. The MODY3 is like MODY1. MODY4 is a pancreatic agenesis. So that's a with pancreatitis problem you can find out, and they are MODY4. And then all of them are like MODY9 and MODY10. They are very rare disease, MODY8, 9, 10, but that does not mean we don't have. We have some of the patients. So that's what International Registry of SPAD, it is officially associated with SPAD, and where the SWEET registry, we found that there are a lot of patients all over the world who are typically MODY in a different formats in 9, 13, and now with 18 different MODYs also been described by some of the analysis. Also, neonatal diabetes, some of the papers from India also, and some of the patients who are diagnosed, those who are diagnosed in first 6 months. But this neonatal diagnosis can be even in 6 to 12 months too. But after 6 months, if some of them are diagnosed 6 to 12, they have autoimmune diabetes type 1, they may also have. This may be again transient or permanent. I have 2 transient neonatal diabetes, but it can be permanent form of diabetes also. And they may require sulfonylurea throughout the lifetime to control these patients. Again, some problem. This is FCPD, very typical with a pancreatic calcification. These are the presenting patients are like very lean and thin, mostly getting confused as a type 1 diabetes. But the most important thing for them is they don't have ketonuria. So they don't develop, even when they are irregularly taking the insulin therapy, may not be taking sometime basal insulin also. Their sugar may be very high, but still they don't develop ketonuria. And that this gives you the clue that they are the one who are having actually patients with MMDM, and their requirement of insulin is also very high. So normally in a type 1 diabetes patient, we need, to start these patients with 0.3 to 0.5 unit per kg, and then we slowly increase to 0.7 unit per kg and up to 1.2. Most of the time they get control, but the patient with MMDM, their requirement of insulin is very, very high. And this also gives you a clinical, a clue that they could be not a typical of type 1 and they are MMDM. They are secondary diabetes. As per the classification, they are not type 1 diabetes. Their requirement is always very high for the insulin, but they are insulin resistant and they have severe hyperglycemia and they don't develop the diabetic ketoacidosis. This is condition of a LADA or lady. If it is in adults above the age of 25, we call it young, while those who are developing latent autoimmune diabetes in very young patients, not in adults, we call them a lady. These are the one who are, we can say 1.5, because they are typically those who are confused with LADA and type 2 diabetes because their age of onset may be 25, 28, 30. They may be normal weight, slight weight loss may be there at the time of presentation. So they confuse with the type 2 and LADA. Sometimes for first 6 months, they can be started with oral hypoglycemic agents. They get controlled also. And that's the reason sometimes we get confused between LADA and type 2 diabetes. And they require diagnosis by confirmatory investigation by putting them on an autoantibody, C-peptide level, all those things. And their C-peptide level also not very low. They will be slight low, but not like very low what we see in type 1 diabetes. So don't treat lightly just because they are kids. And this is most important thing, that these type 1 diabetes who are developed, or type 2 diabetes in young, or they may be MODY, or they may be patient with MRDM, we have to be very, very aggressive while controlling their hyperglycemia, because they have to live for another 50, 60 years. If you want them to have a normal life or a long life without any complication, they have to be treated more aggressively in compared to the people who are treating, like we treat type 2 diabetes commonly at the age of 50, 60, and we may not be so aggressive for those people, but someone who is developing diabetes in their 20s or in their young age, the teenager, we have to treat them more aggressively. So as I told you, there could be 3 scenarios. A female of 7 years, typical, presented with diabetic ketoacidosis, clear-cut diagnosis, maybe type 1 diabetes. Still we need to confirm, not necessarily as per SPAT, it is good to have autoantibodies and C-peptide. So this is what even a 7-year-old girl, typically diagnosed, hospitalized with diabetic ketoacidosis, all symptoms with this, we should have autoantibody. And let us create a habit of doing autoantibody more often. We may say that it is very costly, but I am sure when we all will start sending patients for their autoantibody testing, the investigation cost will significantly decrease. This had happened for C-peptide. This had happened for HbA1c. You know, before 20-25 years, the HbA1c in India was costing 600, 700. Some of the lab used to charge 1,000 rupees. Same was the C-peptide. They used to charge for 1,500, 2,000. I'm talking of before 20 years. Now today, they are charging only 400 rupees. Even in autoantibodies, if you have your own lab, and if you have significant number of patients, you can do it, and the get autoantibody with the testing will not cost you more than 500 rupees also. With the lab, they are charging 2,500 definitely. And if you want to get all 3 autoantibodies together, the most of the labs will do in 4,000 rupees if you are sending them regularly. So make a habit of doing more often, and I'm sure the cost of these autoantibodies will also decrease in our country, because the time had come now, we have to think for prevention of type 1 diabetes, where you have to do the siblings also for their autoantibody, and we want to know that whether they are going to develop diabetes or not, and we have to prevent for that. If a female 12 years presented with a significant weight loss, but not with diabetic ketoacidosis, should we confirm? Yes, we should confirm by getting autoantibodies and C-peptide. But if she's not having a typical symptoms, and there is a symptoms like with acanthosis nigricans, with insulin resistance, I think you can get still C-peptide is better and get the autoantibodies, because some of the obese children also developing type 1 diabetes, and you may get confused if they are type 2 or type 1, get their C-peptide and autoantibodies. Also, as I told you, if your 17-year-old boy or male or female is presented with this confirmatory test are must. It's not like that we should not do. So sometimes to diagnose someone once in a lifetime, it may be costly, but I think it's better to have it, put it on a capital letter on its file, ask the patient that keep this report throughout your lifetime with one good C-peptide value report and one report of autoantibody, which will be good. So managing diabetes in young, type 1 definitely insulin, fulminant diabetes has to be on insulin, LADA patient preferably on insulin only, because some of them are still continued with sulfonylurea, and because for first 6 months they were controlled, they are confused also. Patient always argue with the doctor that, I was well controlled with sulfonylurea and some oral anti-diabetic agents, why you want to put me on basal bolus therapy? MMDM definitely on insulin. They may be given sometime a very small dose of metformin because they have very high insulin resistance. FCPD is a condition which is a secondary diabetes, should be on insulin. MODI is a 1 and 3 sulfonylurea. As I told you, they can be, some of them can be controlled only with their diet therapy also. On insulin, MODI 5, neonatal diabetes, mitochondrial diabetes are on sulfonylurea. Type 2 diabetes in young, still now we don't have much data below the age of 12, but definitely between 12 to 18, metformin is the choice of therapy. Lifestyle modification and weight loss. To summarize my talk, diabetes now perhaps the most common endocrine disorder in children and adolescents across the world. So it is the most common. After that comes the pediatric bronchial asthma. Several unique challenges are there. Differential diagnosis wide. Clinical course is likely to be more aggressive. Adolescent patient is prone to develop disease complication not only because of the long duration of hyperglycemia they accumulate, but also due to inherently aggressive nature of the disease and suboptimal control. Unfortunately, the diagnosis of often delayed, not in type 1, but some of the slow growing type 1 and a lady patients. Timely and accurate diagnosis combined with regular follow-up and maintenance of optimal glycemic risk factor control by judicious use of available therapy will ensure these young people enjoy a long, fruitful and a complication-free life in spite of diabetes. So this is like seeing an elephant from where? You may find there are 4 legs, someone may be seeing only 1 leg if you are seeing only one side of it. So whenever you are seeing a type 1 or any young person with diabetes, try to find out that what type of diabetes he is having. With this, to know more about diabetes, we have our national meeting, national conclave, type 1 diabetes conclave type 1 at Jaipur in month of December, 7th and 8th December. We have with us the international patron and founder members, me, Archana and Partha is here, and the organizing secretary for this meeting is Dr. Meenal Mohit. With this, I once again thank Manoj and Purvi for this wonderful opportunity.
Thank you, sir, for that very, very lucid presentation and very important one. Countries are talking about universal screening for type 1. How far are we from that, and what can we implement in India?
So you are talking of prevention of type 1 diabetes?
No, actually, so just early detection and accurate detection. So screening for type 1, are we even there
So
yet?
I mean, just now before, in the other room, there's the type 1 diagnosis and early screening for all of them, because we have now therapy which are available, which can prevent or which can delay the diagnosis. Now, it's very important. Someone may say that it's very costly, why we should do it. But I say that at least the path have come. Now there is a immunotherapy which is preventing. Today it is only preventing or delaying type 1 diabetes maybe for 1 year. A time will come that these are multiple immunotherapies using in combination may delay it for more years. And a time will come that even it may permanently prevent also. So it's a new area, completely immunomodulation. And it's not only for type 1 diabetes, but many more other immunogenic diseases also will be in future, will be prevented by this immunotherapy. So new path have come, and I'm sure we are very optimistic. At present in India may not be ready, but we are trying that, how many of our type 1, because we have many persons with type 1 diabetes whose autoantibody negative. We can call them an idiopathic type 1. We may not get that. We have, and sometimes
Is that
we
around
don't
20%?
do all three.
20%?
Yes, so 20%, but we do first GAD. If GAD is negative, then I do ZNet, add IA2. But we still find the GAD is the most common which is done because it's most cost effective too. We don't get all 3 of them. But yes, it should be done. And we may find that 20 or 30% of our patients, even typically presented with type 1 diabetes, have idiopathic type 1 without any autoantibody positivity. At least these 3 of them are not.
Great. Do we have any? Yes, sir.
Yes, sir.
patients in our
Yes, sir.
type 1 clinic. The gene score, which we have for Indians, then the 3 antibodies and IL-2 and the zinc.
All 3 autoantibodies is done for all 800 patients. Yes, sir.
Antibody negative, some of them because of the we developed the gene score, which is published with etc. But you didn't mention Wolfram syndrome. There seems to be an excess of Wolfram antibody. Each party are reported it from. And we have now 20 cases.
20 patients with Wolfram.
Wow.
But that is done regularly for most of the time. Great. No, if they develop the symptoms, particularly for hearing deafness, we definitely do it for them. We send them. Wow. No, this is very important. Say out of 800, if 20 patients, that's very big number. So, I am in the registry and we have database of 1700, which we are regularly doing. But we have only one, which has been confirmed and diagnosed with that. So we have only one Wolfram. Thank you, sir.
Great discussion. I think in the interest of time, because of a technical issue we started late. Maybe we can have it at the end of the session. They are all here. Thank you, sir,
Thank you,
for
sir.
that fantastic talk and discussion. May I invite Dr. Sujoy Ghosh for the next talk. He is a senior endocrinologist from the city of Kolkata and very accomplished professor of endocrinology at IPGME and R Kolkata, international member of the International Advisory Board for the endocrinology section of Davidson's textbook of internal medicine, also the National Joint Secretary, Indian Thyroid Society, Vice President of RSSDI, and the list again goes on. But let's hear it from him for managing type 1 diabetes in limited resource settings.
Thank you, Dr. Pul.
I'll request Dr. Anil Virmani and Dr. Abhi Chandani to come to take chairing of this session ahead. Apologies
Right,
because
that's
of an
fine.
emergency.
Can I have my slides, please? Hopefully, yeah, the slides are there. Right. So I'll come down from where Dr. Bansi was talking about antibodies, and then we went on to talking about universal screening for type 1 diabetes to something which is closer to the ground about how do you manage most of our patients with type 1 diabetes, because managing type 1 diabetes is resource intensive in terms of finances as well as people who would actually manage type 1 diabetes. So if you're looking at the challenges in India, of course, is the economy of India, the proportion that is actually spent on health, level of education and awareness, available infrastructure in terms of management of type 1 diabetes, the challenges related to diagnosis and management. We were talking about whether to do C-peptides and antibodies. A significant proportion, I still believe, die without a diagnosis of diabetes. And of course, behavioral and psychological issues. So in terms of the policy gap, there is still no national health policy. Let us hope it happens next month. There is no medical support system in terms of in the government hospital. In at least most of the states, you don't get insulin syringes, insulin, glucometers, strips. No emergency support system because those of you who are sitting here are interested in type 1 diabetes, but you will see a general physician or a pediatrician is scared to manage type 1 diabetes. Anybody with a type 1 diabetes, whatever disorder, they will say, नहीं आप जाइए आपका डॉक्टर के पास जाइए, गवर्नमेंट हॉस्पिटल में जाइए या to a private practitioner. And we don't have enough number of diabetes educators to manage type 1 diabetes. There's no program to support prevention and complication. Insurance, job, nothing of that is there. So when we talk about in resource limited setting, I don't know whether you can at all read, I'm trying to talk about the bit in the yellow, the intermediate care. Because you know, in India right now, on an average, a type 1 diabetes individual lives for only 29 years. Whereas the national lifespan is 70.5, almost 71 years. So that's the kind of life years that is lost because of type 1 diabetes. So in that intermediate care, I'm talking about a basal bolus insulin, where the basal is glargine and the short-acting insulins or the boluses are human insulin, a glucometer, and where you have at least 3 strips a day, preferably 4 plus. At least you have some way of doing an HbA1c test, and the basic anthropometry, basic screening test, basic diabetes education, and with a target HbA1c of somewhere between 8 to 8.5. That itself would reduce a lot of mortality and morbidity in our type 1s. Can we achieve just this? So we know so much about management of type 1 diabetes. Partho is going to talk about closed loop pumps and things like that. We know all of that, but what about implementation of what we know? That's the gap. So we need some amount of implementation research, and we need a model of care wherein the medication, the monitoring, the counseling, the emergency care, and an electronic registry would be the basic components. And the components of care, I've already talked about the gap areas, so we would be providing these components of care. And the model should be scalable, replicable, cost-effective, and in line with the adult NCD program. Otherwise, the government will not support it. So on that basis, we first launched 5 clinics. We have now launched 15 clinics in the state of West Bengal in 15 district hospitals. In the adult NCD clinic, we have converted it into once a week type 1 diabetes clinic. And that's the official logo, which the government of India has also adopted, that this is going to be the logo for your type 1 diabetes clinic. So if you're looking at how to set it up, the first thing was to have a sensitization program of all stakeholders who would actually be responsible, identifying and utilization of the current resources. So I'll go all of them step by step. So in the sensitization program, we told people about the outline of the program. We identified the human resources. We reassessed the existing NCD clinic, and whatever was there in terms of the gap, we went and filled that in. So that's the human resource, that's the physical infrastructure. And we made training modules and prepared stuff like finding an identity card, a patient diary, an SMBG logbook, a type 1 diabetes diary. You needed letters to be sent out to the school, an IEC booklet, and monthly summary reports. We created an online web-based application portal through which every child could be registered and followed up on a monthly basis, and all of the data could be kept. You had to ensure that you had absolutely perfect stock keeping, and that there was no time when the patient would come and you would say there is no insulin, there is no glucometer, there is no syringes. So all of that is there. Stock maintenance, completeness of data. And to start off the program, we had a program at the state level where we brought in people from all of these districts, trained them up. And then we had an initial visit at the site where we met the core team, and we prepared certain checklists through which we ensured that everything was there on site. The things that were not there in terms of the trained resource or equipments, drugs and consumables, We ensured that they actually made it available before the clinic would start. And the supply chain maintenance is absolutely important. We ensured that the clinic itself had the pharmacy. It was separated out from the main pharmacy of the hospital to ensure that the supply chain was uninterrupted. We then had an on-site orientation cum training workshop about the management of type 1 diabetes, and then went for community mobilization. So training of the ASHA workers, the ANM workers, and telling them that when you are going to the homes to fill in the CBAC form, you have to ask whether there is any child with diabetes or any child with symptoms of diabetes who could be actually referred on to this particular clinic. At every healthcare facility of the hospital up to the district general hospital, you had a poster and a leaflet, and that all healthcare professionals were trained that if you have features like A, B, C, D, for example, polyuria, polydipsia, altered sensorium, increased breathing, do a blood glucose test so that you would diagnose. And timely referral of the patients to the type 1 diabetes clinic. Now, it's very easy to have perhaps all of this, but it is important that you have some kind of support system. So a hand holding for 1 year. So mentoring of all of these clinics by a trained endocrinologist for 1 year, so that the person who is, because this entire group of people are people who have never treated type 1 diabetes before. However much you teach them theoretically, you need some amount of hand holding. And we have regular audits of processes, including the stock and inventory, monthly summary reports, checking completeness of data entry, identifying gaps, and telephonic contact with trained program coordinators for emergencies. So if there is a problem, they will call up the district NCD counselor who would try and help and guide. If it didn't work, the child would come to the hospital. If that didn't work, there's a blue light ambulance that would pick up the child from the district hospital to a tertiary care hospital to a department of endocrinology. So this is what one of the district hospital clinic now looks like. And every 3 months, we are doing camps so that you can actually educate the children and the family. The children themselves are the educators right now, in the sense that one child demonstrates how to take insulin, then the others learn easier. And particularly some of the topics like sick day rules need to be re-educated and re-taught repeatedly. And so that's what we've done. I'll just skip that. This is some of the other pictures. This is our initial card, the anthropometry that we look after. This is what we do in terms of management and screening. These are the investigations that are provided for free. This is what are the consumables that are delivered on a monthly basis. This is our training material, the monitoring material, and the daycare facility and timely referral. So if I look at the data at 1 year of 4 of the clinics where we have newly enrolled type 1 children, you can see that the monthly family income of these families is somewhere around 7,000 rupees, which is for a family of 4.5 approximately. And to start with, when we inherited these kids in our clinic, you can see almost about 60% of this clinic were on basal bolus. 40% of them were still on premix and split mix. At the end of 1 year, everybody is on basal bolus therapy. If you look at the injection sites, about 20% of the children had unhealthy injection sites. So that's now come down to less than 2%. In the past, a lot of these kids were not taking the insulin themselves. It has improved. It's only the ones who are below 7 that the parents are probably still injecting. The HbA1c has come down by about 1%. The fasting glucose has come down. The postprandial glucose has come down. In this 1 year period, our ketoacidosis rate has come down to 0. Overall hypoglycemia rates has come down to 0. Hospitalization has come down to 0. And death has come down to 0. If you're looking at the clinical and psychological well-being, so the diabetes-specific health-related quality of life, the parents' reported quality of life, the family functioning have all improved. And if you look at the monthly expenditure that these families were incurring, at the bottom, if you see, At the beginning of inclusion of them into the program, they were spending on an average 3,500 rupees per month when the family income is 7,000. So 50% of the family income was going in managing one child with type 1 diabetes. That has now come down to somewhere around 400 rupees per month. That too is expenses like traveling to the hospital and things like that. And more importantly, these children that we are looking after, 40% of them are below poverty line, and 70% of them, both their parents have not completed primary education. So in that setup, I think we've done reasonably well. And thereafter, we wrote up in the Lancet that this should be the model of care from the National Health Program. This is our methodology paper, and hopefully the draft document which is lying with the Government of India will be launched on 17th September next month. Thank you very much.
Thank you, Dr. Sujay. I know the West Bengal model is being followed in a lot of places. I hope it is done throughout the country. Any questions from the audience? Yeah.
May I have a comment?
Yeah.
Sir, thank you very much for very, very eye-opening and motivating talk. I think it's a learning process that we will imbibe from the current presentation, and we'll take it forward in the best way we can.
Thank you.
And I would urge everyone to go through that 2022 superb paper. I think you were the main writer. You just flashed it on the screen, and it's a very lucidly written paper, and that paper will probably guide us how to go forward at our individual sites and in our states. Thank you, sir.
Thank you. So I think one of the things that I was trying to show was the local sites. So because children often don't change sites, the needles and things like that. So local site abnormalities. And if you're talking about the problems that kids face with type 1 diabetes is wide swings in blood glucose. So there will be hypoglycemia if you are using a basal bolus insulin. That we can probably minimize with better carb counting, better education, but we can't do away with it entirely.
Thank you, Sujay.
Thank you.
I would like to invite the next speaker, Dr. Ashna Sarta from Aurangabad, who will be talking on effective camps and group sessions for type 1 diabetes.
Good morning, everyone. And after listening to the first talk by Dr. Bansi Sabu, where we had the whole diagnosis dilemma, and then the low resource care setting. So we have seen the diagnosis part. We have talked about even in low resource setting, how Dr. Sujoy has managed to have a beautiful model that has gone to the last mile, and we all want to actually emulate it. We are trying to make it happen in the entire country. I'm going to talk about something which makes that care happen, because it's okay to deliver it in the sense of putting it on a prescription or trying to make it accessible, affordable, but how do you motivate a person to actually accept it? The way the question was just asked, that is it safe, all those insults or lipos are happening, all that. But how will that happen? That this is minimized, and that will happen through a lot of education. So one-on-one education, especially in low resource setting, although it has to be done, but it can be reinforced beautifully when it comes to various camps and group sessions. I sort of made this talk thinking of people who are already doing camps and sessions, and hence I emphasized on the word effective. Everywhere these are happening, but to make them effective, I have just included things which are usually missed. So just to do a camp that where people gathered and we are teaching insulin technique versus doing something where the missing links in a camp and optimizing the outcome by
little tips, and that is just something I wanted to share because it's been like 25 years of camps, camps, and camps and camps. So I thought I'll just share those practical tips. So first, camp. Why a camp? Camp is a residential time when kids and youngsters are away. They feel free, they're in a safe space, and they're away from parents, because always being supervised, always being amongst their anxious parents can be also a burden. And when they are there, they understand that their colleagues are living with type 1 diabetes, and they understand it very well, and make the camps child centric. So my tip here is, whatever activity you design, involve children in it so that they tell you what they want. For example, we did this residential camp in a school, 100 girls from villages, and we asked them, what do you want? They said, we want to swim. We have never been in a water body in our life, because we are not allowed to dress that way, go into the water. So we requested a school in the summer holidays to give us their premises who had a swimming pool. And we did a summer camp there where the girls in morning, evening, we taught them how to swim. And these are girls from villages. Swimming was not important. The happiness they got from swimming with their peers made them want to do carb counting, made them want to inject themselves, check their sugar before, check their sugar after. So camps are a great way in setting the context, making them want to. And what are group sessions? Something like this in a conference, but for people living with type 1 diabetes, their interactive session always to be led by a mentor. If you leave them alone, we think they can be free sessions. There should be a secret mentor. If we want them to be alone, it could be a secret mentor who secretly has been appointed the job. And so these, I call them planting a champion. So if you have a group session and it is supposed to be interactive and free, you still plant a little few champions to drive the positivity of that group. Because otherwise it could become, one negative can turn everyone negative versus 9 positives making everyone positive. So it's very important to plant these positives in a group. So it's not just casually, it has to be planned. So if you want to make effective camps, then you must know what is the effect that you desire, right? Unless and until you pin it out that from this camp, from this workshop, this is what I want to have. So for example, there is a carb counting workshop, but there is a hidden agenda of building acceptance and confidence, because self-efficacy will improve. There's a trekking activity that we did because it was self-management. 100 children trekked for 24 kilometers last month. But what happened? They learned how to check their blood sugar levels every hour because everyone was doing it. They knew how to keep it in time and range, because otherwise they feel very lazy about it. They knew how to carry a 1 carb snack and how to eat it at frequent intervals without telling them enough lecture form. Because it was a protocol created, because everyone was doing it, because it was a group, it was except the naughtiest one was compliant and they were able to do it. So that's the value of a camp. But to be able to do this, your purposes could be any. It could be teaching purpose, it could be life skill teaching, fitness, family camps, research camps, whatever camp you do. Most important is planning, and this is what I want to share. So they just don't happen. You can't wake up on a Sunday morning and say next Sunday morning, chalo trek pe chalte. That's not how a camp works. Half the job, or more than half the job, is planning, selection of the participants. If you have, we want everything to be inclusive, but if you don't match them properly, it can be a disaster. For example, I have very low resource setting people, and I have children living in very high resource setting. And if you mix them, it may be good for some, but mostly it would lead to complexes here and lack of meeting each other. So one has to think of that psyche while we are selecting who we are taking together. For example, cultural appropriateness. So why do I do girls' camp separately? Because I have lots of Muslim girls who will not take off their burqa if a boy is around. And I don't feel, I'm not going to challenge that. I am not going to give them a lecture ki take off your burqa. I am going to say, I'm going to give you a safe space where you can do so and still learn how to manage your type 1 diabetes. Have a list of tools needed. There are slow learners, visual learners, doers, people. So you can teach by dancing, you can teach by mimicking, you can teach by actual hands-on workshop. You can teach by only audio. Learners are different, but everyone can learn. So if you're doing a camp, imagine if there's one who just does not understand this way, does not listen. There's a child with ADHD, is restless. That child, the camp is not going to have any benefit. So it's very important to design it that way. And for this, we need a good team. So camps can be harmful if not designed very well. Even if 5 children go back feeling that, no, I can't do this is too overwhelming, I can't be like that star who was on the stage, it's going to set them back by a couple of years rather than take them forward. So a lot of effort should go into designing a camp. Team has to be oriented, and one of the very important points in a team is you should have a very, what would you call, everyone should have a similar goal and vision. You have to orient them, define what is not to be done. I'll tell you what is not done in Udan's camps. Nobody in Udan is allowed to scold or take a negative action except me. That power is only with me. No matter what happens, somebody beats up somebody, doesn't matter. That power is only with me, because I cannot trust them to do it right yet till they become mature. And this team of mine is everyone is living with type 1 diabetes as a parent. Hence the empathy, learning, motivation. So even if you don't have that many, but do involve people living with type 1 diabetes, I think there's going to be a whole talk on that. And they are the best advocates. What can go wrong? Dr. Banshi will remember this. Diabetes India, our first one-up challenge to Kalsubai. Okay, great. 23 kids came from all over the country, all over the place. I was there with them. I had a medical team with me. We prepared for everything, and we thought nothing would go wrong because these were people supposed to have screened by their own doctors, certified that they're capable, because I don't know what's happening in Kolkata or Chennai. But on the top of the hill, in a tent, midnight, raining, dark, and this 6'2" guy, weighing 90 kg, starts convulsing. And I'm in the tent next to him. There's a growling noise, and I thought there is a wild animal there. And I suddenly realized something shaking, and we just went out there. He had a room partner. Room partner didn't know, a tent partner, didn't know what to do. And of course, our whole team was there. It was so tough. So he was in severe hypoglycemia. When he came out and he said, "Oh, you're just like my mom. My mom also does this for me." I said, "What do you mean? Has this happened before?" He said, "Yeah, it happens to me once in a while." And the doctor didn't inform us. So anything can go wrong. Even when I remember it today, it gives me goose pimples because I thought of a million possible scenarios of what could happen on top of a hill. And that was so scary as a person responsible. So be prepared, take legal notices from everyone if you're doing, because as an organization, you're responsible. It's not only from minors, take them from even majors of their own deposition. So minors will be wards, otherwise it will be done. And very important is every child matters. Who do we bring here as a star? I always say that why is that person a star who has secured 100% marks or become a doctor or something? That's okay. But these are the stars. So in Udan, in camps, what we do is chill. So we don't have people who have done great and then give the award. We think, who are the kids who will benefit from an award? Who are the kids who need to come on the stage? Who are the kids who need a prize and it will change their life? Because they will go back home and somebody is going to say, wow. And their acceptance in their society will change. And we work the other way around and we create titles for the awards to give them that way. So if you're child-centric, that one award in a camp, one prize in a camp. So why not? I have like hundreds of titles for awards. We give so many. But that child comes back again and again and again because they feel special. Another very important time is free time. I have been to many camps which were not organized by us, and we found it's too back-to-back. Children don't like us, adults, us as in adults being there all the time. Give them me time. Let them do what they want. Just have a very unobtrusive kind of a supervision, very, very planted supervision. So I think parents know how to do that. You keep a watch, but you let them be. This is something very important, very close to heart. Choose your words carefully. Language does matter in a camp. I have seen things go wrong. I have seen children from places gone into depression because of a camp and not come out of it, which was the goal. Simply because not the right words in the right way was it. So it needs training. Let's not take it that lightly. We can do harm as well. So it's very important that we actually learn and train ourselves in child care, in common psychology. The words we use are very, very important. Being sensitive is, I think, the whole purpose of the camp. Education I've not covered because that you all know. We're going to teach carb counting, we're teaching dose adjustment, pumping, whatever you want to teach. But that's 30%, 70% purpose. Why are we doing it in a group session? Why are we doing it in a camp? Is we want to make them want to learn this and do it for the rest of their life in a happy way. So even if they learn a little less, it's okay. But if they have positive memories, it's going to have a large impact and they'll come back and back. This boy has Down syndrome. So he was the star of our show. I mean, he has Down syndrome. He has siblings who have Down syndrome. He's living with type 1 diabetes. He has such a beautiful smile. And we made him the star of the show. And people were like, he doesn't really dance well. That's your problem. That's how you see it. We found his dance beautiful. So if you are sensitive, this boy who never wanted to come to the clinic now asks his parent every time. He will remind the parents now, it's time for my insulin shot. And he keeps that prize he got and he says, I got the prize, I will take insulin. So that's how it works. It can change a life. So be sensitive to who are there with special needs, who are usually not included, and a little bit can go a long way. And this is my last slide. I call it, in Marathi we say it's Shevat God. So whatever happens in your camp, you might have to scold somebody, you might have to, reprimand a child, something may happen. If while leaving, you make it happy. Whatever happens in your clinic, you might scold a child, falsified your diary, this happens, that's happened. जाने से पहले पीठ पे हाथ रख लो, सिर पे हाथ रख लो, जप्पी दे दो, and ending में कोई अच्छी सी बात कर लो. Right, so if the last memory a person has before leaving should be a recap of all the happy things that happen. And our mind is very easily modifiable. They forget all the negatives. They go back with a very happy memory. So all these together can, other than the education, I didn't cover the education because that I believe all of us do know, but these are the things which can make a camp go wrong and if handled right, can make camping the life-changing event for people living with type 1 diabetes. Thank you so much.
Thank you very much. A big round of applause for this brilliant talk. Thank you so much. It was an absolute learning experience. And what takeaway? I don't think there would be any questions. Everybody is just to admire your slides. Thank you.
Thank you.
Is Manoj there? Next speaker is, I think, Dr. Manoj Chawla. He is there. He'll be talking on AID, arguably the best treatment for type 1. I don't think he needs any introduction. He's already the star of the show.
Thank you. Pleasure being here, and thank you, the entire team here, to ask me to be a part of this type 1 symposium. Can I have my slides up there? Okay, so what I am speaking on the next 12 minutes or so is about automated insulin delivery devices, arguably the best treatment for type 1 diabetes. Okay, so, well, the best glycemic control system in the universe is what God has given mankind in terms of the human physiology. I don't think any of our efforts yet can come close to what the body offers in maintaining a perfect glucose homeostasis with an interplay between the periphery, when you talk about the pancreas, the adipose tissue, the central glucose sensors, the autonomic nervous system. So it's a complex mechanism, but well-oiled machinery which works well to keep things going. Now, when we come to automated insulin deliveries, well, let's understand what's evolved. So you talk about the important terminology. There's often confusion amongst people who use insulin pumps or those who want to start using pumps. So what's changed is, let's understand, in the progress you first had the sensor augmented pumps. So these were pumps which were integrated with the CGM devices compatible with the same. Then you had sensor augmented pump with the low glucose suspend technology coming in, which then moved to having an overnight closed loop system. So the need has always, the holy grail that one has looked for is to get a completely automated insulin delivery system, which of course is the dream would change lives of people with diabetes, and it's doing that largely. So you then got approval for only an overnight closed loop, then got into a hybrid closed loop system, which automatically determines the basal insulin infusion throughout the day with user-initiated mealtime bolus. So patient would still have to do the carb counting, look at the sugars, and then decide on their bolus doses. And then eventually we moved to having the advanced hybrid closed loop system. The improvisation was that you had, it still automatically determined the basal insulin throughout the day. As you said earlier, it was only overnight, then moved to throughout the day. But in the AHCL, beside the basal insulin, which was automatically controlled and automatically changing throughout the day, you also had correction boluses, which means that the patient would still end up taking their bolus, but the moment the sugars would go above a certain level, it releases a bolus rate, which tells us that we've reached an AHCL, but yet the holy grail and the dream is to have a completely automated system without patient intervention for taking that bolus as well. Hopefully that's what the future holds. So that's been the evolution of technology over 100 years, from the discovery of insulin to the earlier pumps, and then the evolution to the final AID systems. Now, when we talk about the guidelines for automated insulin delivery, and the topic essentially I'm speaking on, is that the best solution? Of course, many would argue and say, well, we are talking about in India, where people with type 1 are still landing up in hospitals with ketoacidosis, not getting their insulin, and unfortunately, in places with limited resources, we are still losing patients with type 1 who are dying. Well, yes, India is a diverse country. You have extremes of population, but very often we need to realize that while we are doing our bit to try and increase the insulin reach to every patient across the country, we also are trying to provide the best of technology for those who can afford it in a self-pay market. So when you look at the ADA guidelines, it talks about, well, who should get it? The AID system should be offered for diabetes management to youth and adults with type 1 diabetes. When? Well, it also goes on to say that initiation of the pumps or continuous subcutaneous insulin infusion systems, this could be offered even at diagnosis or in the treatment of diabetes, can be beneficial depending on a person or caregiver's needs. And I would take a step back here and say, I'm not a big fan of AID systems at diagnosis. There are many centers across the world which are doing this. I think here in India, we need to be a little more pragmatic about it. I would still want every patient with type 1 to first learn the basics of injecting themselves with an insulin syringe or a pen device, so that in case of emergency, they know how to do all of that, and then move on to learning the use of the pump. So yes, every patient with type 1 should be offered the pump, but not immediately. Individually, as a clinician, you can decide whether this could be 3 months, 6 months, or a year later down the line. Earlier, the better, but not at diagnosis yet, unless there's a different level of maturity in the patient and the support system. So a cross-sectional study at the Steno Diabetes Center, Copenhagen, talks about the glucose monitoring metrics in individuals with type 1 diabetes using different modalities. This was a real-world observational study which spoke about how the different systems were doing. And when you look at the data for multiple daily insulins, in terms of the time in range, they were at 54%, yet doing 41% above the range. The sensor, the sensor-supported pumps were doing a little better again, but not too different. The sensor-augmented pumps moved to a 63% time in range, but where, of course, AID has come in, it's changing the scenario and making patients reach that target of doing at least 70% time in target with minimal or no time below range or hypoglycemia. Now, let me present some data from India. We have enough of global data, but every time it comes down to that, how realistic it is when we come down to what's happening in India. So this is a paper by the Pediatric Endocrinology Group headed by Abhishek Kulkarni from Mumbai, glycemic outcomes of Minimed 780G system. So when we talk about advanced hybrid closed loop technology in India, what we have available is the Medtronic 780G systems. Across the world, they have different options, but as of now in India, we have the 780G available for us. So this is the data for use in children from India, and they look at outcomes of comparing the outcomes of European and Indian children less than 15 years with type 1 on 780G. And we're doing pretty much similar, and that's the beauty of AID systems. Irrespective of what you were on earlier, irrespective of whether you are in India, parts of Asia, Europe, or the Americas, you're going to see similar data in a few months' time. So here we can compare, and of course the European data has the pre and post, 60% time in range moving to 72%. And then you look at the post AHCL data from the Indian 160 patients, which they did the initial analysis in children less than 15, you're seeing them touching 71% time in range. Now these are a couple of papers, so I would request no photographs as this is yet to be presented at the ATTD Asia meeting. Well, this is a paper where we spoke about automated insulin delivery system adjusting to the physiological changes in Ramadan fasting. So this was done in this year's Ramadan, which happened, which was between 12th March to April 11. And when you look down in terms of the TIR metrics, for 30 days before Ramadan, patients were doing 73 time in range. This is all those who were on the AID systems. They get into the Ramadan fasting, which we know, like any of these long hours of fasting can be tricky. What we saw that is during the Ramadan fasting, they maintained 71% time in range with nothing in the hypoglycemic range, which is most important in these prolonged hours of fasting. And then in the follow-up in the month after the Ramadan, they continue to do well with 74% time in range. So this paper is accepted for an oral at ATTD Asia, and we'll be presenting there. This is other one headed by Banshi, which is talking about time in tight range achievement. So we are aware of time in range, and I think over these 3 days of the meeting, you will be hearing concepts of even time in tight range, which refers to the range between 70 to 140. So what are patients on the AID systems doing? We're doing about 75% of it average time in range. And no other data in terms of even patients using CGMs or even the sensor augmented pump failed to get us there what AID does. So you're getting 75% time in range in this cohort and 50% doing time in tight range. Actually, when you think about it, you realize that how naive were all of us when we were earlier using pumps with the belief that basal insulin can be constant, right? We were all taught that fix the basal insulin dose, and it's only the bolus that the patient has to learn to do carb counting and change. It was silly of us, we were naive, because basal infusion rate changes every few hours. And that's been the pathway when you have moved to the automated insulin delivery devices, because it is changing your basal infusion rate every few hours as required. This is the third paper, which Jyoti will be presenting. Switching to automated insulin delivery system, retrospective data from India, from multiple centers of which are using the AID systems. So before AID, the average A1C in these patients, this cohort was 8.77 with TIR at 44.5. Post the use of AID systems, when we analyze the A1C has come down to 7.1 with the TIR improving to 75.9. Now, let me quickly show some cases of what's happening and our own experience and why I strongly believe that the AID system is arguably the best we can offer to our patients with type 1. 16-year-old female student visited us in 2021, complaining of a lot of fluctuations of blood sugar. We got into the basics of diet, injection technique, reviewed all of that, which I believe all of us should be doing for all patients on insulin. She was typically on an MDI therapy with some aspart and glargine through the day. Her A1C, in spite of those 4 shots, was 11.8%. And on that particular day, sugars at 315, 429. I don't see a single eyebrow being raised in the audience because everyone comes across this. Being a type 1 on MDI, just taking your MDI 4 shots is no guarantee that your sugars are going to be under control. And unfortunately, we have many patients with this kind of reading out there. Well, she starts using a real-time CGM. So fine, that's the first part, that you convince them to monitor more often. And you start seeing the data. This is a snapshot of the CGM data. An estimated A1C, which may have its own limitations, is still at 11%. You're seeing in target only 7%. 93% in spite of 4 shots of insulin is above target, above 180. And the coinciding readings at multiple times we can see. So Well, we get us started on an insulin pump. We talked to the family and we said, okay, let's use the pump available at that point. Honestly, I've forgotten what pump we gave this child at that point. But she starts using the pump, so she's still taking her boluses on the pump, and we have set a basal rate. As I said, we thought we were getting her onto a pump and we're going to change her life. What happens after that? She still continues to use CGM. Well, and see the profile on the top. In spite of all the efforts, the A1C's come down, but to 9.9, she's moved to 22% in target. It hasn't changed much. And which is when 780G comes in. We again counsel the family. They are fortunately affording and want to do everything for the child. Said, fine, we'll move. Luckily, Medtronic was offering some exchange system in those days for those who wanted to move up to 780G. I don't know if they're doing that anymore. And this is the data soon after getting onto the AID. You see the picture getting flatter and within range. You've been hearing the term FNIR, flat, narrow, and in range, and that's what beautifully happens to this. You're suddenly seeing the time in range improve to 84%. It was meager 10-12%, moved to 22% with the basic pump, and then moves to 84%. And this is the trajectory of her A1C coming down to last year coming down to 7.8 from the 11.8 where she saw us the first time. This is a recent data. I think this is uploaded till very recent, a couple of days back, I think 28th August. So this is her most recent data. Fortunately, it all gets connected with our system, so we are able to monitor and see. So we've just downloaded it yesterday or day before. And she's continuing to do well at 73 to 77% in range, hardly any hypoglycemia, can still improve a bit with those excursions. Well, another patient, again a student, having issues with multiple hospitalization for DKA, sugars just out of control. You try and review everything. Again on MDI, aspart and glargine, A1C is at 8.8, high sugars. Starts using the Libre Pro intermittently. So gets into CGM. What was available back then was Libre Pro. Starts using that. No, I think. So she starts using the Libre Pro, and she also gets onto the 620G insulin pump at that point. Again, similar basal insulin fixed with some boluses. And we start still seeing a huge variability for her. So we're seeing the Libre Pro data. Again, do not look at the estimated A1C has its huge limitations. You're still seeing a 58% in target. But what's worrisome is she's still having 17% hypo and going time below range. So you've gotten her onto a pump, but still not able to change this aspect. Well, starts using real-time CGM intermittently from the Pro, but we're still struggling 46 to 50% of time in range with some hypos going up to 5%. Well, she switches from that to the 780G, and this is last year, this is 2022. And we start things getting flatter, and this again going up to 84% time in range. And I think this would be her recent data uploaded on 13th August, 15 days back, where she's touched 91% time in range. So again, a 780G being a life changer for this one. Finally, my last patient here, an elderly gentleman with 35 years of diabetes, 65 years, with being on HAI and glargine, 8.1% huge fluctuations, starts using real-time CGM. You can again see the data, the fluctuations all over the place, 26% in target sugars. At that other point, only 17% with a lot of reds and hypos that you're seeing there. Gets onto the 780G, this individual, and it's a game changer for this person. He's now moved up to 88 to 87% time in range with hardly any hypoglycemia. Continues to do well. That's the trajectory for this gentleman, who I think will be available this evening in the pump session. So let me conclude by saying AID appears to be superior. It is the fundamental right of everyone with type 1 diabetes. It is difficult in India, but we all need to work together to make it a reality. We need people to champion this cause. Partha has been doing it in the UK, but I think we have many champions here, and he continues to support the cause. So hopefully we'll have many more patients getting onto AID in India with or without support. Thank you so much.
Thank you, Manoj, for a very, very motivating talk.
Thank you.
You enlighten us about what is latest available in the field of insulin, automated insulin therapy. So thank you for that. If there are any questions, comments, welcome from the crowd. I think you have driven.
Everybody agrees that it is
nicely.
arguably the best option.
Thank you.
Thank you.
I think there is no doubt that what you talked about, automated insulin delivery devices, The only thing is, I think the cost may be a prohibiting factor in majority of the cases. And I think to cover that, our next speaker is none other than Dr. Partokar, who is going to bring his experience from his NHS UK and tell us type 1 advocacy, what India should be doing. Over to you, Partho.
Okay. I'm your secret agent there. Kohinoor leke aayenge. Ruko na. Okay, so you've heard from the beginning of this session some really wide-ranging talks. You've heard from Dr. Sabu about different types of diabetes. You've heard from Dr. Ghosh about what they're doing in West Bengal, which I think is a fantastic initiative. You heard from Dr. Sarda about what she's doing with her Udan. So some amazing examples. And one of the work that we're trying to do is get everybody together to a certain model of working. You've heard from Manoj about AID and a fantastic question, does it widen the gap? Because some people can afford it, while we're also having a debate in lots of parts of the country. Why are we talking about AID when we can't even give people basal bolus insulin, right? So there is that gap and discussion. But I'm going to change tack completely. And I think for the audience, I'm going to ask a few questions, and then I'd like you to just think differently. So my first question to you all is, who in this audience has got type 1 diabetes? Hands up. 1, 2. Anybody else? Okay. Anybody in the audience who's got a child, family, anybody who's got type 1 diabetes? Okay. Now, the final question, let's say by a magic, not the type of magic you want in your life, but let's say there's a big magic show right now, and your most loved one has now got type 1 diabetes. Okay? Your most loved one. Your son, your daughter, your mother, maybe even your mother-in-law, depends on the relationship you hold, right? What would you like them to have? What would you like them all to have? Is there anybody who would say, if I can afford it, I want them to have CGM? Or would you say, no, I would like them to prick their fingers? Anybody? No. That's how life works. So the fundamental thing, what I want to also think, the principles of what our role as doctors, and we're all here, the best advocates for people living with type 1 diabetes is us. Because the reality is that most places, people with type 1 diabetes are not on stage. They're not invited, they're not in sessions. There's no chance for them to speak up. So the advocacy has to be for us. And I'll tell you why. Next, how do we move? Right. This is what is required to get good HbA1c in type 1 diabetes, right? 8 to 10 glucose measurements a day. So if you don't have CGM, which most people don't, you have to prick your fingers 8 to 10 number times a day. If you haven't done it in your lives, I would ask everybody to just prick your fingers 4 times a day and try and do it for a month. You'll see you'll get bored of it, of pain, anxiety, and the rest of it. Within about a week, you're going to go, ho gaya bas, bahut ho gaya yaar. So that's what you have to do. You have to check your blood glucose that many times. You have to actually give yourself insulin 6 to 8 times a day. You have to make all these adjustments in your life. And the important bit is you got to have luck, skill, motivation, perseverance, support, but you have to have it every single moment of your life. That's why type 1 diabetes outcomes are so difficult. It's not about the technology and everything else. It's just very difficult to do. So what I would say, I don't know if anybody knows what this is. Do you know what this number is? Anybody? Can anybody guess what is this number? This is the amount of time a person with type 1 diabetes has with you as a clinician in their lives. That's it. That's all they have. And that's an overestimate. That's based on you seeing your doctor, a person with type 1 diabetes seeing their doctor 4 times a year. 4 times a year, half an hour per session gives you about 0.02%. The point I always say, 99.99% of the time they're on their own with their insulin doing all those things. So don't be surprised when people's control is very difficult to achieve. None of us will be able to do it. I can absolutely guarantee you, which is why all this technology. To me, I've always said diabetes sits on these 3 pillars. Self-management. Why do you think glucose monitors are so popular? Do you know why they're popular? Because why would you prick your fingers when you don't have to? It's as simple, it's a quality of life thing. So people go like, okay, I can see my readings all the time. So let me give you an example of what glucose monitors. You will hear lots of evidence, lots of science about continuous glucose monitors. I'm going to use the example of Shah Rukh Khan to explain to you what is continuous glucose monitors. Who has not heard of Shah Rukh Khan? Is there anybody who hasn't heard of Shah Rukh Khan in this audience? You all know Shah Rukh Khan, right? That's the only continuous feature in my life since I left India in the 1990s. He was number one then, he's still number one now. That's the only continuous thing I've got in my life. If you have never heard of Shah Rukh Khan in your life, never heard of him, and people show you 4 pictures of Shah Rukh Khan, you're going to go like, nice looking gentleman, looks smart, what does he do? Then you show him a clip of, I don't know, Veer Zara or something, and you go like, wow, he's a good actor, he's nice, very charming, romantic man. That's the simple difference between a finger pricking yourself, because with finger pricking, you just got 4 pictures in a day, 4 random numbers without any idea where they're going, up, down, left, right, center. With a continuous glucose monitor, you can see what's happening. That's what self-management is. Peer support. This is the biggest thing. People with type 1 diabetes talking to each other, and finally access to a trained professional. I use the word trained because not everybody is trained in type 1 diabetes management. The basic principles of type 1 diabetes is the basal bolus insulin. Everybody should be on basal bolus insulin. If we're not doing it, then we not need to have people trained to do it. So these are some of the things that people always talk about when you have challenges. Evidence, regulatory body, clinicians. Clinicians are a challenge as well. And here's the power of language as to what we are saying. And I think when people say, what can our rules be as clinicians? If anybody has got, somebody said they have somebody in the family has got type 1 diabetes. When you see a doctor, what is the one thing that you want when you see a doctor in your lives? What is one thing that frustrates you if you ever see a doctor? If he's not nice. If he or she is very impolite, rude, it always stays in your mind, right? If you're seeing them for 0.01% of their lives, the minimal we can do is be nice. It's the minimal thing to take away. Because if you're nice, this is not about giving people a lecture. And we were talking, this is the same thing with diet and everything in life. Don't give people a lecture as to what they should do when you're not living their lives. You don't have their challenges. How can you tell them what you should do when you're not living their lives? That's the simple principle of being a medic in the world. So here are some reading material, if you haven't seen it, called Language Matters Diabetes. And I always say this important thing. The best science, right, in life is the one you can get into people's lives. Because otherwise, the paper you have published, the research you have done, whatever you've shown is just for your own CV. Bas aur kuch nahi. You have improved your CV, you improved your reputation, you haven't changed anybody's lives. You get your research into people's lives, it's amazing. That's the benefit that you're trying to drive. I'm going to skip this. So I always talk about building a community of doctors. It's very important that you have got like-minded people together saying, like, we want to challenge people, we want to be an advocate, we want to do better for people with type 1 diabetes. And the principle comes back. I always wanted to go home and think about, if I had type 1 diabetes, would I want good care? And if my patients are not getting it, then we should try our best to try and get them that care, right? I use social media, I'm not going to talk about, I think challenging clinician systems, it's our job to also challenge our clinical colleagues. If somebody says to you, no, humse nahi hota hai, we are going to do BD mix. I'm sorry, BD mix is not good care in type 1 diabetes. If you are as a clinician going like, no, we need to talk about it then. We don't do that for type 2 diabetes, do we? We are talking about SGLT2 inhibitors. Nobody's going around saying, no, we're going to only use gliclazide and that's it. So why are we doing the different for type 1 diabetes? No difference. Now we talk about all of this, but I left out obviously the most important person. So we've all talked about type 1 diabetes, but do you know who we have completely forgot? The person who's living with type 1 diabetes. So we haven't heard from them. So I'm going to end my talk by saying that I think we should ask somebody from type 1 diabetes to come around and tell us what life is about and what is that people with type 1 diabetes would like. We as clinicians get together in this conference, we talk to each other, what should be best. So on that note, I'm going to invite Snehal, who's in the audience from Blue Circle, and she's going to give us a little overview as to what patients would like, what people living with type 1 diabetes would like from us clinicians. So thank you very much. Snehal, floor is yours.
Hello everyone, good morning, and thank you for having me here. And we have had some amazing presentations here on covering a lot of topics. I do not have a presentation as such I want to focus on a few things, and I would like the audience to just listen to me and look at the lens of type 1 diabetes, living with type 1 diabetes from a patient perspective. So, hello, I'm Snehal Nandagavli. I'm based in Mumbai. I live with type 1 diabetes, and I was diagnosed in December 2001. That makes it 22 years now. And what Dr. Patha just showed, it's been 22 years. I have been taking injections every day, 6 to 7 times a day, pricking my fingers to check my blood sugars on a glucometer almost 8 to 10 times a day. It's been last 6 years I have moved to a continuous glucose monitoring system. But even with that, sometimes the patient minds cannot completely rely on the CGM numbers, you know. So even when I'm on CGM, I usually check my blood sugars on a glucometer 1 to 2 times every day. So that has been like 22 years of my life. That is more than 80% of my life living with this condition. So it's important that we hear from the patient voices, and thank you for having me here. What India must do is what the topic I was given to talk about. And before I get into anything else, I am on multiple daily injections, MDI as we call it, like I said. And we also had a beautiful presentation around the uses of pumps and automatic insulin delivery systems. But for me as a patient, it's a emotional or like a mental discomfort with the idea of having an electronic device attached to my body 24/7, you know. So even when we say that the pumps are the next thing in having better diabetes management, I think for me, I'm doing very well even with using syringes or pens. My last HbA1c was 6.2, which has always been around anywhere between 6 to 6.5, you know, even with MDIs. So the most important thing, along with doctors' help, wherein they guide you on using insulin and pricking your fingers for the blood tests and using CGMs, the most important thing I feel is the access to correct information and education. You know, if you give someone all these amazing devices and tools, you give them CGM, you give them pump, you give them insulin, but they don't know what to do with it, you know. So there's no use of actually having all this technology available. So the first and the foremost thing I think is India as a country needs to focus more on having correct education, not only to the people who are living with type 1 diabetes, but also their caregivers, because that's important. If it's a young child, he may not have the correct knowledge of doing it on his own, and that's where the parents, usually it's most of the cases it's the mothers who take on that burden of handling the child's condition. So having this access, maybe it's like a doctor certified access for patients as well as their caregivers, I think that would be the first step for us as a country to have like a set of resources which are available for the patients as well as the caregivers. The second thing I want to talk about is training of healthcare professionals as well. Like Dr. Patha said, in most of the diabetologists or endocrinologists that we have, they may not meet a patient living with type 1 diabetes more often. There will be usually cases of type 2 diabetes. So at times it becomes very difficult for the doctors as well to give them proper guidance. So, and also to cater to the misdiagnosis and undiagnosed cases of type 1 diabetes. It hurts my heart when I hear cases of fatalities due to misdiagnosed or undiagnosed type 1 diabetes. We are living in this century wherein we have access to all the latest tools, all the latest technologies, and we cannot be here saying that there was a case where there was undiagnosed type 1 diabetes and we lost the child. So that is something that really hurts my heart, and as a patient as well as a global diabetes health advocate, I would like to focus more on, we as a country should focus on reducing the numbers of misdiagnosed cases or undiagnosed cases, and at least try to, our aim should be to bring them down to zero, but for now it should be to reduce them down. So that was my first point, that focus is more on awareness and education and healthcare professional trainings as well. The second thing that we all, in the presentations before me as well, they talked about was healthcare and insulin affordability. We know that insulin has been discovered. We recently had the celebrations of 100 years of discovery of insulin. But did you all know that insulin is the 6th most expensive liquid in the world? And in India, it is not covered under any insurance. Most of the medical supplies and insulin requirements are out-of-pocket expenses for the patients and their caregivers. That can also lead to a financial burden of this condition. So we would request the government to kind of build in rules and regulations and initiate policies that would have some cap on the increase in the prices of insulin. Also, there needs to be awareness around the generic insulin which is available in Jan Aushadhi Kendras across India. There's not a lot of awareness around that. Personally, I have moved to the Jan Aushadhi Kendra generic insulin Glargine and the regular insulin since 2 years now. And even with that, my, like I said, my HbA1c has been in well controlled. But we also see cases wherein people don't trust the generic insulins a lot. So there needs to be a lot of awareness and a lot of talks around the availability of generic insulin, as well as that it works as well as the branded insulin as well. Because it's almost 50% price reduction when we compare it to the branded insulins. So that can definitely, like, throughout the journey of a person living with type 1 diabetes, the financial aspect of it comes into play, and this can definitely reduce that burden. The second thing that comes in picture when we talk about insulin and the medical supplies is the supply chain management. Because we all know that insulin needs to be kept in a temperature controlled environment. So at times, if it is not, the supply chain management infrastructure is not well developed, what can happen is that it can get spoiled. That reduces the efficacy of the insulin, and obviously it's a wastage of a precious medicine which is available. So there needs to be proper distribution and availability of insulin and medical supplies, especially in the low resource settings, because that's where we see this cases wherein the insulin has become spoiled because it was not stored at a proper temperature. The last thing that I feel that India should do is focus majorly on the legislative and the policy support aspects. So we need to have diabetes, type 1 diabetes as a part of the universal health coverage program. We know that the WHO is focusing a lot on bringing UHC to all low and middle income countries, especially focusing on the Southeast Asia geography. And I know the Indian government is also working on that. But just having universal health coverage is not enough, especially for people who are living with type 1 diabetes. We need to include type 1 diabetes in the universal health coverage, so that it not only includes insulin, but also the related medical supplies, you know, the glucometer, the blood test strips, the syringes, the pens, the pen needles, the CGMs, the pumps, the path labs. There's a lot of expenses that come along when you're living with type 1 diabetes. The second and the last thing would be having some measures to have employment opportunities. Discrimination on the basis of type 1 diabetes. We also see some cases wherein patients are denied a job or denied admissions in schools because they are living with type 1 diabetes. And one of the slides also mentioned that no child should be left behind. I think that is something that I, as a community leader, would like to focus on. Is like, no, we should ensure that in this journey, that no child is left behind, and we ensure that the quality of life for people living with type 1 diabetes is better, and if I have to say, as same as others as well, you know. So that would be it. Thank you.
Thank you, Snehal. So I think the appeal from both of us is that you've heard the views, and I'll give you one statistic to take away. India is a very different country, and quite rightly, we should all be proud of what India is doing, putting a rocket on the moon, everything. But if you've got type 1 diabetes in India, your lifespan is 24 years lower than the rest of the world. That's a statistic to take away, which might have been fine in 1990s, not in 2024. So I would encourage all our clinical colleagues to think about some of the basics we should do. We can talk about AID, we can talk about screening, but I'd like you to think about the basics. Basal bolus insulin, glucose monitoring, being trained on that and making sure we're providing that. And of course, as Snehal said, in today's day and age, to have a story where somebody is dying because they're just not picked up to have type 1, no longer should be an acceptable thing in India. India is no longer a country which can't afford, right? People look at me, they say, oh, you're from the UK, you're from the rich country. And I always point out that isn't India supposed to be economically more stronger than the UK? You are. So I think that's the message which I would like everybody to take away. Be proud of being in India. At the same time, if that's what we are, then we need to make sure that Snehal doesn't have to come back on stage and tell us why is a child dying because they can't be picked up to have type 1 diabetes and have some insulin. So we'll leave it at that. Thank you so much.
Thank you, Partho and Snehal, for a wonderful duologue, I'll say. I think to sum up the whole thing, for patients with type 1 diabetes, besides the regular monitoring, insulin management, and lifestyle modification, I think the three major pillars that we often ignore are mental health support, education and empowerment, and of course support systems where they have a network. And all these three are free, and they can be easily used and make the life of give quality to the life of a patient of type 1 diabetes. Thank you.
Thank you so
If there are
much.
any questions or any discussions, otherwise we'll end this session. No? Group photo. Can I have all the speakers of this session on the stage, please?
So I just wanted to say, Partha sir said about Shah Rukh Khan. He is definitely the Shah Rukh Khan of type 1 diabetes care. And Archana Sarda ma'am being Kajol of type 1 diabetes care. Miss Nehal. Our theme for WCPD is be a warrior against diabetes. You are a true warrior. Okay.
We are honored to have lead this insightful sessions exploring the latest advancements and future directions in insulin therapy. I would like to invite Dr. Makkar and Dr. Pratiksha Patil to chair the session.
Morning, everyone. Once again, I would like to thank Manoj and Puri for this great opportunity and to be here for this very important and very well organized DRS meeting. We have two very eminent speakers for this session of insulin today and tomorrow, and I can see Dr. Unni there. So Unni, you are requested to take over. Dr. Unni Krishnan, I don't think he needs any introduction. And Unni, should I go through the introduction?
Fine, sir.
So he doesn't need introduction and he agrees with that. Thank you.
So, welcome to all of you for this session, and thank you for the kind introduction, sir. My task is to look at how the insulins are evolving and what are the lacunae in adoption of insulins. I may need some help. So the statistics show that India has a rising burden of diabetes, and the world itself, the number is going to increase to 783. And India has a huge number of people with pre-diabetes as well, who are just about to convert to diabetes. And we have about 101 million people with diabetes at present. So among this 100 million or so, only 6 million people with type 2 diabetes are actually being managed with insulin. So that's a very small number. And 46% of patients with uncontrolled type 2 diabetes keep on delaying insulin therapy. And that happens every day in our practice. We see a patient, we give them metformin, we give them SGLT2, it's time for insulin, then we give them DPP4, then we've given them sulfonylureas, and at the end, the beta cell has been so destroyed that you need to go for basal bolus insulin, and even sometimes even that doesn't work because the glucose toxicity has really set in. And the reason for that is that there are barriers both among doctors as well as among patients. One of the important barriers among patients is needle phobia, and the regimens are burdensome, and the very drudgery of having to take daily injections is always a problem with patients. Among doctors, we don't have time to tell the patient, we don't have to address non-compliance. And why there is non-compliance? Because again, the pain of injection is so bothersome. We all agree that the one insulin that has made insulin initiation easiest is basal insulin. And the ADA in 2024 said that basal insulin alone is the most convenient initial insulin therapy. So that's the very good evidence out there and very good endorsement out there. We have first generation basal insulins and we have ultra long basal insulin analogs. The first generation basal insulin like glargine have a half-life of about half a day, and the ultra long acting insulins have a half-life of a day. But both are injected once a day. Of course, glargine U100 can be injected twice a day, but degludec and glargine U300 need to be injected only once a day. Now, the deficiencies among the old glargine U100 is that it's not truly once daily. It lasts less than 24 hours. It requires a fixed time of dosing. There's a lot of nocturnal hypoglycemia. Glycemic variability is a problem. And why is variability a problem? Despite the same insulin therapy, despite the same meal pattern, despite the same stage of the disease, sometimes patients have a fasting of 60, sometimes they have 200. You can't increase the dose because you're worried about hypoglycemia. You can't decrease the dose because then you're worried about hyperglycemia, and that sort of becomes a very limiting factor. For some patients, basal testing is an option, but otherwise that's very, very difficult to address. And of course, there is high variability. That's the reason this happens. And these insulins are said to have a peak, said to be peakless, but they do have a peak. In fact, you can make use of that peak because if you understand where that insulin, the so-called peakless insulin is peaking, you can inject it in such a way that you make sure the postprandial sort of comes along with that. So is it time to upgrade from glargine U100 to degludec? Certainly yes, because the action of degludec is faster and longer, the variability is lesser, the efficacy is better, the time in range is better, and the safety has been proven not just in RCTs, but also in real world studies. And if you look at degludec versus glargine U300, I think degludec represents true innovation, and glargine U300 is also good. It represents an incremental improvisation, but degludec represents an innovation because once again, when you compare it to glargine U300, it's faster, longer, has less variability, is safer, less hypoglycemia, and very importantly, the dose requirement of degludec is less than the dose requirement of glargine U300. So the cost sort of balances out. Now, if you look at the label, you can use many basal insulins. But if you want to choose a basal insulin to be used in pregnancy based on a randomized control trial, that basal insulin will have to be degludec. And if you look at, of course, NPH is always there. But otherwise, if you want to look at an RCT and then choose an ultra-long acting basal, then that basal insulin is likely to be degludec. And of course, Pediatric, it's approved more than 1 year of age. You can use it in adults, you can use it in elderly, you can use it in renal and hepatic impairment. At the Chalaram Diabetes Institute where I work, we routinely use it in patients on dialysis as well with diabetic kidney disease because it is so smooth and there's no hypoglycemia. So it's an ideal basal insulin, but probably it's the best thing that happened to basal insulin after the discovery of basal insulin. But of course, it isn't perfect. It is flat, peakless. It minimizes hypoglycemic events. It's the best basal we have today. It has a long duration of action. It allows flexibility. You can inject it any time between 8 to say 32 hours or so. And you can also see very, very minimal variability. And what is the advantage of that? The advantage is that you are likely to see your patients at a fixed time of the day having a predictably same glucose at every time of the day. So your titration is better. And because hypoglycemia is less and titration is better, we are able to reach targets. Any insulin can lower the blood glucose levels. NPH can, glargine can, but an insulin which is less variable and more predictable allows you to titrate to reach target, allows the patient to titrate to reach target, and therefore you can reach a better A1C because you're not that worried about hypoglycemia. And that's why patients are better. But despite all these breakthroughs, there are many breakthroughs, and Degludec is the best basal insulin, but can we do better? What are the problems with current insulins? And one problem is that patients with diabetes have to keep injecting them every day. Whenever, I think about 16 years ago, I was diagnosed to have tuberculosis. And the picture that you see in my CV, that was when I had lost about 15-20 kilos and I had mediastinal lymph nodes and I had to undergo a biopsy. And I took anti-ATT for about a year. And you won't believe, though I had this big problem and though I had to take these pills, I used to forget to take it, and I needed a family member, my wife, to actually tell me that take it every morning with tea, breakfast, take it. So even a tablet is so difficult to take. An injection, forget about having to take it on time, but the real, the drudgery of having to inject, that itself will make your subconscious mind want to forget the insulin injection. So yes, Sunday, Monday, Tuesday, the whole days of the week, and that leads to delayed insulin initiation, and people are afraid of needles, and rightfully so. And 90% of both doctors and patients wish for an insulin which ideally need not even be injected, but if possible, at least avoid daily injections. And therefore, fortunately, we have Icodec insulin, which is going to come, which is a once weekly insulin. And daily insulin is challenging because 59% of patients report that it is very difficult or somewhat difficult. If you ask your patients, they'll say, हाँ मैं तो insulin ले रहा हूँ या ले रही हूँ. Then you ask them, are you taking it every day? नहीं, महीने में 2-3 दिन तो ऐसे ही miss हो जाता है. So even if it is there, even if Degludec is flexible, there's a chance that they will miss it. And that itself becomes a problem, especially on holidays or weekends when they travel, somebody's marriage, they just miss the insulin. So it's important that to note that adherence to insulin injection is challenging. And to take it at the prescribed time with meals every day is extremely difficult. And therefore, about 65% of patients are non-adherent. Why don't we detect this non-adherence? Because there is a silent pact between us and our patients. We tell the patient, हाँ आपका HbA1c तो 8 है, आप कितने insulin ले रहे हो? Yes, doctor, I am taking about 20. Oh, you are taking 20? Your A1c is 8. Let me increase it. But we know, and the patient knows, that ठीक से तो लिया नहीं है, miss तो हो गया है. But there's no time when you see so many patients who address that, and sometimes we miss out. Patients are also human, we are also human. So that silent pact actually damages the patient's health, and it's important that even if once a week insulin is not here right now or is coming later, whatever it is, even the daily insulin, please ask your patient whether they are actually taking it. And let me tell you, this is true for all chronic diseases. Thyroxine, very common. Patients will not take it. In last 3 months, 4-5 दिन तो ऐसे ही miss हो जाते हैं. Then some people miss it for 10-20 days. So yes, we need to address it. And repeated insulin injections and injection-related trauma causes lipohypertrophy. Patients, sorry to say, patients inject at the lipohypertrophic sites only because of the chronic injection and fibrosis, pain may not be there. Pain is actually less. So some patients inject there only, and you will have to actually educate them, and they are not aware. Many times patients come to us from far off, and our diabetes educator just does an assessment and comes back and tell me, sir, the entire abdomen is riddled with lipohypertrophy because the patient is constantly injecting it on one side. So I think if you are able to reduce the number of injections, and if you give that priority, then this might also be overcome. There are other interventions that may address adoption and adherence. So less frequent injection is one. Easy regimen. Nobody wants to check their glucose every day and adjust basal insulin every day. Of course, degludec is easier. It's every 3 days. But still, you might have to titrate it by checking every day and adjusting it. So therefore, less frequent injections. There's a simple regimen. A simple regimen is like, for example, a co-formulation. Very simple regimen. Having a very simple regimen, a single device, flexibility in dosing. I think all this matters to patients who don't want to be set by very rigid routines. We want our insulin to adjust according to the patient's life. We don't want patients to have to eat 2 times a day to fit in 2 injections of insulin or something like, or wake up at night to eat a snack because of hypoglycemia, etc. So less frequent dosing is one of the most sought after attribute for patients. It will lead to adherence, convenience, and satisfaction, and that might lead to better outcomes. And that is why you have once daily insulins. Of course, we are going to have even better, smarter insulins in the pipeline, but once daily to once weekly is a big step. And that means if once weekly insulin comes, instead of say 365 injections of basal insulin a day, your patient may well be taking only 52 injections a day. Your patient may be theoretically saying, हाँ मैंने तो Thursday insulin ले लिया है, मैं 3 दिन छुट्टी के लिए जाऊंगा, and अगले Thursday वापस आके injection. So that 1 week is overcome. I think that's a big deal. I think that's a big thing for patients, just to be able to reduce the number of injections. So I think nearly 50% of patients are uncontrolled on type 2 diabetes with delay in insulin therapy. So delaying, if you have 100 type 2 diabetes who are uncontrolled, about half are actually delaying insulin therapy. And because of several reasons, our resistance, patients' resistance, keep on adding OHA. So there is metformin, there is sulfonylurea, there is gliptin, there is gliflozin, there is imiglimin, there is acarbose, there may be berbesha, whatever, XYZ added on. And then patients reach a point where the beta cell is flogged and the beta cell is not there, C-peptide is undetectable. And then you start insulin, you will require basal bolus insulin. People with type 1 diabetes know what I'm talking about because they have to take 4 injections. But type 2 diabetes, at least in early stages, they can be managed with a basal insulin, which gives rest to the beta cell, allowing it to be responsive to oral agents. So despite the innovations in insulin, the delay in insulinization, the burden of daily injections and needle phobia exists. And by reducing the number of injections, we can improve not just adherence, we can go ahead and improve HbA1c. We can improve the quality of life. We can improve patient outcomes. And that's what I'm pointing out to you. Friends, it's a pleasure talking to you. And thank you so much for listening to me.
Thank you, sir, for a lovely talk. You explained where we really lack from initiating insulin, what are the problems in maintaining, adhering to the dose. For the next session, I would like to call upon Senior Sir Dr. A.K. Singh from Kolkata, who will be talking about 2 goals in 1 shot, in operative as well as intra.
Thank you. Good morning, everyone. Thank you, organizer Manoj Purvi. Always a pleasure. So continuing on what Dr. Unnikrishnan started, now there is a data that is emerging that suggests that insulin degludec can be used in inpatient departments. So now this ultra long acting basal insulin has a data not only in the OP settings but the IP setting. So this is the financial disclosure. This is a Novo Nordisk sponsored session. So let's look at what an ideal basal insulin should look like. As you can see, it has to be flatter. There should be a minimal variability. It should have at least 24 hours of action. And needless to say that it has to have a flat profile. Now, when you look at the evidence-based data of insulin degludec and how it compared with other existing basal insulin, as you all know, the most popular basal insulin across the world have been the Lantus, which is glargine EU100. But if you look at the real mechanism of action and duration of action of these three insulin, as you all know, glargine EU300 is the concentrated formulation of glargine EU100. It's not new insulin. So by concentrating the volume of glargine EU100, you could prolong the half-life of duration of action of insulin. But at the same time, you lose bioavailability. As you all know, the glargine EU300 requires later higher dose compared to glargine EU100 to achieve the similar HbA1c control. So in terms of duration of action, the degludec is the longest acting basal insulin at the moment. Now, if you compare degludec to the previous basal insulin, now, needless to say that there are several studies. This is a PK/PD study in type 1 diabetes that compared insulin degludec to glargine EU100 in terms of within day glycemic variability, and you can find out that degludec was, significantly showing better, variability compared to glargine EU100. And that has been translated into the clinical outcome as well, and I will show you. Similarly, if you look at the day-to-day glycemic variability between degludec and glargine EU100, you can see clearly that degludec is absolutely flatter insulin, unlike glargine EU100, which was actually thought to be a flatter insulin, but it does have some kind of peak, and you can see in this euglycemic clamp study in type 1 diabetes, there was a clear peaking with the glargine EU100, which is not at all seen with degludec in these type 1 diabetic subject. Now, even if you look at the glargine U300 data, so degludec was compared in type 1 diabetes compared with the glargine U300. And again, you can see the degludec was found to have a better, flatter profile compared to glargine U300. But here is a caveat. This is one study where the degludec was found to have a flatter profile compared to glargine EU300. But in another study, now, this is a Novo Nordisk sponsored study, but in another study done by Sanofi, interestingly, glargine U300 found to have a better, glycemic variability compared to degludec. So there is a little bit, issues with these PK/PD study when the sponsors are different. So I would not hesitate to tell you. However, these are pharmacokinetic data of three different insulin. Did it translate into any clinical benefit? As a clinician, this is what we are looking at. Now, if you look at the head-to-head trials of insulin degludec versus glargine EU100, there is absolutely no doubt that degludec had better outcome in terms of significantly less hypoglycemia, be it overall hypoglycemia, be it nocturnal hypoglycemia, be it a severe hypoglycemia. Needless to say, in these randomized control trials, starting from the begin to switch to and devote, these were two double-blind randomized control trials. Remember, there are no double-blind RCT conducted ever with any insulin. The only exception being the switch 2 and the devote trial. In these double-blind RCT, the degludec was found to have a significant less hypoglycemia across the board, regardless of what kind of hypoglycemia you are talking about, be it nocturnal, be it severe, be it overall. So the data clearly suggests that degludec is superior to glargine EU100, and there is no hesitation, there is no controversy there. Needless to say that you have got a dose time flexibility. As you can see that degludec is the longest acting, and Dr. Unni was talking about that you have got a flexibility until a range of 8 to 10 hours. You don't need to take insulin to go to a birthday party or in a marriage anniversary of your friend. You can go and enjoy your party and come back and take insulin. So you have got the opportunity of 8 to 40 hours of flexibility. For glargine U300, by, concentrating the volume of insulin, you could prolong the half-life, you could have little bit flexibility, but that flexibility was limited to only 3 hours. Of course, glargine U100 had got no flexibility. It has to be taken at the same time every day. That's the only issues with the glargine U100, apart from, some peaking and variability, etc. And therefore, the digludec was found to be superior in terms of lesser hypoglycemia. So when we are talking about insulin, we are never claiming that A is better than B or B is better than C in terms of glucose control. Even NPH is as good as insulin digludec in terms of glucose control. So let's be very clear. When we are talking about these insulin and comparing insulin, we are comparing the hypoglycemia episode, not in terms of glucose control. All insulin reduces blood glucose similarly, full stop. But when it comes to hypoglycemia, of course, digludec has the best data. Now, when you are comparing digludec to glargine U300, there were 2 RCT conducted. One was BRIGHT trial. BRIGHT trial was a Sanofi-sponsored trial that compared digludec to glargine U300, and there was no difference between 2 insulin in terms of glucose control, and in terms of hypoglycemia. But if you actually look at the primary objective, as I said, there was no difference in hypoglycemia between digludec and glargine U300. But, some of the, dissection of the data did suggest that maybe, in the maintenance phase, there was little less hypoglycemia with glargine U300. Similarly, there was another RCT, called CONCLUDE, done by Novo Nordisk, that compared digludec to glargine U300. Again, there was no difference in hypoglycemia between digludec and glargine U300. But again, deep dissection of the CONCLUDE trial did suggest that during the intensive phase, digludec produces less hypoglycemia compared to glargine U300. So for me, it looks to be very little difference between digludec and glargine U300 when it comes to hypoglycemia. However, the real world data suggests something different. So there was a real world studies called CONFIRM. This was one of the largest real world studies comparing digludec to glargine U300. In this real world studies, digludec found to have significantly less hypoglycemia compared to glargine U300. Now, these are the data that will keep on coming. But the only drawback to me, I don't find a huge difference between glargine U300 and digludec when it comes to glucose control or even it comes to hypoglycemia outcome. But what is nagging with the glargine U300, and which is very clear cut, as you all know, in the EDISON program, when the glargine U300 was compared to glargine U100, nearly you need a 20 to 30% extra dose of, to at least 25% in Asian studies, there was increased requirement of doses with glargine U300. And if you look at the current RSSDA guideline, Dr. Makkar is sitting, we wrote there that, the data clearly suggests that for the glargine U300, it requires 20% of extra dose compared to digludec. Of course, even, the dose requirement of glargine U300, as I said, was nearly, 25% higher than insulin glargine U100 in some of the EDISON's program. So this is the one aspect of digludec. Now the new data. The new data is, can you use insulin digludec in inpatient? So that's very interesting. Sometimes as a clinician, we feel that if you are using a very longer acting insulin, can it be useful in an inpatient setting? If it causes hypoglycemia, ladies and gentlemen, very surprising fact that if you have got a longer acting, flatter acting insulin, it causes significantly less hypoglycemia. The classical textbook teaching no longer exists in terms of evidence. When we were, MBBS guy in early 90s, we were taught that if you have got a patient who has a chances of hypoglycemia, never use a basal insulin. But at that time, when we are talking about those basal insulin was NPH, that ultra lenti, remember. But now if somebody asks you in your NEET SS exam that which insulin causes the least hypoglycemia, it is the ultra long acting basal insulin. Which causes highest hypoglycemia? Ultra short acting insulin. The answer has gone 360-degree opposite now. So that's the evidence. Now, in one hand, whether you are thinking that ultra long acting insulin may not be used in inpatient setting because of fear of hypoglycemia, but the case is absolutely opposite. Since it do not causes hypoglycemia in the tune, it was supposed to, and compared to the previous basal insulin or even shorter acting insulin, now we are looking at the evidence of insulin degludec in inpatient department. So this is the basic fact that, and interesting and paradoxical as well. The insulin degludec, being the longest acting insulin, is the fastest acting basal insulin. So if you look at the onset of action, the moment you give insulin, so sometimes people feel that, oh my God, if I start degludec today, it will take 3 times to achieve a therapeutic concentration to steady a state, and then my patient high blood sugar will be controlled. Ladies and gentlemen, if you look at the onset of action of this 3 insulin, you can see the degludec is not only longest, it is the fastest acting insulin to work on. And as I said, now the data is emerging in the inpatients department. These are the 2 studies which has been published. One is from India, you can see from Medanta, Dr. Safi Kuche and their team. They studied and compared insulin degludec to glargine U300 in inpatients undergoing coronary bypass surgery. This is the data from Medanta on your left hand side. On your right hand side is the study that compared degludec to glargine U100. So these are the 2 randomized trials which has compared degludec in inpatient setting. In one trial compared to glargine U100, in another trial from India compared to glargine U300. Let's look at how these medications work. Now there are other trials that looked into how it actually start working in inpatient setting. So as I said, it is the fastest acting, ultra long acting basal insulin, and you can see that in degludec hospital trial, you can see those 2 patients, 2 groups divided into nearly 90 patients in each arm, comparing degludec to glargine U100, and you can see the moment you started, there was reduction in plasma glucose within day 1. So within 24 hours, your patient is achieving the target, blood glucose in inpatient setting. And if you look at these results in terms of comparing degludec to glargine U100 in patient setting in the hospital, here is the evidence, and you can see there was no difference between degludec and glargine U100 in terms of glucose control. But you can see there was, some point of time where the degludec was found to have a better glucose control compared to glargine U100. And again, if you further dissect the data, you could see here that if you look at the target in range, the 2 days you cannot survive without talking about TIR or TAR or TBR. Manoj is laughing. And when you look at the inpatient setting, I feel that despite debate, there is no debate whatsoever that when you are using inpatient, you need to have those CGM data to make a good blood glucose control. And there's no debate about inpatient CGM. Now, if you look at these, in-hospital trials, the degludec seems to have a better glucose control within range, as you can see, between 70 to 140, significantly higher percentage of patients had those targets compared to glargine U100. And further, not only the glucose control, but at the expense of significantly less hypoglycemia in this in-hospital trial. So, ladies and gentlemen, this is emerging data with degludec in inpatient setting. Now, this is another trial called, this is actually observational studies that looked for comparing degludec in terms of glucose control with glargine U100. So the previous was RCT. This is a prospective observational study. You can see here significantly, degludec arm has better glucose control compared to glargine U100. And the OP and IP data cannot be different if you look at the PK/PD of 2 insulin. Also, needless to say that, so this is a crossover observational studies. When you shifted from degludec to glargine and glargine to degludec, you could notice that the significantly less proportion of patients had hypoglycemia with degludec compared to glargine. But in this data, it was not highly statistically significant. There was a nominal benefit in this inpatient study, observational study. There is a 4th studies with insulin degludec that looked for the glycemic variability, and you can see when you look at the CGM data here, you can find out that glycemic variability was significantly less with insulin, Digludic, even in patient's department compared to Glargine. So ladies and gentlemen, as Dr. Unikrishnan was alluding into, the Digludic has now come out from the outpatients to inpatient to now pregnancy. So you can see Dr. Arvind was asking me just now that whether Digludic is approved in pregnancy now. So let it be very clear that DCGA has given approval to Digludic to be used in pregnancy. There are many countries that has given approval to Digludic in pregnancy because of the RCT conducted. It was called the EXPECT trial, conducted in people with type 1 diabetes with pregnancy. 100 patients in each arm randomized to either Detamate or Digludic with 3 sorts of aspart, because it's a type 1 diabetes with pregnancy trial. What can be a better trial than a RCT in type 1 diabetes with pregnancy? And Digludic was found to be non-inferior to Detamate in this head-to-head trial. There was no difference in maternal and fetal outcome in the EXPECT trial, and this is the reason as to why on the basis of EXPECT trial, the Digludic is getting approval across the world in terms of their use in pregnancy. And I'm not going to other details. So to summarize, when we're looking into ideal insulin, the Digludic seems to fit the bill. And needless to say that you look at the PK/PD data, there is no debate to say that Digludic is superior to Glargine EU100. There can be debate to say that whether Digludic is superior to Glargine EU300. That's we will keep on debating. But then for the other previous basal insulin, Digludic is clearly superior. Their PK/PD is completely different from the Glargine. So therefore, in terms of choosing basal insulin, Digludic now fits the bill both for the OP and looking to be absolutely fit even for the inpatients department. Thank you very much for your patience, list.
Thank you, AK, for a wonderful presentation. I think I would request Manoj to please join us on the dais and start with the panel discussion. I would request Dr. A.K. Singh and Dr. Unikrishnan to join us on the dais.
Can we have some mics? 2 mics up here. The mics are there. Thank you, Dr. Unikrishnan and Dr. A.K. Singh, for enlightening us again on the evolution of insulins. And yes, it's a personal triumph to see AK talk about glycemic variability and time in range. It tells us that there is light at the end of the day. AK, well done on the TIR and glycemic variability. So good. So we invite questions. We have 10 minutes to take questions. We invite questions. Do let me know if any of you want to ask questions on this and come up to the mic, and I'll allow you one by one. But in the meanwhile, let me start by asking question to our 2 speakers. So let me ask the first question to AK actually. AK, based on all your experience, and you've been there using all the insulins, we've moved on from using different insulins, different insulin regimens, insulin combinations. Can you share your experience on using human insulins earlier, which we were all doing till some time back and even now at times, and then the new generation basal insulin? You did refer to some aspects in your talk, but what do you really feel is the difference between the earlier insulins and the new generation?
I'm sure many of you sitting in this hall, those who are senior pro, if I have used bovine and porcine, I'm sure many senior colleagues sitting here must have used bovine and porcine. So we have seen those era from, ultra lenti to bovine to NPS to Glargine to, 300 to Digludic. Of course, for the past 100 years, researchers are looking into having a better insulin. When we, as I said during my talk, when we are talking about better insulin, means we are trying to minimize number of pricks. We are, trying to minimize the level of hypoglycemia. At one point of time, we need insulin for almost every event type 2 diabetes. Needless to say that type 1 diabetes can't survive without insulin. But needless to say that every type 2 diabetes will someday need insulin. So therefore, there is one drug that has to be the best in the business is the insulin. And as I said, for past 100 years, 1921, the discovery of insulin to we are in now 2024, more than century has passed. People are looking into improvised insulin. Improvisation in terms of two things. One, if we can minimize insulin. Remember, NPH twice daily, Even glargine U100, even type 1 diabetes, 40% of the patient need 2 injection of glargine U100 to achieve good control. Detemir, remember Detemir was tried to be improved, but again the requirement of Detemir was twice daily, 20% higher dose with Detemir. So we could improvise, but we could not improvise in terms of minimizing the number of pricks, because these were not classical 24-hour acting insulin. We were taught that insulin glargine U100 is a 24-hour acting insulin, but the half-life is 12.5 hours. So exactly it is a 2 injection. Now we have got newer insulin, which is truly more than 24 hours. So as you know, duration of action of degludec is 48 hours nearly. So it's many people has done a study, alternate injection of degludec, and sometimes found it was as good as everyday injection. And many of my friends were asking, what is the need of giving degludec once daily? You can give twice, at least 1.5 days daily. Typical Indian Jogaru style. So yes, Manoj, I agree. Over the 100 years, we did improvise and wait for some time. We are looking for once weekly insulin now. So we are trying to minimize the number of pricks, and we are trying to minimize the hypoglycemia. Hypoglycemia is terrible, not only for the patient, but also for the doctor. You are always right that patient alerted for hypoglycemia. We always teach patients that if you develop these symptoms, you reduce the dose, etc., etc. Now, with this newer insulin, if you could minimize hypoglycemia by 50% in the BEGIN program, in the DEVOTE trial, you look at the hypoglycemia episode, it was significantly less with degludec compared to, glargine U100. So, over 100 years, we could minimize insulin injection, we could improvise hypoglycemia.
Thank you, AK. Dr. Unni, you could add to the same one, but I actually have another question for you. And you mentioned it in your talk, and it was good to see you using Hindi as well, now that you're working in Pune and not in Kerala, about your interaction with the patient. So, well, even though things have improved, do you still think there are reasons for delayed initiation or titration in terms of once daily insulins are available, but what really are the factors that persist for delayed initiation or aspects of delayed intensification? You think it's patient factors, physician factors? So you could give your thoughts on that. And I also want to ask, probably you will come to mention about the once weekly, which you did. How are you so sure that when your patients tell you that in a mahine mein 2-3 baar chhoot jata hai, right? How are you so sure that they will not tell you the same thing about the once weekly? कि 1 महीने में 2 महीने में 2-3 बार छूट जाता है. So your thoughts there?
Well, I think it's very interesting. So I was just looking at how many years I've been in now Pune, and it turns out that I've worked more in Pune than in Kerala, because I was in Kerala from 2003 to 2012, and from then on
Last
I've been
12
here.
years you've been in.
And my Hindi is good because I've been all over the country in my childhood. But thank you for that. And another point about why adherence is such a big problem is because I think it's just, I always wonder, is it the CMEs where we talk about patient resistance and doctor resistance? I think it's just a drudgery of having to take that injection every day. And I think there are some arguments that if patient doesn't take it once a day, how will they remember to take it once a week? But I think it's very easy to take it once a week rather than once a day, because once a day is certainly tougher. If you're asked to take a pill once a day versus once a week, I think once a week is better. Now, why we don't prescribe thyroxine once a week then? The problem with prescribing thyroxine once a week is if you take that high dose once a week, like say 700 microgram once a week, for the first 4 hours after the pill, the levels of thyroxine shoot temporarily above that normal upper threshold. And that has led to the suspicion that that could increase the heart rate, heighten the risk of atrial fibrillation, bone loss, etc. So thyroxine is very different from an insulin, which has to be injected, and therefore patients would take it once a week. And there are many things you do once a week. For example, Sunday is holiday. You might choose to tag it to a Sunday. So I think once a week, the advantage of icodec is that it has a very smooth action. And as you know, it binds to a C20 fatty acid. So it also the albumin binding in the blood is a big deal for this molecule. And that's how the release is smooth and you get a week-long injection working well. I hope that, we've been fortunate to do clinical trials, so I do have some experience with IcoDec as well as with IcoSema. That's a disclaimer. But when we use it in the real world, we'll get to know where we are headed.
Sure. So, yes. The mic.
Hello.
Yeah.
Am I audible?
Yeah, now, sir.
AK, you have beautifully deliberated regarding the different insulin, right from NPH to human insulin to a faster acting insulin and then the degludec, the basal insulin. My question to you, you are actually very clear and tell the full stop that hypoglycemia is the only difference between all the insulins. My question here is, when the insulins were evaluating, there are better pharmacokinetics and pharmacodynamics, whether it is the NPH, then human insulin, and we have seen everything in my lifestyle and in my life. So my question is very clear. Efficacy of insulin is very important. Hypoglycemia is of course important. Weight gain is important as far as insulin is concerned, because these three things are always with when the patient starts taking insulin. So my question to you is, only hypoglycemia is the difference, but better pharmacokinetic and pharmacodynamics of the insulin takes better efficacy of the insulin, definitely, other than the hypoglycemia. So this is my
So
question.
we are running out of time.
Yeah, so,
quick answers.
See, the PKPD is for pharmacologists, not for clinician. Second, PKPD will translate into the clinical outcome, which is hypoglycemia. So if any insulin which has got a better PKPD will have a lesser hypoglycemia compared to the comparator. Simple. It did not translate into any glucose control. There could be. So if you conduct a trial, for example, with NPH versus degludec, and if you only measure fasting glucose, degludec would be superior. But if you measure prandial glucose, the NPH will be better because you are giving twice daily. So at the end of the day, HbA1c will be same. So there is no difference, as I said, in the glucose control. See, NPH was never beaten by glargine U100. I have wrote 4 papers on what was the inside story of insulin. Why glargine U100 was brought? The only benefit was hypoglycemia, nothing else. So even I would say that if you are comparing degludec to NPH, there will be no difference in glucose control. The difference is the hypoglycemia, and that's why I said full stop, because of hypoglycemia benefit.
2 quick questions. Sir, I'll go to the lady there and then come to you. A brief question and a brief answer, please.
I'll be quick. So you talked a lot on the degludec insulin. Is it also prescribed to type 1 diabetic patients? Are you prescribing that?
No.
Type 1. So you're talking about degludec for type 1 patients? Yeah.
Yeah, so when I was talking about approval in pregnancy, that was for type 1 diabetes. So
Other than pregnancy, like...
yeah, of course, you are entitled to use degludec in every patient, type 1 or type 2, doesn't make any difference.
Okay, and what would be the frequency of like one degludec shot? Will be
It's always once daily. Degludec is only allowed for once daily.
Once daily?
Yes.
But then if the duration of the profile of the insulin says 48 hours.
Right, so duration of action is different from the biological action. Right, so duration of action means if you have injected degludec and try to measure degludec in plasma, you will find it until 48 hours. But the glucose lowering ability do not persist beyond, say, 24, 30 hours. That's why it has to be given once daily.
Okay.
Thank you. Dr. Makkad, your question, please.
So I was partly to Arvind's question. See, when all these trials are treat to target trials. So whenever we are comparing insulin, it is treat to target. You are achieving the same A1C with different insulins. The only difference is only how much hypoglycemia it causes. So when we had the glargine, the difference between glargine and NPH was that you were able to achieve 1% lower A1C with the same amount of hypoglycemia. And that is how these trials were designed. So AK's point here, the only target that we are looking at is how much hypoglycemia it is. Because you can achieve 7% or less than 7%.
So it's glycemic equipoise in the trials. Yes,
that is what is there. And second thing is the question that came that, you are seeing the duration of action going to 42 hours. Now, if you go back to the basics of pharmacology, every drug you need to, give at the half-life, then you achieve this, stable concentration. So half-life of degludec is about 24 hours. Half-life of glargine is about 12 hours. So if you are giving glargine at 24 hours once daily, then you see, tailing effect of the glargine. But if you start giving glargine at 12 hours, you will get similar control as you are achieving with degludec given 24 hours. So it is all about the pharmacokinetics and the drug profile and the half-life of drug which matters.
Thank you. Thank you for explaining
One
that.
last question. So you also touched a little bit upon the insulin that is given once a week. So I wanted to specifically understand the impact for women especially, because during menstruation we tend to increase the number of units of basal, So like if I'm like, let's say I've already taken my basal on Monday once a week, and if I start my menses somewhere in the week, then is there study around that, or like,
So,
especially for the women?
why don't you introduce yourself? Are you a type 1?
No, I think Sneha Nangauli is a type 1 diabetes.
She's a type 1 champion. Okay.
In fact, one of our collaborators, we work with them on many
Sure. So I think
projects.
that's a valid question
Yeah,
quickly.
yeah.
So how do you titrate then in such a case?
So I think there's no real answer to that. Once we use it, we will be able to find out better. So once we use it in practice, of course, we have used it in clinical trials, but I'm not, the information is confidential, so I can't disclose it with you right now. But I think when we use it in the real world, we will find out answers to all this.
Very, very valid question, Snail. Thank you for that. Dr. Virmani, right?
Dr. Yuni, you very nicely gave an analogy of why we don't give thyroxine once a week. Now, did not the same thing happen with icodec when there was increased incidence of hypoglycemia in the first 3 days? That is why it was not approved by FDA.
Well, we don't know. I think once we use it in real life and once you see the hypoglycemic data, I think you will be more convinced. Because there are several ways to titrate the dose of icodec. One of the ways is that you measure blood sugar readings on 3 occasions and take one of the lowest readings to titrate the dose. And the titration is also plus or minus 20 units. And that ensures, and that there is a flexibility that in people whom you suspect that they are at risk of hypoglycemia, you need not increase the dose by 10, 20, you can even increase by 10. So that option is there. So once we use it in day-to-day practice, once in a clinical trial, we don't have all this flexibility. Once we are able to intuitively understand our patient's profile and able to adjust the oral drugs, to adjust this 20 versus 10 titration, I think those real-world studies will tell us. And as we speak, more trials are ongoing and we'll have more data.
So just one point I would like to clarify. Icodec approval has nothing to do with hypoglycemia. First of all, we need to realize that icodec was found to have non-inferior hypoglycemia compared to glargine and degludec in type 2 diabetes. It was superior to even degludec and glargine in type 2 diabetes trial. Okay, in different onwards program, in type 2 diabetes, the icodec was superior to glargine and degludec. But in type 1 diabetes, there was more frequency of hypoglycemia with icodec compared to glargine. And therefore, they are studying whether the icodec should be given a, the simple approval in type 1 diabetes also, like other insulin. So let's not confuse. In type 2 diabetes, icodec still has got lesser hypoglycemia or nearly similar hypoglycemia compared to glargine and degludec. It was only issue with type 1 diabetes.
True. So yes, I think FDA is taking its time and looking at more data. The EMA, of course, has approved it. The DCGI has gone through it, and we should hear very soon from them for its availability in India. Clearly, this session tells us about the interest in the newer insulin, which looks like a solution, but may come with its own challenges in the real world, something that we all will have to be looking at and be more vigilant, which we always emphasize on. With that, let me thank both the speakers for their wonderful presentation panel and hand it back to the chairpersons to take this ahead. Right? Thank you.
I think we had a wonderful session, and I think we are, so we'll close the session here. Big round of applause for both the speakers, and thank you, Manoj.
For that, I would like to call upon Dr. Arvind Gupta and Dr. Sanjay Reddy for the same on the stage.
So we have another interesting session lined up. We have a duologue coming up on bridging perspectives in diabetes management with IDEC-S. And we have for this two very eminent speakers, both stalwarts, Arvind Gupta from Jaipur and Sanjay Reddy from Bangalore. Over to you.
Thank you, Dr. Makkar, and thank Chairperson for the kind introduction. I have Dr. Arvind Gupta with me, a senior colleague from Jaipur, and then the stage is set by Dr. Unni and Dr. A.K. Singh on the basal insulin. I know when you look back and say the first statement which Dr. A.K. made, when you type 2 diabetes, at some point in your life you have to start using insulin. It's better to start talking to every patient earlier that you have to start using insulin in your lifetime of a type 2 diabetic. Now, this talk is sponsored by Novo Nordisk. We have conflict of disclosure here. So both of us have been contracted by Novo Nordisk to do this talk. So what I will do is, we all know we're all very fond of using pre-mixed formulation. If you look at how many, or most of the patients, most of the physicians, most of the people in our country have been using pre-mixed formulation. Then came in the, we looked at different types of insulin, but we'll start off with a case, Mrs. Savita, who's 52-year-old female, entrepreneur, sedentary lifestyle, comes for consultation with complaints of tingling in foot, frequent fatigue and lethargy, has challenges adhering to an advised diet. The fasting is 142, A1C of 9.8, creatinines are normal, LDLs still high, 126, 62 kgs, HP of 11.4, postprandials of 168, post-lunch 148, post-dinner is 284, EGFR of 89, triglycerides 110, blood pressure 130/80, medical history, moderately adherent to diet and exercise advice. Dinner is a major meal. You can see that with the postprandial rise after dinner. History of GLP-1 RA use a year back, stopped due to GI adverse effects. On sitagliptin, metformin, and empagliflozin. Father is a diabetic, mother is a diabetic with CKD. Please remember, Dr. Arvind Gupta has worked on CKD and families, so he knows more data on CKD and families. So suppose you have somebody with CKD in the family, be more careful with them because they're likely to develop CKD. Was a fellow with Dr. Prasanna and collaborated trying to work on this study. I'm worried about initiating an injectable therapy, and moreover, I'm worried about the complications of uncontrolled diabetes. I want therapy to well fit my lifestyle that is easy to understand and is convenient to adapt. Now, we were all talking here of different insulins, and we know the benefit is only hypoglycemia. Can we use a convenient insulin regime which can address? So I've asked Dr. Arvind, how do you manage this case scenario? Do we add another OAD, initiate insulin? What is the right time to stop OADs and start an insulin? Over to you, sir.
Thank you, Sanjay, and thank you, Manoj. Am I audible? Hello? 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 Hello?
So shall I give you the mic?
Okay. At the outset, I thank Manoj, Purvi, and beautiful DRS team for inviting us for a beautiful conference, WCPD. And thank you, Makkad and Pratiksha, for the kind introduction. Let me ask, before I go with this type of things, I want to ask anybody if patients are on 3 OAD already. HbA1c is 9.8%. What do you think? What do you think? Anybody? Doctor, can you give, if patient is already on 3 OAD and HbA1c is still 9.8%, duration of diabetes is 12 years. What do you think? Can we add another OAD and wait for a longer period of time to set in already micro and macrovascular complications in the diabetes? Anybody? What do you think? You want to give insulin, and this is the most difficult part I am telling you. The patient, the one immediately when you say you need insulin, you know that there are tears in the mind in the patient. Tears in the, when the attendants are there, everybody is telling this is the last day or something, or they want to think in their back of mind that yahan se chalo, we'll go to another doctor. This is the state of affairs in our society, and there are several myths when you start thinking of even giving insulin to our patients, and when the patient is already, you know that initiating insulin is a difficult thing, and we know the basics of the diabetes, that even more than 50, 60 or 70% beta cells are already lost. And what do you think, giving one another OAD and thinking of decreasing or reducing HbA1c to a target level from 9.8 to 7% or less than 7%? Never. And that is my point here, want to discuss here, that if you see here, that unlike insulin, addition of subsequent OAD doesn't work and doesn't offer any more benefit as far as micro and macrovascular complication is concerned. And if you see here, slides?
Yeah.
Okay. So, if you think here, this is one of the very elegant study, and which says that even pre-treatment and post-treatment here, the use of multiple OADs is actually it is a convenience to you, but it never helps to their patients. But thus, there is substantial benefit when you initiate insulin, and we know why there is a benefit of initiating insulin. We can think of preserving whatever the remaining beta cells in the patients. That is the first important point when you initiate insulin. Of course, there are several other points which we have discussed earlier with Dr. Unni and Dr. AK. So, the most important thing, if you think of that reduction of HbA1c to the target level, you can only think when you want to, when you initiate the insulin right at the right moment. And Dr. Makkad is here and all RSSDI, when we were discussing all these things, that initiation of insulin after 3 OADs, very clearly we say that, and all the international guidelines also say the same thing, that failing to achieve glycemic targets on 3 oral agents, please think of initiating insulin and those type of patients. And the important thing is that initiation is very difficult, and it is said that it should not be given as a threat. That is very important. कि ये punishment है, ये आज आपने control नहीं किया तो आपको insulin लगेगी. That is very, very common point by a primary care physician to the patients, कि आपके next time यदि आपका control नहीं आया तो मैं insulin लगा दूंगा. So that should not be the point. We should actually explain the patients that what are the benefits of insulin in your, not only the quality of life, not only the benefit in terms of reducing HbA1c, but long-term micro and macrovascular complications will be less. So, Sanjay, now I want to ask you here, do you think we have to consider in our own patients, do you think our Indian reality is something different, or Indian patients are something different?
Thank you, sir. And that is a valid question. Now, the idea is we all see our patients, and we're very different from different counterparts, our Caucasian counterparts. From we have a lot of phenotypic difference, and want to enumerate in some of them. We develop diabetes very younger. We are thin, fat individuals. We progress from pre-diabetes to diabetes faster. We have high levels of abdominal fat, and beta cell dysfunction occurs quite early in us. And there's increased insulin resistance even at low levels of body mass index. And I know all of you in the audience have seen enough data to tell you these facts are true. We have this typical Asian Indian phenotype. And also you should understand, we eat very differently. Whether it is north, east, west, south, our consumption of carbohydrate is very high compared to any other counterparts other counterparts across. We get 70% of our energy from carbohydrates. And other thing which we need to see, if this was a study which was done, and they found that 83% of the patients this is the starch study, had PPG more than 160. We have a problem. We not only have fasting hyperglycemia, we also have to concentrate on our postprandial hyperglycemia if we want to think of using an ideal insulin which can address both these issues. Another factor is, if you look at the glucose profile, and you have a basal profile, and then you have the bolus. Whenever we eat, what happens to our blood glucose? Please look at it. More than 12 hours a day, we are in a postprandial state, meaning to say we're eating something or the other. The basal part, even if you take care of the basal component, we have these peaks. And these peaks are not only influenced by what you eat, and there are other factors which are responsible for this. I'm not going to enumerate the 41, just looking at some data, look like the 41 factors which can influence blood glucoses throughout a 24-hour lifetime. A lifetime of an individual. So you see that we have high, both of this, peak preprandial glycemia, additional people with diabetes have basal hyperglycemia and postprandial hyperglycemia. So what we need to think of is and look at the difference in glycemic response in Asians and non-Asian people with type 2 if you initiate only basal insulin. The rule, whenever you're teaching students, you say fix the fasting first, and then you can concentrate on the postprandial. I think that's a little out of context to typically an Asian Indian phenotype, where we're looking at data with a huge carbohydrate intake, irregular meal patterns, probably having one of the meals which is very huge compared to all the three meals, and the response to basal insulin is lesser in Asians compared to other populations. So, and also, one of the studies on the ground realities, I know that impact study, which was done by Shashank Joshi and et al., 9 of 10 people in this room, how many of them want both FPG and PPG controlled at the same time? You have incidences where you only have the fasting glucose, which is high for some time, but at some point of time, you want to reach targets just by controlling fasting hyperglycemia. You need something which also addresses postprandial hyperglycemia. And many of you sitting in the room say, can I have an insulin which can control both of it and have greater flexibility? So this is what we are heading. So the indices for holistic choice of insulin therapy is choose an insulin which has lower hypoglycemia. We were talking about this for a long period of time. Has mealtime flexibility. Can I just take it before meal? I need not time it half an hour before meal. Yeah, we have insulins which work on. We can time it half an hour before meal and still would do wonders. Convenience of the device, better quality of life, cost effective, and efficacious. So if you look at all these choices, one of the options we have today is a co-formulation called IDEC-ASP. It has digludec. As you listen to both the speakers enumerate on all the factors of digludec and its how better it is than the compared to whatever basal insulin is available. So I want to ask Dr. Arvind Gupta, do you think IDEC-ASP is unique, and why is it unique?
You are absolutely correct. And before I give the beauty of the co-formulation of injection, if you go back to the history, that when NPH insulin was there, it was very difficult to mix with the short-acting insulin. and then the glargine came. First basal analogs came. It was very difficult to combine with the short-acting insulin because of the pH difference, and it was really different. And that's why scientists have done the fantastic job. This is known as designer insulin. A newer insulin, which is known as co-formulation, where if you see here, the IDEC, the D-glutic is in hexamer, dihexamer form, and insulin aspart in the hexamer form, and they remain in the same vial or same cartridge and have the different actions altogether. So there is no interaction between these two. The IDEC works its own, aspart works its own, and these two components do not interact with each other. And that's why the scientists have done the greatest job. And for the first time, a co-formulation came in the world with the name of IDEC-ASP. And what are the patient profile where we can use? As Dr. Sanjay has already told you, that we want to control both fasting and postprandial, because our diet is such that it is a postprandial hyperglycemia always. We are in the habit of eating right from morning breakfast to lunch to evening snacks and heavy dinner too. All carbohydrate rich food. So the first profile where we can use the IDEC-ASP, the co-formulation, the patients who are uncontrolled on OAD, please do think of starting with the IDEC-ASP. And of course, the safety profile, as earlier already you have seen the D-glutic and both analog short-acting aspart. The safety profile is the best profile. And of course, the flexibility, which is very important in our things. We have to go sometimes marriages, sometimes birthdays, and several things on the week days. So sometimes we miss that. Flexibility is definitely there. Of course, if a patient is uncontrolled on basal insulin, again, this is one of the important aspects where we can think of starting IDEC-ASP. Hypoglycemia already been highlighted earlier, that it is one of the important factor in initiating insulin as well as in adherence and compliance. Of course, unacceptable weight gain, again, very important thing, and I also asked earlier to AK regarding this, and of course, flexibility is again there. And then in the different population, like in elderly and frail people, we can think of this is the safest insulin you can start, the IDEC-ASP in those people, and also the comorbidities, or if the patient is already having hepatic impairment, the renal impairment, again, you can think of starting IDEC-ASP. And of course, if patient is a fasting condition and want to reduce the hypoglycemia, and of course, the patient, very commonly we come across the traveling people and some of the business people who are traveling very frequently, they have the erratic meal plans. You can think of safely given the IDEC-ASP. And of course, the other, hello, yeah. So, and also the patient already on the premix insulin, not controlled, not comfortable, you can think of who are fasting, still fasting is not controlled, patient is having recurrent hypoglycemia, or again the flexibility is there. In that case also you can think of, and patient already on multiple doses MDI, basal bolus insulin, where you still think of severe variability. I have seen the type 1 diabetes population and other type 2 diabetes, where has several fluctuations in spite of having basal bolus. You can think of IDEC-ASP, and of course recurrent hypoglycemia, and of course flexibility is the best part where you can think of using. Now Sanjay, just tell us the difference between iGlar Glargine U100 and iGlar U300, and why this co-formulation is better than these two.
Okay,
we are
sir,
using 300 and 100 for years together.
Now we're using 100 and 300 basically for as a basal insulin. But the basic difference is it's difficult to compare only basal insulin with something called a basal plus insulin, where you have a faster acting component already built in. But I will show you some data. The data is IDEC-AS versus glargine 100 and IU glargine 300. The efficacy, if you look back and look at this study, this is IDEC caused greater reduction in A1C, FPG, and PPG because you have a digludec, which is a basal insulin, and you have also controlling postprandial hypoglycemia. Definitely, it is going, even if you're using it once a day, it will have better effect because you're controlling one aspect of postprandial. If you're using it before breakfast, that means if breakfast is the major meal, if you're using it there, you're also taking care of postprandial glucose rise. So the data would be definitely different. I don't have studies to say, can we use a pre-mix formulation, which is there earlier, with insulin IDEC as a co-formulation and see which is better. But what the data we have is data comparing with IU 300 and 100 IU of glargine. Definitely IDEC as the co-formulation scores over it. Then if you look at IDEC as versus U300 and 300, safety and insulin dose, we already heard Dr. AK giving you all the differences between digludec, glargine 100 and 300. The significant in insulin requirement, the dose requirement is significantly decreased if you use IDEC-AS versus versus insulin glargine 100 IU. No significant increase with glargine Q300 and IDEC-AS. The insulin dose is not much different. Difference in hypoglycemia, there's no significant difference in hypoglycemia, even though you're using a prandial component here. Remember that. So you're using a co-formulation versus using a formulation which is only taking care of fasting hypoglycemia. That means though you're using some co-formulation, the hypoglycemic effect is not very huge. So
Sanjay, can I just ask a quick question?
Yes, sir.
We are continuously comparing IDEC-AS with either glargine 300.
Actually, I asked this question when I was told, do we have something, I made this comment earlier when I spoke, do we have something like a premix formulation to compare IDEC-AS? I don't think there's a study. I think that real world studies on this, like if you're using the old regular insulin and NPH versus, I would like to see a study, but I don't think, I think we would request probably data.
I know, data is very limited, but the interesting thing here is that, when you are using premix analogs, you don't have a sufficiently long duration for the basal component. So the variability still stays. Second thing is with this, actually you can give eccentric dosing. You don't need to give it only morning, evening. You can give morning,
afternoon, you can give it anytime.
Because the degludec will give you a stable profile as far as the basal is concerned, and you can correct only the prandial correction wherever the meal is going to.
Yeah, I absolutely take your point. We're going to come back.
Dosing is very important.
Very important. Rather, you can give it morning, afternoon, rather than giving it a fixed dose. You're using the old insulin morning and evening only, or if you're giving it 3 times, even there. But we can't use 3 times IDEC-AS, but 2 times, and the smaller acting and shorter acting in between also works. Thanks for that insight, sir. And switching to IDEC-AS from glargine U300 or 300. This is quality of life questionnaire, but quality of life questionnaires, and how many of you done clinical trials will know it's based on many things. So I will ask Dr. Arvind Gupta to enumerate what happens when you use these insulins. Do we really improve patients who are on IDEC-AS their quality of life? Over to you, sir.
Absolutely, Sanjay. Whenever you are moving from the earlier premix insulin or other insulins to the IDEC-AS here, and there are a beautiful study here again from the Mumbai, and this study clearly alluded to us that quality of life is again very, very important. And if you think here, this is improved quality of life with the reduced pricks. Whenever the pricks are reduced, definitely you feel better. Your quality life, your day-to-day working is definitely better. It is found is comfortable to inject in a different social situations because few pricks are there, And this is very improved thing. You feel better from inside. And of course, 86% people found it very, very comfortable in any social situations. And of course, they could manage, 94% people could manage their day-to-day activities better after initiating. So this is one of the beautiful study done in Mumbai only, and clearly said that. So another point is the pill burden is reduced. Multiple pills you are taking, and you are taking one injections or two injections in a day, definitely, again, the clear study says that reduction in pill burden definitely improves the quality of life here. And again, 70% people on 3 multiple oral anti-diabetic drugs are shifted to 1 or 2 by just giving 1 injections of IDAC-ASP, and 50% people on 2 oral anti-diabetic drugs are shifted to only 1 oral anti-diabetic drug. So pill burden is reduced, quality of life is much better with the patients. And here the cost effective. Again, I presented one study in Epicon, Kathmandu. First time when NPH insulin and the conventional insulin to human insulin, and I was criticized like anything, that you are thinking of human insulin is better than the conventional insulin. At that time, I'm talking of 25 years back, 30 years back. And again, the same question here. And dear friends, this is still true that if you see the cost accrued in the by the other insulins to IDAC-ASP, clearly if you say the total cost here, like here 79,000 per year to only 76,000 per year by different,
Again,
whether it is
again I am interrupting here with Arvind. You know, whenever the question of cost comes, there is a saying for managing diabetes, that cost of diabetes treatment does not lie in the treatment cost, it lies in the complications.
Yes, absolutely.
So whenever you are looking at the cost, always keep in mind that if any therapy gives you a better control of diabetes, it is cost effective.
Absolutely, Dr. Bridge. It is not the simple question of cost of insulin, but it is the cost of preventing so many outpatient visits, reducing emergency room visits, reducing in-hospitalization. So all these costs actually ultimately makes it is better option of giving the IDAC-ASP in the patients. And if you, again, the yearly, if you see the cost of this is much better when you use the IDAC-ASP.
Yes.
So now I think now we want to discuss the practical aspects.
What are the practical aspects? Now, we have different situations. Where do we use IDAC-ASP? Do you use it for the first time when you're starting insulin? Do we use it in patients who are already on basal insulin, not achieving targets? Do we use it on already people using pre-mix insulin, the older pre-mix insulins? Or how about people using basal bolus? Can we reduce their injection costs or the number of injections which they take? So over to you, sir, and tell them how do you want to initiate IDAC-ASP in patients with a drug name, and then probably with all the other situations which happen in normal clinical practice.
I think everybody will agree in the audience here. The flexibility is very important in your day-to-day life. You are working in the day-to-day life. You are professional. You are going for business. You are going for traveling. So flexibility is very, very important. And in spite of the flexibility and sometimes irregular injections, still if your HbA1c is controlled, I think nothing better than that. And here the IDAC-ASP scores from other insulins to the newer insulin. And here, this is one of the very elegant study which says that here the flexibility is dosing. You can have in the morning, you can have in the lunch, you can have with the dinner. And in spite of that, you can start with the safely of any uncontrolled diabetes with 10 units of insulin. You can easily titrate the dose of IDAC-ASP, and also you can intensify the dose of IDAC-ASP. So not only the titration, but intensification can also be done, and adherence is much, much better when you see all these regimes, whether once a day or whether twice a day.
IDAC can be given depending on the individual blood sugar levels and the controls. So now if how to change or how to change from earlier insulins to the IDAC, and very simple formula, nothing rocket science is there. A patient is on basal insulin once a day or twice a day, 1 to 1. The similar dosage you can convert from other insulins to the IDAC. And again, if patient is on premix insulin, similar dose you can convert. Premix twice a day, again the similar dose, and premix thrice a day, you can convert to twice a day IDAC with a similar dose. So dose will remain. But my take on here is, though the dose can be similar, but the better insulin is there. So initially, always I want to reduce the dose of the newer insulin and gradually see the blood sugar levels. And if blood sugar levels are still high, then you can gradually titrate. So initially you can reduce the dose which patient is earlier taking. So that is my take here. And again, the similar thing is that the patient is on basal bolus or some doses, you can just think of individualization, reduce the dose initially and then titrate. So switching is very, very easy from other insulins to the IDAC. So my take-home message here, Sanjay, the similar thing which you have already told, the earlier speakers have already told, the best whenever you want to initiate, titrate, intensify, and adherence. Hypoglycemia is one of the important things. IDAC has a lower hypoglycemic profile. Flexibility is definitely one of the very important aspects. It is a very simple regime. Convenience to the patients, better quality of life, having the less breaks, and of course it is cost effective, we have already seen, and overall combined with the efficacy of the insulin, which is not compromised when you are starting IDAC.
Okay. Now we started with this case, and all of you were of the opinion she's on 3 drugs. A1C is 9.8. We looked at her blood glucose profile. We found that postprandial at dinner time was high. And looking at all the data, and also fastings also were not on target. And all the guidelines which told us that we need to start insulin, and all of you agreed that we need to think of insulin which would control both fasting and postprandial hyperglycemia. So all the data presented on IDAC-ASP, she was started on IDAC-ASP and then titrated and to achieve, and after 3 months, A1C is 7.2. The take-home lessons are here, and which I want to tell you once again. If there is a need to start insulin, please don't postpone. And whatever type of insulin you want to start, based on the patient profile, please consider this. Now, starting insulin is one thing. Many patients on insulin are still not controlled on A1C. So please look back. One of the things I was talking to Dr. Arvind Gupta is, now I ask patients to get their medicine box with them. You will be surprised at the compliance issues which we have. They're telling, Dr. Uni telling, I missed 2 to 3 days, it's more than that. So education in every visit, doesn't matter with which type of insulin they're taking. Please ask about hypoglycemia and make sure you use drugs and insulins which are safer, cause less hypoglycemia. Third, please monitor to target. Majority of the time what is lacking is compliance with insulin, initiating insulin, and also monitoring to achieve targets. These are the 3 take-home messages. You can use any insulin which is right for the patient at that particular time, whatever insulin, and availability locally if they are available. Other thing is storage and education regarding insulin. I think the messages are here for us to take. So I end my road with this take-home message. When there is a need to start, even after 100 years of insulin being there with us, I think we're far, far behind in achieving glycemic goals. Starting insulin, titrating to targets, and starting safer and effective insulins. Thank you very much.
Thank you, Dr. Sanjay and Dr. Arvind, sir, for practical aspects of the IDAC-ASP. We have time, so we can have few quick questions.
I think the best thing what Sanjay told, and मेरे पास में भी एक पेशेंट ऐसा है, सन लेके आया, अपने फादर का डब्बा लेके आया, एंड ये कहता है कि साहब 1 महीने की मैं दवाई लाता हूँ और ये तो 2 महीने में भी खत्म नहीं होती है. So what the Sanjay told that I always ask for my new patients, the dabba leke aao, brings a dawai ka, and he wants to see
So
my
there is
health.
again one very famous quote. The drugs that you don't take never have any effect.
Yes. Please make sure that they
And
take
what
the
we
drug.
do in a diabetes setting, it is a chronic patient. So most of the time actually we want to increase. जब भी उसका blood sugar ज़्यादा है, HbA1c ज़्यादा है, हम लोग उसकी दवाई बढ़ा रहे हैं. But we never think it compliance is not there. Patient is not taking drugs. Patient is not taking insulin.
So for the drugs to be effective, you have to take them.
Take them.
Absolutely.
So the bottom line is that.
Yes.
Dr. Sharma wants to make a comment.
Yeah.
Wonderful presentation by both the speakers. Only thing which I want to know, in interest of all the audience, that what is the ideal time to give this insulin, and number two is that how to titrate the dose.
Yeah. Dose titration was shown in one of the slides. You have to start with the same basal if you are converting from an insulin. Otherwise, you start up titration always with the basal. And I think before you came, we had a quick question on eccentric dosing of this. You can dose it. This is, of course, to be dosed pre-meal because it has a rapid acting component. But you can start with the largest meal, before the largest meal, provided there is a component of postprandial hyperglycemia. If you have a very small postprandial rise, maybe you can start only with the basal. Then you don't need a combination of IDEC.
So then we can give it in 2 times also, twice.
2 times,
Yes, sir.
yes, 2 times.
Majority
and
of the
eccentric
patients end up
dosing
with 2
also.
times.
And we can start with as Dr. Makkar has said, the largest, ask the patient which is your largest meal, which is the most carbohydrate rich meal, start.
Sir, I have many
IDEC as per
patients
that.
who take, every day the largest meal varies. One day it's breakfast, one day it's dinner. So I tell them, which is your largest meal of the day on that day? They miss breakfast. If you tell them you just take before breakfast, say, which is your largest meal of the day? If you're taking it, your largest meal of this day, this is what you need to do. This is how we start.
Then in that case, we cannot keep on changing the time every day.
No,
No,
you cannot.
no.
You cannot once in a while. They are for
Once in a
erratic
while.
patients. Not everybody.
Sir, as you rightly mentioned that it is a twice a day, but can we use this IDEC as 3 times a day? And if yes, in what conditions?
See, we don't have data on that. Largely, IDEC as studies have been done with 2 times a day. 3 times, you have to keep in mind, degludec half-life is 42 hours. So there is no pile-up effect if you are using twice daily also, but we don't have data with 3 times.
Sir, PKPD
If you need third correction, the third correction can
Shorter
be done
acting,
only with
shorter
a
acting.
rapid. Only rapid.
Sir, one more question, sir. So most of the people in city and they have a heavy dinner. So as you mentioned, we can start IDEC at post dinner.
Yeah.
But does it control the post lunch also once a day?
No, sir.
So again, you have to understand the concept of IDEC aspase that you are giving a basal, and with that you have a component of rapid acting which is correcting the postprandial correction. So if you are using one dose is taking care of fasting and correction for 1 meal. If you need a second correction, suppose you have given a dose of IDEC as before dinner, your fasting is controlled now and your post dinner is also controlled, and you need to correct the post breakfast, then you need only rapid. Then you don't need to give another dose of IDEC because your fasting is already on target, unless you split this dose into 2 and you are able to control both the prandial loads.
Sir, I take Dr. Makkar's answer for your question is very apt. But please remember, ask your patient to monitor. The monitoring of pre and post will give you a fair idea as to where you need to intervene and which meal would be better.
One more comment, if patient is affordable, definitely I'll try the CGMS into that patient and see what are the different fluctuations. If patient can afford, otherwise
Without
Dr.
monitoring,
Makkar
without
is very
monitoring,
clear.
you can never.
No, you
adjust the
cannot do
dose of-
this.
Sir, last question. Sir, most of the time this 12 hours gap is not maintained. morning, evening of
So,
will it make any difference?
Talked about the eccentric dosing also.
Eccentric, so it doesn't matter, just before the meal. 12 hours doesn't matter. If he's having 14 hours, it's fine. But just before this meal, time it before his meal.
So we have seen in most of our practice, there is a subset of patients where there is a premix 50 by 50 which is used specifically for patients who are on very high carb diets. So will it be practical if this IDEC aspart, if it comes in a 50 by 50 combination?
I think they will come back, don't worry. You need to ask that question to Novo Nordisk people sitting there. I don't know, but I see nod the head. It's a difficult, if you do a 50-50, they need to do clinical trials for this. I'm not sure. I don't manufacture it, but I think.
One more thing you have to keep in mind, one size does not fit all. So you have to customize therapy. I think with that, we are already on time for closure of this session. Let's have a big round of applause for both the speakers for doing wonderful job, and also a round of applause for the audience for being so interactive.
Thank you very much.
And over
Thank
to
you,
the organizers.
Manoj and Purvi and the chairpersons for giving us this opportunity to be here, and Novo Nordisk for sponsoring this symposium. Thank you very much.
Thank you so much for everyone for attending. Our morning session has now ended and the lunch has been served. So you can continue with that.
Hey, hey. Hey, 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 hey. फुल गेन आहे नाही नाही येऊ का इथून आतून आव नाही ना नाही भैया check hey 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 up check hey 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 check hey 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 hello hello check check hey 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 hello hello check hey 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 check check hey hey hello hello mic testing check one hey hey hello check hey hey
check one. Hey, hey. Hey, hello, check, check, check. Hey, hey. check 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 one. Hey hey hey. ऑन अरे ऑन आहे बा. मग तेच तो बोलतो. कसला डिस्प्लेचा ना गेन ना याचा पुढे गेला हा सिलेक्ट सिलेक्ट हो सिलेक्ट गेन आहे ना याचा -9 ला आहे. वाढला तरी येत नाही ना. चेक 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 -32 चेक वन. इथून ओके आहे ना. म्हणजे आउटपुट मध्ये काय राउटिंग आहे का. केबल खराब असते तर इथे सिग्नल नसता आला ना. चेक चेक बाकी तर सर्व मॉनिटर बिनिटर मी पॅच केलंय. हे बघ इथे मीटर पण येतो बघ ना. चेक 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 चेक. मग राउटिंग नाही ना. हो दुसरा म्हणजे याच्यानंतर थांब. मी आता ज्याच्यावर मी हँड चालवतो ना. हँड चालवतो त्याच्यावर ना. त्याच्यामध्ये घेतो थांब. 6 नंबर. हा 6 नंबरचा आउटपुट चेक आउटपुट म्हणजे हा चॅनल मला वाटतं त्यात पॅच नाही. 10 नंबर. हा आता कसं करता ते. काय बोलतो. नाही होणार. बरोबर बोल. त्याला लावतो मोने TFT आता. TFT लावतो.
वक्रतुण्डमहाकाय सूर्यकोटिः समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्डमहाकाय सूर्यकोटिसमप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
Check. Hey. Hello. Hello, mic testing. Check one. Hey, hey.
Hello. Hello everyone. So now we'll be commencing our afternoon session. To chair this session, I would like to call on the stage Dr. Ayaz Ansari. He's with us. And the other two chairs will also be joining us soon, Dr. Manish Agarwal and Dr. Abhay Sahu. To you, Dr. Ansari.
Should we start? Yeah, should we wait? Good afternoon. First of all, welcome to all the delegates and faculty. And thanks to the Manoj Chawla giving the platform, and just there's a very good and bonding sessions of the diabetes in young. First, I'm going to invite our first speaker, Dr. J.K. Sharma sir. He is a medical director, Center Delhi Diabetic Center, New Delhi. He is a founder secretary of the Journal Innovative Physician Forum. He is a IPF Global Ambassador. He is a scientific advisor of the IPF Medicon 2024. He is a treasurer of the RSDA National 2022 to 23. He is going to, without the wasting the time, and he is going to talk of the how to approach to diagnose, how to make of the diagnosis of the diabetes in young of the Dr. J.K. Sharma sir, please.
Thank you, Dr. Manish and Dr. Ayaz. And
Please close.
I extend my thanks to Dr. Purvi Chawla and Dr. Manoj Chawla and all the organizing committee for this afternoon session, inviting me to deliver this talk. And my topic is diabetes in the young, how to approach to the diagnosis. We all know that the physicians and pediatricians are facing fresh challenges due to the new epidemics affecting the children's physical and the mental health. Earlier, the infectious diseases like the viral infection, the mumps, chickenpox, pneumonia, diarrhea, nutritional deficiencies, they dominated the childhood diseases. But today, these are being replaced by the non-communicable diseases like the overweight, obesity, and diabetes. So diabetes in young people is a challenge for both the patient as well as the physicians. And when we talk of the various kinds of diabetes, you can see the heterogeneity of diabetes. And the two most common forms of diabetes in the young are type 1 diabetes and type 2 diabetes, each having an almost similar prevalence of 40 to 45% and up to 10% being contributed by the MODY, that is the maturity onset diabetes of the young, and other genetic forms of the diabetes. Where are many others? You can see the list over here. Type 1 diabetes, which is the most common form of diabetes in children and adolescents in the majority of countries, but other forms of diabetes also occur. And where here, when we say that the young means up to the age of 35 years. We are not saying that they are the children or the adolescents up to the age of 35 years. We consider them as the young. Top 10 countries for estimated number of prevalent or existing cases of type 1 diabetes in children and adolescents. Dr. Saub, please come on the dice. 0 to 19 years per annum, and we can see that in India, number of children and adolescents with type 1 diabetes, 229.4 thousand, which is a very good number. And the various mechanisms associated with type 1 diabetes pathophysiology and related complications, you can see that there are pro-inflammatory cytokines, AGs and RAGs, bone cell activity modulators, and they all lead to the various complications like the cardiovascular disease, nephro, retino, neuropathy, and the bone diseases. Welcome, Dr. Rakesh. Please come. So type 1 diabetes is associated with unique physiological challenges in the young children with constant management demands, elevating parental diabetes-related stress and fear of hypoglycemia. And the diabetes technology use has significantly increased in young children, contributing to improvement in glycemic levels and parent and child psychosocial functions. There are certain factors which increase the risk of health in child and adolescent patients with type 1 diabetes, like the dysfunctional avoidant coping strategies by the parents, irrational fear of hypoglycemia, neglect of the child, or excessive demand placed on the child, too early independence, conflict in the family, low socioeconomic status, membership in a minority group, specific cultural features, the incomplete family, separation of the parents, maternal illnesses, especially the depression. So these are the very important factors. And these are the various recommendations from ADA 2024 standard of care, but I'll not look into these. When we come to the autoantibodies, the anti-islet autoantibodies in the diagnosis type 1 diabetes, because we all know that it is an autoimmune disease. In 1974, the IC islet cell antibodies were detected. In 82, the 64 KD antibodies. Then in 1990, the GAD antibodies. And then 1991, the carboxypeptidase H antibodies. Then 1994, the IA2 autoantibodies. And likewise in 2007, the zinc T8 autoantibodies. And if you look on the other side, positivity is only 11.9%, and amongst the positive, their GAD plus IA plus 2A plus zinc only 1.13%. GAD only 3.2%. So the various autoantibodies are involved into this. And the important drivers for the epidemic of youth onset type 2 diabetes, they are the increasing frequency, severity, and earlier onset of childhood obesity. Increasing frequency of intrauterine exposure to diabetes, sedentary lifestyle, other psychosocial factors. And we can see that in today's time, the youngsters, the physical activity has gone down, the dietary habits have changed, they are more stick to the screen and don't go for the outdoor games. So the prevalence of young onset type 2 diabetes, now coming to type 2 diabetes according to the IDF 2021, if you look at our country, India, 0 to 0.9 per 1 lakh population is the incidence rate of young onset type 2 diabetes. And these are the long-term complications of young onset type 2 diabetes: hypertension, diabetic kidney disease, dyslipidemia, nerve disease, any microvascular disease. So the prevalence of diabetic kidney disease, diabetic retinopathy, peripheral neuropathy, hypertension, and arterial stiffness were all higher in young adults with type 2 diabetes than in those of similar age and diabetes duration with type 1 diabetes after adjustment of the socio-demographic factors. Now, these are the various potential mechanisms responsible for the aggressive clinical phenotype in youth onset type 2 diabetes. The first is insulin resistance. Then the beta cell dysfunction. There are pollutants. Genetics plays an important role. Treatment access or intensity and adherence, lifestyle factors, structural racism, and in utero exposure to diabetes is another mechanism for that. Youth onset type 2 diabetes is characterized by pathophysiological heterogeneity and inadequate glycemic control, highlighting the need for new treatment approaches and innovative study designs in population of varied genetic and cultural backgrounds. And we can see that incidence of youth onset type 2 diabetes increasing by 5% per year. And the prevalence of overweight or obesity in adolescents is 10 to 19 years, increasing by 8 to 40%. And so the incidence of youth onset type 2 diabetes increases 1 to 3 per 1 lakh per year. And these are the various complications. Very important amongst them is the mental health. And complications in those with youth onset type 1 diabetes and those with type 2 diabetes, you can say both macro, micro, macro, and the early mortality is there. So how to screen? The ADA 2024 recommends that risk-based screening for pre-diabetes and or type 2 diabetes should be considered after the onset of puberty or at 10 years of the age. And if the screening is normal, repeat the screening at a minimum of 3 years interval or more frequently if BMI is increasing. Fasting plasma glucose, 2 hours plasma glucose duration during a 75 gram oral glucose tolerance test, and A1C can be used to test for pre-diabetes or diabetes in children and adolescents. And we can see that more number of pre-diabetic population is there as compared to the diabetes in our country. So children and adolescents with overweight or obesity in whom the diagnosis of type 2 diabetes is being considered should have a panel of pancreatic autoantibodies tested to exclude the possibility of autoimmune type 1 diabetes. So we have to differentiate whether this child is type 1 or it is type 2 diabetes. Another very important is the MODY. MODY is the maturity onset diabetes of the young, and most MODY causative agents subject GCK encode transcription factors expressed in pancreatic beta cells. And MODY is a monogenic diabetes when there is a genetic mutation. Various subtypes, at least 14 MODY subtypes are available. And the subtype determination is important as the subtype differ in terms of the age of onset, clinical course and progression, and type of hyperglycemia and response to treatment. Now these are the various MODY subtypes. Prevalence of MODY types. It is a monogenic autosomal dominant form of diabetes with onset before the age of 25. Absence of beta cell autoimmunity and impaired beta cell function. You can see that 51% have HNF1A MODY type, 32% is GCK MODY type. So these are all the 14 types of, and you can see that the various MODY genes involved in the various subtypes, all 14, they are all different. And the GCK involved gene in 15 to 20% and HNF1 alpha 30 to 50%. There is a glucose sensing defect in the GCK subtype and beta cell dysfunction in the HNF1 alpha, and the other features are in GCK subtype there is stable mild fasting glucose, but in the other one it is the glycosuria. So we have to find out, and we can see that these genetic testing for MODY is being done in our country also, and Dr. V. Mohan Center is doing excellent work for that. If anybody is suspecting any patient of theirs as the MODY patient, you can send for investigation at Dr. V. Mohan's place, and Dr. V. Mohan is doing it free for these people. How to diagnose? The misdiagnosis of MODY with type 1 or type 2 diabetes can be avoided if clinicians can establish a correct molecular diagnosis and with advances in genetic testing added by the development of new techniques. Diagnosis before the age of 30 years is a useful discriminator between MODY and type 2 diabetes, whereas a parental history of diabetes produces a 23-fold increased chance that a patient previously diagnosed with type 1 diabetes may be diagnosed with MODY at a later stage. Who should be genetically tested for MODY? Patients with a strong family history of diabetes presenting in the 2nd to 5th decade of life. Leanness, lean patient, autoantibodies when tested they are negative, and the features inconsistent with type 1 or type 2 like low renal threshold, large increase in the blood sugar in OGTT and lower than expected CRP levels, lower than expected HDL cholesterol, high insulin sensitivity, children diagnosed with diabetes, one who are antibody negative and exhibit elevated C-peptide levels. So when we test these four, or when we suspect, then that person be subjected to the genetic testing for this. And this is the algorithm for etiological diagnosis of diabetes. When you clinically suspect type 1 diabetes, get the islet autoantibodies done. If they are present, it is type 1 diabetes. If they are absent, high type 1 diabetes genetic score and or low insulin secretion at a distance. If it is so, then again it is type 1. If it is not, and there is diabetic ketoacidosis at the onset, then it is the KPD, or if it is not, then it is the monogenic diabetes. When we clinically suspect type 2 diabetes with the usual features, then it is type 2 diabetes. If not, go for the islet antibodies. If they are present, then it is type 1 diabetes or LADA. LADA is the latent onset autoimmune disease of the adults. Then if islet autoantibodies are negative, then it is again the monogenic diabetes. So if there is clinical suspicion of monogenic diabetes, neonatal MODY or syndropic, go for genetic testing. If it is positive, then it is monogenic diabetes, and if it is negative, then it is undetermined. Coming to the neonatal diabetes, refers to diabetes diagnosed in the first 6 months of life and has an estimated incidence of around 1 in 2 lakh live births, and these are the various tests for this also. Come to LADA, it is characterized by genetic, phenotypic and humoral heterogeneity encompassing different degree of insulin resistance and autoimmunity, and patients with LADA are leaner and have healthier lipid and blood pressure profiles. Moderate type 1 diabetes genetic susceptibility, look for the specific trigger, the islet autoantibodies, GAD autoantibody positive, beta cell apoptosis, and if there is insulin deficiency, then it is LADA, and there is high degree of heterogeneity. If type 2 diabetes genetic susceptibility is there, obese, low-grade inflammation, go for islet autoantibodies. IA2 autoantibodies positive, accelerated loss of the beta cell function, impaired insulin secretion, and again it is the LADA. And this is the new diagnosis of diabetes. Age less than 50 years, BMI less than 25 years, clinical risk assessment, acute symptoms of hyperglycemia at onset, history of autoimmune disease, familiarity of autoimmune diseases, and accordingly measure the GADA, measure C-peptide. If the GAD antibodies are negative, it is type 2 diabetes. If they are positive, then it is LADA. So measure C-peptide to define the therapy. When we measure C-peptide, if it is normal value, consider type 2 diabetes, and if it is low value, then measure the GAD antibodies. If they are negative, then it is type 2 diabetes. If they are positive, then again it is LADA. The offsprings being exposed to maternal GDM throughout its lifetime, then maternal GDM, in utero programming, early life programming, or the reprogramming adolescent consequences in the form of metabolic syndrome, type 2 diabetes, cardiovascular disease, and the obesity, and transgenerational programming, again type 2 diabetes, cardiovascular disease, and the obesity. Now the Indian problem needs Indian solution. So any diagnostic criteria and procedure should be simple, doable, economical, and evidence-based, and single test procedure, also known as the DIPSI procedure, that is recommended by the Diabetes in Pregnancy Study Group India, Ministry of Health, Government of India, and affordable test. National Institute of Clinical Excellence guidelines recommend 2 hours post-glucose more than 140 milligram per deciliter as the diagnostic criteria for GDM based on the study performed in multi-ethnic population in UK. So the single test, DIPSI, diagnosis 2 hour post-glucose more than 140 with 75 gram oral glucose in 300 ml of water, fasting or non-fasting state irrespective of the last meal. Normal glucose tolerant women maintain glucose despite glucose challenge and due to brisk and adequate insulin response. And women with GDM, they have impaired insulin secretion, glycemic level increases with the meal, and glycemic excursion exaggerates further with the glucose challenge. Now these are the glycemic targets in women with pre-existing type 2 diabetes before and during pregnancy, which we can see here. So to conclude, diabetes in the young presents unique challenges demanding early and accurate diagnosis for the effective management. With increasing prevalence, comprehensive approach that includes timely screening, personalized treatment, and ongoing support is essential. Emphasizing education and resilience can empower young individuals to navigate their condition with confidence, and collaborative care and innovation will continue to improve outcome with quality of life for this valuable population. Young people with diabetes teach us that determination and hope can shine brightly even in the face of a chronic condition. And now I invite you all on behalf of myself, Dr. Makkada, the organizing chair, Dr. Rakesh Sai, President RSSDI, Dr. Sanjay Agrawal, Secretary, and Dr. Vijay Vishwanathan to this 52nd Annual Conference of Research Society for the Study of Diabetes, 14 to 17 November, Yashobhumi Dwarka. If you are not registered, please get yourself registered and enjoy this academic feast. With that, I thank you everyone. Thank you, sir.
Thank you, sir, for enlightening this very important approach for diabetes in the young patients. And shall we go ahead and we can conduct several camps, or especially in the school-going children and the college-going children?
Pardon?
Is there any program that we can detect diabetes in the young patient, especially doing camps in the college-going students and school-going students?
You know,
What's
we
your
have to select, we have to look for that where the testing should be done, which I have already narrated in one of my slides. So the suspicion, eye of suspicion should always be there with the physician and should look that. And then the family history is of course there.
We can have 1 or 2 questions from the delegates, please. Yes, sir.
In one of the slides you mentioned low HDL-C cholesterol as one of the risk factors for MODY. So what exactly is the association between HDL cholesterol and MODY?
It is a finding that has been considered, and it has been found that in the patient the HDL cholesterol is low.
Thank you.
Any more questions? Thank you very much.
Thank
sir.
you very much.
Thank you, sir. Now moving further, I would like to call Dr. Sanjay Agarwal, sir, who is going to talk about the therapeutic approach in the diabetes in the young patients. Sir is a director at Eagle Clinic Diabetes Care, Head Department of Medicine and Diabetes at Ruby Hall Clinic, Head Department of Diabetes, Obesity and Metabolic Diseases, Yadri Hospital, Fellow of the American College of Endocrinology, Fellow of American College of Physicians, Honorable Secretary, Governing Council of National RSSDI, Member Editorial Board, BMJ, Open Diabetes Research and Care General, and is also member of writing committees for RSSDI guidance or many more. Also editor-in-chief for many more, and list goes on, sir. Sir, over to you.
Thank you very much. At the outset, I would like to thank Manoj, Purvi, the entire team of DRC, as well as the team of World Congress on Prevention of Diseases, Diabetes, for giving me this opportunity to speak today over here. Manoj asked me to speak on what would be therapeutic approach to diabetes in the young. And part of this lecture, I think very well was covered by Dr. J.K. Sharma, who outlined the different types that you would tend to get, the forms of diabetes that you would get in the young. Up till now, our concentration has always been that what do we really relate diabetes in the young to? It's always been type 1 diabetes. It's only of late that we have been recognizing other forms of diabetes which can present in the young. And the most important of which, a disease that we consider to be of the older generation, is now surfacing more and more in the younger population, and that's type 2 diabetes. LADA and other forms, MODI, we've had them, but they are not in that much of a prevalence that we see over here. But the growing prevalence is more and more of type 2 diabetes in the young, and I'm going to talk about it a little more during the course of my talk. So this is a trend that has actually been changing. So while we keep relating to type 1 diabetes in the young, we shouldn't forget that type 2 diabetes can present early, or vice versa. We may see type 1 presenting late, and we may often see patients who come to us with diabetes later in life, and we find out that their autoantibodies are positive, and they may have a type 1 diabetes presenting later. So this is something that we should always be concerned. What is driving this epidemic of type 2 in the younger? And it's always the overweight and obesity that we are seeing today. Obesity has become almost like epidemiological proportions. And given the lifestyle our children tend to see, where they're, away from all kinds of physical activity, they're more sedentary, more couch-driven, you find that a prevalence of obesity is more and more rising. And that's the reason why we see more of type 2 diabetes. Along with that, there are certain challenges that we see in patients with diabetes. They have a lower level of awareness. So patients who present in the young, they're not aware that they can get diabetes. So often diagnosis is delayed. Type 1s present very early because they're very symptomatic, and they come to us early because they lose significant weight, they're symptomatic, they have a lot of osmotic complaints, and there's no question that they will come to you. But all the other forms of diabetes in the young, they present pretty late. And that's not that they get the diabetes late, but we do recognize it much later. They also have a lot of psychosocial impacts. I mean, imagine a family which has a young diabetic. The child as well as the family goes through a huge amount of trauma, and they're trying to cope because they know that this diabetes is going to stay with the child all the life, and he's going to cope with diabetes. At some point of time, he's going to require insulin, maybe from the onset itself or a later point of time, but he's going to be committed to insulin therapy permanently. Often these patients, because of their lifestyle, their commitments to education, their social life, or for that matter, do tend to have uncontrolled diabetes. And they do tend to miss their doses or perhaps stop their doses. Or for economical reasons, we have seen often that patients cannot afford treatment and they end up with complications pretty early. So we've got to be very careful about the fact that how we spend time counseling these patients, because it's exceedingly important that you talk to them that this is a form of disease that is permanent. You have to take treatment, and you have to have solutions how you're going to manage these patients. As I just mentioned, that obesity in the Indian kids is on the rise, and this was basically a Times capsule that had come out, that between 5 and 19, you find that there is an increasing incidence of obesity in the Indian population. This was documented by the WHO. And almost between 1990 to 214, the number of overweight children in the low and middle income countries has doubled from 7.5 million to 15 million almost. And from 2014, almost half, 48% of all overweight and obese children under 5 years lived in Asia and 1/4 in Africa. So it's not that in our population we don't see childhood obesity. Walk around the road and you'll see them, and you go to the schools and you'll see them. And if you see the curriculum, there's very little activity-driven curriculum that you have in the schools. It's more of an academic-driven activity that they've got. And we need to change this and make the school authorities as well as parents aware of the fact that they need to make the children more active. This was a registry that was conducted by the ICMR, and this is in India. So if you see clearly, the larger proportion of the patients in the young are type 1. But next comes that almost 25% of the patients who present in the young are type 2 diabetics. And then comes all the other form of diabetes in the young, which Dr. Sharma alluded to during the course of his talk. This was also sort of validated by Dr. Mohan and his group. And he said that if you look at the year-wise distribution of presentation of type 2 diabetes, we are seeing a higher incidence of type 2 diabetes over the years. And the data stopped short at 2006, but I'm sure the incidence or the prevalence of the occurrence of type 2 in the young hasn't stopped, and it's growing more and more in terms of numbers. This was a study that we did, and we published this. And this was sort of driven by Dr. Rakesh Parekh and Dr. Amit Gupta. We conducted a campaign, what we call as a Defeat Diabetes campaign. And we sort of said, how many people have tested their blood glucose? And we said, can we make people sensitized to the fact that they need to test their blood glucose? And we sort of drove a campaign to say, test your blood glucose. And can we said, let's touch about 100 million people in 100 days. We were sort of touched almost 128 million people in the country in 100 days to sensitize them that they should test their blood glucose. And on a single day, we got 1 million people to test the blood glucose, and we collected the data on this population. So of all the clean data that we could collect, what our findings were that below 25 years of age, we have, below 25 years of age, almost 10% of the people were not aware that they have diabetes. If you look at below 30 years, almost about 13% of the population were not aware that they have diabetes. And if you look at less than 35 years of age, almost close to 18% of the population were not aware that they have diabetes. So that's a huge burden of diabetes who are unaware that they have diabetes, and they've not even consulted somebody or tested the blood glucose. It's on just a random glucose testing, they found out that they have diabetes. So when we boil down to the fact that these are the different forms of diabetes that you see in the young, and I'm not going to go into the details because Dr. Sharma has already alluded, but what we look at is early type 2, type 1, or type 1 presenting even later, pancreatic diabetes, endocrinopathies, flatbush diabetes, LADA, MODI, and various other forms. Right? And here's the overlap that you see in all these diabetes that we talk about in the young, and you see more or less all of them are present between the age group of about 15 to 30, where you see all these coming, but peaks are of course of type 1, type 2, and MODI that you see over here. So when you approach a patient with young diabetes, what are the parameters that will help you to ascertain the type of diabetes? So you establish the family history, presence of obesity or signs of insulin resistance, C-peptide levels, imaging of the pancreas, whether it's ultrasound or a CT scan, look for presence of ketoacidosis, autoantibodies, and then genetic testing wherever it is possible. There are certain sort of factors that are associated with high prevalence of diabetes in the young, but some of them are modifiable, some of them are non-modifiable. So if you see the modifiable, overweight, decrease in physical activity, sedentary life, higher fat, high energy diets, whereas you find that there is a lot of other factors which govern, and one of them is of course low lean mass, which Dr. Rakesh Sai is going to talk about during the course of his talk, about how the presence of sarcopenia can make a huge amount of difference in patients with diabetes. And then of course diabetes during pregnancy, IGTs, urban stress, you've got a number of host of factors that are related to it. Now, when do we start screening for diabetes? That's the most important part, because as I said, that a lot of people are unaware that they have diabetes. So there has to be certain parameters which help us to guide that we should screen for diabetes. And that was asked by the gentleman sitting there, that how do we recognize that who should be screened, and can we do mass programs? But it has to be cost effective if you do mass programs. So the IDA recommends in its 2024 standard of care statement that screening should be considered in youth who have overweight that's more than equal to 85th percentile, or obesity of more than or equal to 95th percentile, and who has one or more additional risk factors based on the strength of the association with diabetes. Now, this could be maternal history of diabetes or a GDM, family history of diabetes in first or second generation, race or ethnicity, or if you can demonstrate markers of insulin resistance in an individual. So if you have any of these, and then of course, if you have other non-communicable diseases present early, then one of the other things that you'd always like to screen is presence of diabetes in the young. This algorithm has been alluded by Dr. Sharma, so I'm not going to get into it, but it sort of gives you a very clarity about how do you, if you follow the flow diagram, then it kind of gives you an idea how can you arrive at a diagnosis of different forms of diabetes. And, I'll be happy to share this with you if you're really interested. But I'm going to get into the crux of my talk as to what are the therapeutic approaches. So one is, of course, you need to have health management skills, where you need to spend time with an individual or patient about education, give him the idea about glucose monitoring. We need to spend time on medical nutrition, physical activity, emotional assessment, and the emotional assessment is something that we least do it because we feel that it's taken for granted that the parents will do it or the teacher or the friends will tend to do it. But the onus of responsibility should be with us and guide him through emotional hand holding, because that child is going through a huge trauma of detecting something which is going to be a lifetime disorder for himself. Stress management, support needs, and then of course family, peers, medical support that you can give. And we do know that patients who develop diabetes will at some point of time develop other non-communicable diseases like lipid disorders, hypertension, and various complications related to diabetes. And we should obviously spend time to screen these people when they come to us at different phases of their life. As I said, education is important and is the key to success of getting a patient to good control. The education should not rest only with the child, but with the family, with the other caregivers, the school, everybody, because at some point of time, this child is going to go in different environments and they should understand the sensitivity of the illness which a child is bearing with. You need to obviously talk about the illness with the child because he's the focus of all the problem. So regarding his insulin techniques, injection dosing, storage, planning his diets, cheat days, good days, bad days, glucose testing, how to recognize hypoglycemia, and obviously do periodic HbA1c and complication screening. So these are some of the things that you need to educate the child about so that he has a problem-free life ahead. Some of the other management goals can be the weight conversation, because very often when children come to you about being obese or overweight, the sensitivity doesn't lie with the child, the sensitivity lies with the mother. And he says, my child is not fat. Don't call my child fat. And they're very weight conscious about that fact. But they don't recognize that fat is not fit. So you need to be sensitive that you go about this topic in a very sensitive manner to educate the mother and the child that fat is not fit, and that's the crux of the whole problem. And you need to identify how you can get this, better control. And I'm going to talk about it a little later. Increase in exercise capacity, normalization of glycemia, and control of all the comorbidities that you can see in the individual, whether it's hypertension, dyslipidemia, nephropathy, or hepatic steatosis. These are the glycemic goals in the young by age, toddlers and preschoolers, for school age, for the adolescent and young adults. So I've given you before meals, bedtime, overnight, and HbA1c values that an individual needs to, a child needs to control. And these would be considered as optimum glycemic goals that a child should have. This has also been validated in 2024. The UK consensus came out of management of type 2 diabetes in the children and young people, which was published just last month. And what they said is HbA1c should be measured every 3 months in children and young adults, young children with type 2 diabetes. HbA1 target should be individualized. Intensified treatment if A1C is not below 6.5% at 3 months, and individualized A1C targets after the first 3 months, but aim to keep it below 6.5%. Again, they talked about self-monitoring of blood glucose. So ideally it should be done 4 to 6 times a day, at least all pre-meal and bedtime sugars daily, early morning, twice in a month, post-meal sugars if there's a discrepancy with A1C. Maintain a logbook for pattern recognitions, and limitations of course cost, because obviously you need to consume a strip, and if cost is a factor, then you need to stagger the testings out. And this, we had published a guideline on monitoring of blood glucose. I would urge you to read the RSSA guidelines on glucose monitoring, where we have said that if cost is a problem in a resource like that, then how can we optimize the blood glucose testing? Remember, for CGM, there is no evidence available to routinely recommend the use of CGMS or flash glucose monitoring in children and young adults with type 2 diabetes. Unless the patient is on a pump or device, then you would probably use CGMs more often. Or unless you're wanting to titrate the insulin dose, or the patient is getting asymptomatic hypos and you want to sort of regulate the insulin dosing. What about diet? And I've got just last 1.5 minutes left. So you need to sort of see that you're doing an energy distribution where you've got 50 to 55% of carbohydrate, 20 to 30% of fat, saturated fat less than 10%, and 10 to 20% of proteins. Avoid simple sugars and excess fat, and use low glycemic foods. And carb counting is something that all children should be taught, particularly if they are on insulin therapies, and food exchanges, because they do tend to want to eat something. So unless you teach them food exchanges, they're going to get all the sugars, all over the place, and adequate fiber intake. So this is the calorie circulation calculation that you tend to do for age groups, for boys and girls, as to how much they can consume calories. And this has been mapped out very beautifully as to how much calories a child should consume. Again, you remember that if a child has overweight or obesity, then you need to aim for a weight loss. And this is how they have mapped out in the same consensus that I talked to you about, that you can give a healthy low-fat diet, where you limit fats to 30%, 40 to 50% of carbs. And this is a standard diet we would give. Now, you could give a low-carb diet, where you're giving, this is more like a keto diet that you're giving, where you give 45% of energy that comes from fat. Or the other one, you can use very low-calorie diets, typically with meal replacements, where you give a guided amount of calories and you give not more than about 800 kilocalories a day. This is for an 8 to 12 week period, and then get them back to the gradual reintroduction of their healthy balanced diets. Weight loss, aim for about 5% of weight loss in 3 to 6 months and 10% weight loss in the first year. And we should see that we can get their BMI to below 85th centile. What about exercise? And can I just take 1 minute more, if you have permission? So we should advocate aerobic exercise to about 30 to 60 minutes a day. And this in the form of, you can do aerobic, as well as you ask them to do a lot of strength training exercises, but aerobic exercises are good for the children. Encourage sports, because that's something that is important. And whenever there is an anticipated exercise, you should reduce the insulin dose prior to the sport or the exercise by about 50 to 80%. And where there's an unanticipated exercise, then they should consume about 1 to 1.5 grams per kilogram of carbohydrate before the exercise. I'm not going to get into this algorithm, but it's there as to how do you treat these patients with OHs or insulin. And this is the insulin dose that you can give as a starting point. Remember that hypoglycemias are very important, and very often children don't perceive hypoglycemias, and that becomes a worrisome thing for us. You need to concentrate on managing their hypertension, their lipids, and a lot of these children, despite the fact that they're young, obese, will tend to have steatohepatitis, and we need to be mindful of the fact that if they have steatohepatitis, then we are asking them to do fat restrictions and encouraging exercise activity. Growth spurts need to be sort of factored in, and you need to sort of adjust the insulin requirements accordingly. And you need to screen the patients for the complications routinely, and this is the map that I've given you as to how often you need to screen children for their complications. We need to encourage support groups because that helps them, that they have commonality and they find a lot of encouragement to get to better goals by talking to each other, finding problem solving, and they can sort of help each other to get to better control. So this is the way the forward is going to be in terms of technology. We've got big technology right now in terms of pumps, CGMS, closed loops, inhaled insulins, transplants, stem cell therapy. All these options are available, and maybe the future may be bright for our children who have type 2 diabetes. So in summary, the proportion of young diabetics in clinical practice is on the rise. Diagnosis can often be very challenging, but not less than the management. And more physician awareness, newer technologies, support group initiatives, and personalized treatment is the road for future. Thank you very much for your patience.
Thank you, sir. It's a very lucid topic. And any questions from the audience? One or two questions you can take.
Thank you.
Thank you,
Thank
sir.
you very much. Thank you, sir.
Yeah, our next topic is sarcopenia in young adults. So for this topic, I would request Dr. Rakesh Shah, sir, to come to dais. He's professor and in the Department of Endocrinology, Osmania Medical College and Hospital in Hyderabad. He's president of RSSD from 2022 to 2024. Immediate past president, Endocrine Society of India, president, South Asian CEPIS group, section editor in tropical endocrinology, endotext, online textbook of endocrinology. He's an editorial board member of IGM, and he has lot of awards in his name. He has publications, over 180 publications in various national and international journals, and authorized many chapters in different textbooks, monograms on particular diabetes and endocrinology.
Thank
Over
you.
to Rakesh, sir.
Thank you for the very kind words of introduction. I would like to thank Dr. Manoj, Dr. Purvi, Dr. Bansi for inviting me to be here and asking me to speak on sarcopenia in young adults. So it's a little different topic from what we have discussed. We have discussed about the approach to young diabetes, and then we have looked at the therapeutic options right from the available ones to the futuristic ones. Dr. Sanjay has covered all that. So I'll be speaking about a little different topic on sarcopenia. Sarcopenia, even in the elderly, has not been adequately studied. This is something which is being understood to be an important aspect to be, which could be contributing to the complications. It could in fact be considered as one of the complications of diabetes also. And so I'll try to bring in the concept of sarcopenia, the definition, the prevalence, the pathophysiology, the clinical relevance in terms of how it influences the other complications and how it should itself be considered as one of the complications of diabetes, and the role of diet, exercise, and how to choose the medicines in terms of avoiding sarcopenia. And then coming to young adults, it is I know, as we all understand, sarcopenia is a disorder of older people, and coming to young adults, it is another important area that has not been adequately studied. So I'll try to bring in that concept and speak about some of the data that is available about this aspect. So if you look at we know about the growing burden of diabetes, the fact that diabetes is occurring more in older people. I mean, more and more people are living longer with diabetes, and therefore they end up with problems beyond microvascular and macrovascular disease, having loss of functional disabilities, coexisting illness, several geriatric problems. Amongst these, sarcopenia is an important aspect that needs to be discussed. So as you see, sarcopenia is something which we have discussed. When you're speaking about older people, we speak about sarcopenia, and as the life expectancy is increasing, we are saying that more and more people are living on to have problems because of sarcopenia. So this was defined, if you look back, it was defined in 1988 by Irving Rosenberg, who described this as an age-related decrease in skeletal mass, muscle, and function. So 10 years later, it was also a more rational, scientific way of measuring sarcopenia was evolved, and that was by looking at the appendicular lean mass, which was adjusted for the height, and that was used as a indicator for sarcopenia, or a measurement for sarcopenia. And what we realize is that right from the age of 40, we have been looking at the age of 40 as adults, and then we are looking at older people going beyond that 40, and we're saying that, you know, after the age of 40, there's a steady decline in the muscle mass to the tune of about 8% per year. And after the age of 70, it becomes even more steeper decline, 15 to 20%, 25% loss of muscle strength, muscle mass after the age of 70. So it is traditionally, you know, we are speaking of sarcopenia as a disorder of the older people. And along with the muscle mass, we are speaking about the muscle strength also starts decreasing, and it keeps decreasing, you know, as we look at older individuals. And this is also a cause for the frailty, and it is what is seen is that because of the frailty, there's more risk of falls and all the problems associated with falls, and also along with the fact that it comes with, you know, at older age it comes with cognitive impairment, functional decline, depression, and all these add on to the problem. So typically, if you look at sarcopenia, what is sarcopenia? If you look at a healthy muscle on the left side, in a typical individual, a healthy individual at the age of 25, compare it to a older individual, you find that the muscle loss that you're seeing is what is sarcopenia. So you can clearly make out the decline in muscle mass and increase in the fat mass that is happening with aging. So so to typically look at the, you know, how we categorize it, or what are the criteria for diagnosis of, for definition and diagnosis, we say that you know, the European consensus statement was arrived at in 2019, and they said low muscle strength alone may just be probable sarcopenia, but when it's associated with low muscle mass, then it becomes sarcopenia, certainly becomes sarcopenia. And when it is associated with low performance, physical performance, then it becomes severe sarcopenia. So you have three components in that. One is the not only the muscle mass that we're looking at the muscle strength, then we're looking at the physical performance also of these individuals. So there are different you know, categories, criteria laid down, but I will not go into details of those. I mean, you can look at these in any of the references. I could share this with you. And if you look at, I would like to draw your attention to this Asian working group diagnosis was put up the last time. You can see they looked at a hand grip strength of less than 26 kg per 26 kg for men and 18 kg per woman. That's the muscle strength. Where you measure the muscle mass by looking at again, you look at the appendicular lean mass, as I typically measured by looking at doing a DEXA. But you can also do it by other ways like you have got the bioimpedance for also measuring the muscle and the fat mass. So that's another way of doing it. But the gold standard is probably the DEXA. And then you have got the gait speed. Gait speed is used to assess the muscle function. So these are the three components that need to be looked at. And as you can see, the three components are given there. In different populations, you have got different criteria, but suffice to look at the Asian working group definition for sarcopenia, that in the last row, that gives us a fair idea about what we should be doing. So those are what the cutoffs used, and this was used in the Chandigarh urban population study. They looked at that. They and these are the ways you look at the muscle function. Look at gait speed. Look at 6-meter walk test to decide how long. To decide on the gait speed, and then you have the hand dynamometer for measuring the gait, the muscle strength. So these are, and then short physical performance battery can be used to assess sarcopenia, and muscle mass measured by looking at the mid-arm and mid-thigh circumference. So these are all the cut point. I've just spoken about this, so I'll not go into details of that. But what I would like to highlight is that you have got simple screening tools like SARC have screening tool for understanding if somebody has got sarcopenia. You can look at the ways in which you can do, just look at the muscle strength, look at the need for assistance in walking, the rising from a chair or from a bed, and the climbing stairs, whether they have difficulty. You can look at these questions and understand whether a person has got sarcopenia. So quickly taking you through some of these things, because we don't have too much time today. So this is looking at our own data. We found that we had a prevalence of sarcopenia to the tune of about 20% amongst our healthy diabetics who were otherwise young, not the older ones, but this was in the range of 30 to 50. In that, we found that there was a 20% prevalence of sarcopenia, so which is quite significant. And so what are the causes for sarcopenia? You've got endocrine factors, you've got decreased protein synthesis, you've got muscle atrophy, decreasing physical activity, the insulin resistance itself, mitochondrial dysfunction, autophagy, malnutrition, and DNA damage which is happening. All these contribute to sarcopenia. So if you look at the sarcopenia young, we have got two categories. I mean, we are looking at, when you're looking at, as you know, we've just heard that, you know, diabetes in young is a very heterogeneous condition. So when you, on one end of the spectrum, you have type 1 diabetes. Type 1 diabetes, sarcopenia is very common because of the fact that there is decreased insulin, decreased protein synthesis, increased protein breakdown because of the insulin deficiency. That is one end of the spectrum. On the other end of the spectrum, you have got type 2 diabetes who are obese. And these individuals have a different reason for having sarcopenia. They have the inflammation that is present, the insulin resistance that is triggering off inflammation and contributing to sarcopenia. So the way insulin resistance can trigger the development of sarcopenia is shown in this figure, where there is triggering of the inflammatory pathways. There is increase in the advanced glycation end products, release of and testosterone deficiency adding to it, and also certain new molecules that have been identified like myostatin, which are increased in individuals with insulin resistance, and they can contribute to the sarcopenia. So having looked at that, let us move forward to understand, and also the fact that, you know, if you have a fatty liver disease, metabolism associated fatty liver disease, you tend to have an increase in this problem of sarcopenia because of the fact that, you know, there again is inflammation triggering of this process. So there is interaction between sarcopenia and diabetes. There's a bidirectional relationship. Sarcopenia predisposes individuals to develop diabetes. Diabetes increases the risk for sarcopenia. So there is a clear bidirectional relationship, and correcting sarcopenia can probably, you know, be an important measure to prevent diabetes also in those who have not developed diabetes, and also in terms of preventing the complications of diabetes. That is what we are discussing today. So there is a clear bidirectional relationship between these two aspects. And if you look at certain other points that I would like to highlight today, is that, you know, with sarcopenia or sarcopenic obesity, there's increased risk for cardiovascular disease and also increase of mortality amongst these individuals who have sarcopenia with obesity. And it is also triggering of the various micro and microvascular complications of diabetes. If you look at the data on microvascular complications, we have data on suggesting that retinopathy is increased in individuals who are sarcopenic amongst the diabetics, and also there is data on nephropathy showing that sarcopenia can be associated with higher risk for the development of diabetic kidney disease also. Then there is interesting data looking at the intramuscular adipose tissue. So what we say is that the intramuscular adipose tissue is another important component, and when we are looking at individuals who are exercising or those who are using agents like the GLP-1 analogs, they lose weight, their intramuscular adipose tissue actually is coming down. So this is another important aspect that we should be aware of, that there is a large proportion of intramuscular adipose tissue also. So muscle quality is also important component of sarcopenia. Not just the muscle mass, looking at the muscle mass. That's the reason why we have the test for the muscle function also incorporated in the diagnosis of sarcopenia. Interesting studies which have looked at the association between metabolism associated steatotic liver disease, as we call it now, or the non-alcoholic fatty liver disease. It has close association with sarcopenia, and also with the progression of carotid atherosclerosis happens much more in people who have got sarcopenia and MASLD as compared to those who do not have sarcopenia. And similar correlation has been seen amongst older individuals who have sarcopenia, who tend to have higher risk of cardiovascular and all-cause mortality, as is shown in this Korean study, which has looked at elegantly studied this aspect and shown that the presence of sarcopenia itself increases the risk for cardiovascular disease. So having looked at that, let us now look at the evidence in younger individuals, because the session is on diabetes in young. And if you look at sarcopenia and poor muscle quality, this has been shown in young adults with obesity. So in this study, which looked at individuals with grade 2 to grade 3 obesity, they looked at these individuals and looked at the prevalence of sarcopenia, and they found that sarcopenia, even in these individuals who are on the average about 40 years old, we are speaking of 40 years having the maximum muscle mass, but even in those individuals at an average age of 43, we see that 11 to 13% of them had sarcopenia, and the factors which were contributing towards increase in the sarcopenia was again the insulin resistance, the obesity, and the inflammation that was induced by the insulin resistance. So this is what we need to look at, the possible etiologies of sarcopenia in young. So because this is an interesting aspect that has not been adequately studied, we have got very few studies which have looked at this, and this is something which actually all of us should be looking at, because what we also know from Professor Yajnik's studies that they've looked at the newborns itself. We said that we tend to have lesser muscle mass at birth itself as compared to Caucasian populations. So that is something which is interesting, and that tells us that we need to probably study more about this muscle mass in our younger population and how they are predisposing to the development of diabetes in young and its consequences. So the various factors are listed out here: metabolic syndrome, physical inactivity, inadequate nutrition, vitamin D deficiency, endocrinopathies. All this could be leading to what is causing sarcopenia in the younger individuals also. And what was seen was that, in fact, some people have in this Chinese study, they've tried to look at identifying people with pre-sarcopenia. We're speaking about sarcopenia itself not being studied adequately. They're looking at pre-sarcopenia, and they looked at a cohort of 1,200 odd individuals and with diabetes, and they found that pre-sarcopenia was present in almost about 20%. 1/5 of them had pre-sarcopenia, and they again said that higher BMI, shorter height, higher waist circumference were all contributing towards this problem. That is pre-sarcopenia, which will eventually lead to sarcopenia. And we are seeing all the consequences of sarcopenia. We have already seen that it can lead to not only type 2 diabetes, hypertension, cardiovascular disease, and frailty, dyslipidemia, and eventually lead to increased morbidity and mortality. So the pathogenesis, we have seen all the factors we just discussed, and the treatment aspects that I think this slide very nicely summarizes. I'll although I have more slides, but I'll stop here because this summarizes everything. This says that we need to, if we look at the treatment, we look at non-pharmacological treatment with increasing the protein intake and energy intake, increasing essential amino acids, vitamin D, calcium intake has to be increased, omega-3 fatty acids have to be supplemented, physical exercise. And when looking at physical exercise, it's the muscle strengthening activity which is going to be the aerobic exercises are going to give lesser protection from sarcopenia. It's the anaerobic exercise or the muscle strengthening exercises which are going to be better. And choice of anti-diabetic drugs has to be such that they are going to improve the sarcopenia and improve the muscle strength. So with that, I'll skip through all these slides which I had, but I will conclude by saying that what we need to look at is this is the way we need to proceed. Identify sarcopenia, look at the screening factors, and identify sarcopenia because that has an important impact on the outcomes, and we cannot ignore this. Often we have been ignoring this as a large elephant in the room which is not being addressed adequately. So we need to pay attention to sarcopenia in our patients with diabetes and address it effectively. Thank you. I'll conclude here. Thank you.
Thank you very much, sir. In fact, it was very enlightened. You talked about diabetes in the sarcopenia in the young patients. So it has a very impact on the quality of life. So therefore, what you have told us that we have to slow the progression of muscle loss and prevent the muscle loss. Thank you, sir. So questions from audience? With this, thank you so much. Now moving further to the last talk of this session, I would like to call Dr. Anuj Maheshwari. He will be talking about reassuring hypertension management with cardiovascular protection in the young diabetics. He is the past Vice President RSSDI, Governor American College of Physicians India Chapter, Professor in Department of Medicine, Hind Institute of Medical Sciences, Barabanki, Lucknow, PhD and DNB teacher, 87 papers presented at international and national era, 64 publications on diabetes and many more. He is also a recipient of the 2016 Notable Achievement Award in Hypertension
I think we can
Prevention.
skip some part.
Yeah, and list goes more.
Thank
And
you,
there is
thank you.
one more. He's a well-being champion 2018 by American College of Physicians. Over to you.
Thank you, chairpersons, for the kind introduction. And thank you, Dr. Manoj and Purvi, for inviting me here. So my topic is reassuring hypertension management with CV protection in young. Obviously, reassuring of hypertension is regarding the cardiovascular adverse outcome. But why we talk that this reassuring is required in the young individual? Because we all know that hypertension is a thing which comes with aging. As Dr. Rakesh Sahai just told us that sarcopenia comes with aging, the same way hypertension also comes with aging, with the stiffening of arterial wall. But once this comes in young age, when it is not that much of the age that stiffening of arterial wall may occur, then definitely it comes in our mind what pathology may be behind and how can we really avoid and how can we really reassure our youngsters to get the cardiovascular disease and avoid the cardiovascular disease. So if we look for the reason behind that, heartbeats of a generation which starts with the early life factors and challenges. A lot of factors are with the current generation are there which increase their heartbeat, which give rise to the tachycardia, their studies related problem, their love life, their tensions of the money, pocket money, lot of other things are there which may give rise to continuously increasing heartbeat, which may reflect in hypertension most of the time, and it ends up with the cardiovascular adverse outcome sometime. So this is not just a concern for the older generation. 1 in 8 young adults aged 20 to 40 are riding the wave of the hypertension, and the number are surging day by day because the tension, the stress is increasing in the young generation gradually day by day. As lifestyle behaviors shape our choices, the diagnosis threshold is changing, revealing a silent threat among the youth. Lifestyle behaviors and lifestyle changes which has been adopted by the youngsters, like late night awakening, like working along on the screen, working along on the mobile or computer screen, all these are increasing their blood pressure. So a lot of early life factors. Life journey begins with our heartbeat shaped by early life factors that subtly influence blood pressure. The mechanism behind this influence remain mysterious and not fully understood. Blood pressure patterns established in adolescence echo through time. These early patterns set the stage for the health outcome we experience in later life. Yet the harmony is not always maintained. Elevated blood pressure in youth choreographs a dance with abnormalities in heart and brain imaging. However, herein lies the challenge. Diagnosis rates are low and treatment enters the stage fashionably late for our young dancers. What exactly happens here? Many people, those who are having hypertension in their younghood, they tries to ignore that. Most of the time they avoid it, that saying it is because of some tension. It is because of some quarreling which has happened with a partner. So this avoidance ultimately pulls them into the cardiovascular adverse situation. And this is actually a reason which ends up with the instability of the blood pressure. Variability of the blood pressure is gradually increasing much more than it is required, and it is ending up with the hypertension related organ damage. Conditions enabling the hypertension in the young are renal parenchymal hypertension, renovascular hypertension, endocrine related hypertension, and thyroid related hypertension, which are commonly seen. Many times when we see any youngsters is coming up with high blood pressure, these things comes in our mind because that is not the age when we expect the arterial stiffness. But nowadays, because of use of their alcohol, smoking, occurrence diabetes in the young age, we are getting this arterial stiffness earlier, little earlier, or sometimes much earlier than it is expected. We all know that the younghood hypertension is mostly caused by all these things, and we should explore the reasons behind that. At the same time, high blood pressure in the upper limbs but low in the lower limbs suggests that aortic coarctation may be there. Sleep apnea syndrome is coming up as a big reason for the hypertension, which is oftenly related with the obesity. Marked blood pressure increase during apneic period is seen, and many times it becomes the reason for the stroke also. Brainstem vascular compression, which is the compression of the ventrolateral medulla oblongata by blood vessels, and neurogenic hypertension is caused by increased intracranial pressure, which may be because of the brain tumor, cerebrovascular disorder, and hypertension may be induced by the drugs which may cause the sodium retention or sympathetic activation. In youngsters, especially in India, sympathetic overdrive and sympathetic activation is one of the important reasons of hypertension if it is not backed up by any underlying disease or any underlying organ damage. So what the causes of the high blood pressure in teens commonly seen, which are arising due to insulin resistance and excessive human stress, may be the obesity. Decreased cardiovascular fitness is coming up because of their physical inactivity, hormonal changes, rapid growth spurts, and smoking is one of the important cause behind the hypertension in young. Now question arises, how can we really pick it up early? How can we really identify it when it is in the pre-hypertension, which is more commonly seen in the young people? It is actually a precursor of hypertension and adverse cardiovascular outcome. Early diagnosis and lifestyle adjustment can decrease the risk, but screening deficiencies persist among the youth. Risk factors include diets high in the salt, excess body fat, lack of exercise, and excessive alcohol use. So what we can see here, these are the factors which may be responsible for hypertension in young individuals, which can easily be corrected and not backed up by the underlying organ damage and underlying organ disease, like high risk of the drinking alcohol, smoking, high sodium consumption, which is commonly seen in the Western diet and fast food, what is being consumed by the youngsters, both lack of physical activity, obesity, abdominal obesity, especially when we see that a lot of visceral fat is there around the abdomen. So if we find a link between the hypertension and cardiovascular disease, it is hypertension heart disease classified based on the presence of absence of heart failure. According to the ICD-10 CM guidelines, there is a presumed causal relationship between hypertension and heart involvement. What the complications may be there? Because mostly in youngsters, we ignore the hypertension, we deny the hypertension, and this denial may end up in the stroke, heart failure, sexual dysfunction, which is commonly seen in youngsters and becomes the reason for the broken marriages, vision loss, heart attack, kidney disease, and sometimes kidney failure also. So this is the picture where you can understand what the CVD, cardiovascular disease, and without CVD, hypertension has its impact on the youngsters in our country. So in overview, hypertension is a leading risk factor for nearly all types of the cardiovascular disease, which are acquired throughout the life, including coronary disease, left ventricular hypertrophy, valvular heart disease, cardiac arrhythmias like AF, cerebral stroke, and renal failure. Continuous relationship between blood pressure and cardiovascular and renal events blurs the line between high normal blood pressure and hypertension, as these distinctions rely on arbitrary cutoff values. The prevalence of hypertension in various European countries is around 30 to 45% of the general population, with a sharp increase as people get aged. Prevention of the cardiovascular disease and treatment recommendations should focus on quantifying total cardiovascular risk, which can be estimated using several different models. However, the impact of age on risk is so significant that young adults, particularly women, are unlikely to be categorized as high risk even with multiple major risk factors and an evident increase in relative risk. Therefore, age-adjusted models, those assessing relative risk compared to peers of the same age, and models that include comprehensive assessment of target organ damage and 24-hour ambulatory blood pressure monitoring are necessary. Additionally, national models are needed due to significant variation in the risk factors and hypertension prevalence between the countries. We talk very little about the blood pressure variability as far as the hypertension is concerned. But in youngsters, we find a great variation among the intraday and interday hypertension too, and which becomes the reason of instability towards the adverse outcome. What could be the treatment goals and lifestyle modifications? Healthy diet, obviously the DASH diet approach, which includes minimally processed food, whole grains, legumes, vegetables, fruits, low-fat dairy, fish, lean red meat, limiting the sugar and salt both together. Sodium intake should be aimed for less than 2.3 gram a day, opt for a potassium-rich diet. Weight reduction is the key factor for the hypertension management even in youngsters. Physical activity like outdoor activities with 40 to 60 minutes of the moderate or vigorous physical activity 3 to 5 times a week. Sedentary life should be avoided. Ensure adequate sleep. Prioritize age-appropriate sleep duration. Stress reduction and healthy habits are again important part, like avoiding smoking, avoiding alcohol, using and doing the yoga and meditations regularly can help in removing the hypertension. If we look for the management algorithm in the youngsters, obviously we should measure the blood pressure annually, beginning at the 3 years of the age or at every visit when a person is presenting to a doctor. In the presence of the risk factor, it should be more frequent. If it is found normal, continue to measure blood pressure annually, beginning at 3 years of the age or at every visit in presence of the risk factor. If it is less than 13 years, 90th percentile for the age, height and sex is appropriate. But if it is more than 13 years, more than 120/80 or is appropriate blood pressure for the youngsters. Remeasure twice during the visit and average the values. If it is found normal, repeat at subsequent visit annually or more often based on risk. If it is elevated, then advise lifestyle changes. Repeat blood pressure after 6 months. If elevated, measure blood pressure in the upper and lower extremities to rule out coarctation of aorta is important at this time. If elevated at 12 months, order ambulatory blood pressure monitoring to your patient and initiate the diagnostic evaluation and consider specialty referral. In stage 1 hypertension, lifestyle changes advise repeat BP after 1 or 2 weeks if elevated, measure BP in the upper and lower extremities, order routine laboratory tests, referral to nutrition and weight management, recheck after 3 months of doing all this. If still elevated, then go for ambulatory blood pressure monitoring, evaluate primary versus secondary etiology, get done all the secondary hypertension causes evaluated, initiate treatment if it is found anyone, and consider the specialty referral. Stage 2 hypertension, measure blood pressure in the upper and lower extremity, order routine laboratory tests, recommend therapeutic lifestyle changes, then recheck within 1 week or refer to a specialist. If elevated, order ambulatory blood pressure monitoring, evaluate primary hypertension versus secondary hypertension etiology, get done all the secondary hypertension testing and find it out. If it is not secondary hypertension, then you can continue treating it as a primary hypertension, initiate the treatment and consider a specialty referral. Hypertensive crisis, refer to emergency department. So pharmacological intervention. Indications for the pharmacological therapy are advised when signs or symptoms of the hypertension are present. Considered in cases of the hypertensive organ damage like stage 2 hypertension, concurrent comorbidities or resistance to lifestyle changes. What the medical treatment or what the pharmacological treatment should be used in the youngsters? First line antihypertensive agent includes the ACE inhibitors, ARB, calcium channel blockers and thiazide diuretics. What should not be used? ACE inhibitors are contraindicated in renal artery stenosis, and beta blockers are avoided due to multiple side effects in youngsters for the hypertension management. Initiation protocol should be preferable to start with a low dose. If ineffective, consider a single full dose or low dose combination. If necessary, a full dose combination is preferred. The link between blood pressure and cardiovascular and renal events is continuous, making the distinction between high normal blood pressure and hypertension somewhat arbitrary. In Europe, about 30 to 45% of the population has hypertension, with prevalence increasing significantly with age. Preventing cardiovascular disease and guiding treatment should focus on assessing overall cardiovascular risk, which can be estimated using various models. Age has a significant impact on the risk, making it unlikely for young adults, especially women, to reach high risk levels even with multiple risk factors. Therefore, age-adjusted models are those that assess relative risk within the same age group, along with comprehensive evaluations of the target organ damage, and 24-hour blood pressure are needed. National models are also important due to differences in hypertension prevalence across the countries. Screening and diagnosis in young adults in recent times. Overall, screening for hypertension in young adults with obesity is feasible, but there are challenges in obtaining a complete diagnostic follow-up in this population. Family history of hypertension can be a useful factor in identifying those at high risk of confirmed hypertension. Diagnosis and cutoff. Age 1 to 13 year, normal blood pressure should be considered if it is less than 90th percentile. More than 13 years, if it is less than 120 and less than 80 diastolic. Elevated blood pressure, more than 90th percentile but less than 95th percentile, or 120-80 mm of mercury to 95th percentile. In more than 13 years of the age, it should be between 120 to 129 systolic and 82, and less than 80, it should be maintained to the diastolic. Stage 1 hypertension, more than 95th percentile to the 95th percentile plus 12 mm mercury, or 130-80 to 139 by 89 mm of mercury, whichever is lower. On more than 13 years of the age, the same 130 to 139, 80 to 89. Stage 2 hypertension, more than 95th percentile, adding up with the 12 mm of mercury, or more than 140 by 90 mm of mercury, whichever is lower, and more than 13 years of the age, obviously the same. Hypertensive crisis is considered if it is more than 95th percentile plus 30 mm of mercury without symptom, signs, or target organ damage. More than 13 years, we take the hypertensive crisis at more than 180 and 120 without symptoms and signs, target organ damage. Hypertensive emergency is considered more than 95th percentile plus 30 mm of mercury associated with encephalopathy, which may come up with the headache, vomiting, vision changes, neurological symptoms, facial nerve palsy, lethargy, seizures, or coma, with or without target organ damage. If it is more than 13 years of the age, 180 by 120 is the blood pressure associated with encephalopathy with the same sign and symptom. The cardiovascular protection strategy should be statin, aspirin, monitoring and follow-up. BP monitoring should be done with the importance of the regular home blood pressure monitoring and clinical reading. Avoiding the target organ damage and monitor the kidney function, ECG and echocardiogram. Follow-up frequency should be adjusted based on the control status and side effects. Addressing the non-adherence of the treatment or poor compliance is again an important thing. Cost, side effects, and lack of symptoms are many a times barrier which most motivates the patient to leave the therapy. We can have the strategies for improving the adherence with education, simplified regimens, mobile applications to remind the medication time. At the same time, we can also use the home blood pressure monitoring as a strategy to improve the adherence and compliance. Emerging trends and treatment in young adults may be the digital health technology, blood pressure diagnosis and treatment target, technology and treatment. Many a times we have the wearable devices which monitor the data tracking, telemedicine, therapeutic approach like existing antihypertensive drugs are effective and well tolerated, can be guided by the telemedicine and various applications and wearable devices, improved usage of the free and fixed combinations, including spironolactone and other mineralocorticoid receptor antagonists, should be applied, and consideration of the drugs initially developed for the heart failure and diabetes that also lower blood pressure could be applicable in the young adults as emerging trends for the treatment of hypertension. Thank you very much for your kind listening.
Thank you, Dr. Anuj. Thank you very much for enlightening the hypertension management in the young diabetics. So we can have questions from audience and we can have a discussion. I call Dr. J.K. Sharma to please come to the dais and join the discussion. And also Dr. Sanjay Agarwal and Dr. Rakesh. Please come to the dais for discussion, a quick discussion, sir.
What to ask today? Beta blockers are not recommended in the young individuals for the hypertension management. In fact, beta blockers is not a recommended therapy for the hypertension per se in any age group. Only in those patients we can use the beta blockers, those who are having cardiovascular underlying disease, having had MI before or having the angina. For the cardiovascular reason, they need beta blockers. Only those patients could be kept on the beta blocker. Usually the tachycardia which is occurring in young hypertensive, that is because of the sympathetic overdrive, and it is better to correct the sympathetic overdrive instead of using the beta blockers, because beta blockers may come up with so many other side effects which are not desired at that young age. Many times people also get the sexual dysfunction, many times people get the difficulty in erection. So that's why beta blockers are not recommended for the treatment per se until unless it is required for something else. Yes, yes, please. Good question. I understand your question, and the same problem we also face, and we also faced in our day-to-day practice, that tachycardia is a thing which is challenging most of the time with a young hypertensive. What exactly happens here that instead of using the beta blocker, it is better to address the tachycardia with the lifestyle modification first. If you are failing that, then you can choose the medications which control the blood pressure with heart rate reduction or causing heart rate reduction, like various calcium channel blockers now available with us. Even this ARBs are also supposed to be reducing the insulin resistance, as well as they are also supposed to be having the reducing the sympathetic overdrive. So we can use these drugs. If they are not working and patient is suffering a lot of trouble, what I believe, what I have seen in my patient, if you ask your patient to do the exercise, if it is young, you ask him to go for the half an hour morning walk or half an hour morning run, this tachycardia will come down.
Just
these are the symptomatic thing. If your patient is having these kinds of the symptoms, then you can use. But why do you want to use in the beginning of the life these ibuprofen and metoprolol kind of the thing? Take them for the reserve for the later life when they may be very much needed for the cardiovascular reasons.
Hello, okay, thanks. This is to Dr. Rakesh. And I'm asking you because I was asked this question when I was speaking in the other hall and I didn't have the perfect answer. Use of SGLT2 inhibitors in the young and chances of sarcopenia.
I think this has been discussed a lot about SGLT2 inhibitors because they cause reduction. So the data that has been produced is that the loss in weight is because of the loss of fat mass, and the other component that is there is also the intramuscular fat, which is also coming down.
So although we are looking at weight loss, we are not looking at typically sarcopenia being aggravated by the SGLT2 inhibitors. Same with the GLP-1 analogs also. The weight loss is mainly because of the fat loss, and the fat also from the intramuscular compartment. Also, intermuscular fat also is the fat that is lost. Sanjay, you want to add to that is also the fluid loss that you get, because it's like osmotic diuresis. So it's also the fluid that actually, if you get an immediate weight loss, it's more of a fluid loss rather than the fat loss that you tend to get, because that's very quick and they tend to get a lot of osmotic diuresis. It's only that the fat loss happens very slowly over a period of time. Most of this fat loss that happens is an ectopic fat that tends to. It's not usually the subcutaneous fat that goes, it's the ectopic fat that reduces.
So which gets me to the question that, we're talking so much about using SGLT2 in combinations, double drug, triple drug FDC right from the beginning. Would you say that's valid even for a 25-year-old type 2 or a 30-year-old today? So your thought on the approach?
I would agree with using them early on to provide the benefits. So during the course of my talk, I said that type 2s are presenting early and a lot of them are obese. So imagine a 20-year-old who's going to be type 2 diabetic is going to be prone for diabetic complications down the line. And you obviously would want to use agents which is going to help him to reverse that process. So using SGLT2 inhibitors early on is not a sort of a contraindication.
Looking at the data from the today's study and these studies, which have shown actually that when you look at the younger type 2 diabetics, they have very high risk of cardiovascular complications, which is much more than the type 1 diabetics. So I think we need to be sort of looking at these aspects right from the time they start having diabetes.
Thank you. Dr. Rakesh sir. Rakesh was one thing that normally what about the guidelines selling? Usually older people with sarcopenia, they have actually their own criteria. Do you think that this is same for younger people with sarcopenia, or that is a bit different?
So that is again, that's what I was mentioning, that we need to do a lot more work on this area, because this has not been studied adequately. Sarcopenia and younger population has not been studied adequately. We need to study this further to understand
Actually, if
these
the
points better.
diagnostic
I
criteria,
understand.
that is hand grip and
Yeah,
all
so
those things, probably a younger person will have better hand grip. So how you are going to?
I think we need to look at it more carefully and understand what has to be the cutoff for younger people. We've looked at mostly sarcopenia is always slotted into the older people. So I compliment Manoj for thinking about putting this topic about sarcopenia and young itself, so that we start thinking about it from and this is a important area that needs to be studied. All of us should actually look at this.
I was just sort of discussing with Rakesh on the way when he was talking about his topic. Usually sarcopenia in young individuals is always in a disease state. Rarely you'll find a disuse or something, you'll always have some associated condition that is actually leading to the sarcopenia. And it's the primary condition that is actually more focused on, which is why the sarcopenia gets missed out. But when you see a lot of wasting happening, and usually because of either nutritional or whatever it may be, that's when you find that, okay, this child is sarcopenic. So it's always a secondary problem that is there to a disease. You never get it as a primary entity.
That brings us back to the point that whether the same criteria should be used or we should use different criteria.
Yeah.
That's
So I
important.
think it's very difficult
Unless
to
we study
quantify in
further.
that sense.
Yeah, we
So
look
if you
at
look at all the markers or assessment standards that you tend to do, would obviously be different in children, which has not been standardized so far.
If I can.
Okay, thank you all these
If I can-
speakers. Thank you.
if I can add
With
on-
this, we close this session.
So continuing with our next session, unlocking the power of GIPs. For moderating this coming session, I would like to invite on the stage Dr. Krishna Chadri, Director at Primer Academy of Medical Science, Clintech, American Board Certified in Endocrinology, Diabetes, Metabolism, and Internal Medicine, Chennai.
Thank you. So over the next whatever time that we have, we'll have 1-2 talks, but let me start off with a small introduction. I think what we need to understand is this, that in the next 10 years, we are going to hear this story again and again and again. How there are molecules that will act on a single molecule acting on different receptors, either in the beta cell or in the liver or in other places, and in the brain, that will do the function of 2 or 3 hormones. At this point of time, it could be GLP-1, could be GIP, could be glucagon. Later, it could be an FGF or fibroblast growth factor. But the important thing is, before we start off, what is to understand that it is not anything new that one hormone can work in 2 receptors, or many hormones can work in 1 receptor. For those of you, my history of working with becoming an endocrinologist, one of the interesting things that I learned was that there was a patient with acromegaly who had galactorrhea. Why? Growth hormone and prolactin are cousins, or are actually that their ancestors came from the same hormone. In the cow, it's still a single hormone called somatomammophone, right? So when you have excess growth hormone, it can cause galactorrhea. A tumor that makes growth hormone can also make prolactin. So this is, in the past, we used to call it specificity spillover. Now you amplify this 5,000 or 10,000 times, and then use a designer molecule that is built, that has multiple actions on different receptors, doing the function of multiple hormones active at glucose at an amplified position, balancing out their side effects, and you have what is going to happen in the next 10 years. So what we are going to start today is to understand a hormone called GIP, which we have forgotten for many years. And then I will talk about how to bring in this together in modern practice. But this is what you're going to hear again and again for the next 10 years, that a designer molecule has the ability to act like multiple different hormones acting at 1 or more receptor, bringing a desired effect. And that is the future of diabetes and metabolic health, folks. So with that, let me call Indranil. Indranil is the research physician at Eli Lilly. Know him for many, many years. Keenly interested in endocrinology, and is now, I think, the lead of the metabolic spectrum in terms of the clinical lead for India for Eli Lilly. So Indranil will talk about GIP.
Thank you, Dr. Shadri, for that wonderful introduction and laying open the concept that we will be talking about a bit in the next 45 to 50 minutes that we have. The session, of course, is termed as Unlocking the Power of GIP, where we revisit a forgotten incretin, which is more like a cousin to a GLP-1RA that we are very familiar about. We have learned a lot about GLP-1RAs in the last decade or so. And in the process, we have serially underestimated a very close related cousin, or a cousin actually, which is the glucose insulinotropic polypeptide, or GIP as we call it. The objectives that we have for the session, both mine as well as Dr. Sheshadri's after this, we will start, and of course we will try and unravel a bit about the GIP in healthy individuals, and then what role it has to play in people with type 2 diabetes, and of course using this combination approach as a kind of a rationale in the management of type 2 diabetes. So you will have me on stage for about the next 15 minutes or so, and then we will have Dr. Sheshadri talking to us about the rationale, and then we will have the Q&A at the last. These are certain disclaimers. I can go through it. And as far as myself is concerned, my name is Indranil Bhattacharya. I'm a full-time employee of Eli Lilly and Company. And of course, I'm the medical lead for obesity with Eli Lilly currently. But I have had the opportunity to work on this molecule called tirzepatide in its development when the trials were being done in India, both phase 3 as well as when we try and work on some of the phase 4 designs that would be coming shortly to India. Currently, it's approved for the indication of type 2 diabetes. And of course, we are looking forward to a very interesting stint of this molecule in India in the coming year or so. With that, the GIP, the forgotten incretin. The incretin concept, of course, was discovered back in 1960s. And strangely enough, in 1970s, when the first hormone, which is the GIP, the glucose insulinotropic polypeptide, that was first discovered. A decade later, actually, the GLP-1 hormone was discovered. The GIP, if you just reflect, it has a proximal release in the small intestine, the duodenum part, and it's stimulated by glucose as well as lipids. The GLP, which has more of a distal release in the small intestine, that's actually stimulated by glucose alone. Nevertheless, these two hormones acting together, they do cause what we know is the incretin effect, which I'll come to shortly. This is just a cartoon which shows the two hormone release. And of course, in the middle, if you concentrate, you will look at the receptor, the site of release, the duodenal K cells and the ileal L cells from where GIP or GLP-1, they are released respectively in response to any food intake that happens through the mouth and finds its way into the gut. Since we started this talk about incretin effect, I believe this crowd audience that we have today here, we are all very familiar with the concept of incretin. Just to revisit that this is actually the difference in insulin release when food is given by mouth as versus when glucose is given intravenously. The differential in insulin release is what is known as the incretin effect. And just to show you the concept, this delta is what is the exaggerated insulin release with the oral glucose. This is the intravenous glucose, and this is what is known as the incretin effect. And we know that in healthy subjects, while the incretin effect on the left is preserved, if you move on to the right, it is the incretin effect that is impaired, and that's largely because of the first phase insulin release impairment that happens in people with type 2 diabetes as one of the earlier metabolic abnormalities that happens in type 2 diabetes. Now let's look at the actions of GIP and GLP. We will talk about it at 3 tissue levels. We will talk about it, and that is largely because of the receptor concentration that these two hormones have, and I'll come to it shortly. We will understand it at 3 levels. We will understand it at the level of the beta cell of the pancreas. We will look at what happens at the level of alpha cell of the pancreas. And then we will also look at a standalone action of GIP on the action on adipose tissue. But let's start with the beta cell of the pancreas. Now, of course, this is a receptor-mediated action. If you look into the cartoon carefully, there are specific receptors for GIP and GLP, which is, and these receptors, to these receptors, there is a binding of GIP and GLP that happens. And both of these hormones acting at the beta cell of the pancreas, it acts synergistically to cause insulin or enhanced insulin release in response to oral glucose. That's what the incretin effect that we saw in the previous slide. And just to show you a cartoon diagram, or the role that this is essentially synergistic. And of course, if you look into this model carefully, this is what is happening with intravenous glucose, okay? And then when you give a GIP antagonist, this is the GIP infusion that's happening there, which causes a potentiation. And then when you give an antagonist kind of a molecule, you do see a potentiation, but both acting together is what causes a maximum insulin release. So that's a kind of a concept proof, or a proof of concept, that both acting together, they do cause an exaggerated insulin response. And just to show you a cartoon, and very interestingly, one thing that is often underrated is that when it comes to the total insulin production, just the presence of glucose itself is enough to drive about 30-35% of insulin release. The rest, 65 or 66%, is what is driven by GIP and GLP. And just to show you the cartoon as to how it happens, so this is glucose entering the cell, and of course, through the ATP desensitization, there is an insulin production. Coupled with this, there is of course the GIP and the GLP, which is a GC protein, which binds to the GC receptor complex, and then further potentiates the insulin release. Now, the next obvious question is that what is the contribution of GIP and GLP to this observed insulin secretion? And this is the plasma glucose rise. It doesn't really matter whether you give it orally or intravenously, the plasma glucose is going to rise. However, what we have observed in healthy subjects is that the rise in GLP-1 is always there. This, if you reflect carefully, this is what is driving the incretin effect, and this is in response to the intravenous glucose where it's minimalistic. However, what has been overlooked in healthy individuals is that as one takes oral glucose, there is a huge potentiation of GIP also that happens. Now, if I look into the postprandial suppression, and there you see that the overall with the GIP antagonist suppression, it's maximal and it's more than what you see with GLP alone. And this is if you give the glucose orally, which is with a 75 grams of anhydrous glucose. If you increase the glucose load with a mixed meal test, again in healthy individuals, you see the same phenomena where the suppression is maximum with a GIP antagonist and not so with a GLP. Nevertheless, just to talk about the synergism, it's maximal when both GIP and GLP are acting together. So that's important to remember. If I have to give it a certain percentage, of course, to my earlier postulation that glucose itself drives about 33% of the total glucose disposal, and the rest 66% is what is contributed to by GIP and GLP. This is about 22% coming from GLP and about 44% coming from the GIP. So in summary, GIP itself is responsible for 2/3 of the total incretin effect. That's one of the key messages that we would really want you to walk away from this session. Moving on. The next thing is, how is this action happening? Of course, this is mediated by receptor concentration. The GIP, like its GLP cousin, is a pretty ubiquitous hormone. It has receptors fairly well positioned across the body. Some of these are of course described in humans as well, and some only in mouse model. However, I would like you to concentrate at two important sites. One is at the level of the pancreas, where it's the level of beta cells and alpha cells, and the other is at the level of the subcutaneous adipose tissue receptors. Now remember, there are certain plus signs, 3 and 2. So if it's a 3+, it's a very strong action at that site. If it's a 2+, it talks about an intermediate. If it's a single plus, that talks about a weak action. Okay, so remember that at the level of beta cells of the pancreas, and the previous slides that I just showed is actually reflecting on that idea. And then let's also look at what happens at the level of subcutaneous tissue, adipose tissue, and of course the alpha cells. Now, when we talk about the alpha cells of the pancreas, it's quite interesting that while we know that GLP-1 as a hormone, it reduces serum glucagon, but GIP actually drives it. However, in a healthy individual, the response is predominantly GLP-1 mediated. So in response to a glucose, there is a suppression of glucagon that happens. As the glucose disposal happens, the serum glucagon again drives back to prevent one from slipping into spontaneous hypoglycemia. So that's the overall effect. But remember, this is predominantly a GLP-1 mediated action. Moving on to the last piece of the puzzle, which is the action of GIP at the level of adipose tissue. And this is somewhat of a standalone action because of the simple fact that at the level of adipose tissue, the GLP-1 receptor concentration is pretty scarce. Now, when we talk about GIP acting at the level of adipose tissue, and just take a note that many of these are actually from preclinical studies, so we'll have to take that with a pinch of salt. Nevertheless, we do understand that activation of GIP receptors at the level of adipose tissue, it drives something which is like a systemic insulin sensitivity. That's a very interesting thing. And of course, this might improve the adipose tissue function, and we will see in a minute as to how it does so. Type 2 diabetes, we know there is an impaired nutrition partitioning, and of course, there is a spillover effect, which is ectopic fat deposition at various sites, heart, liver, kidney, and we talk about it. And remember, this is predominantly GIP because GLP-1 receptors are not there on white adipose tissue. Now, what it actually does. Now, of course, this is in healthy individuals, and we are talking about a hyperinsulinemic and a hyperglycemic clamp model. People who are not very familiar with this clamp models, let me just make it simple for you. A hyperinsulinemic hyperglycemic clamp is actually a postprandial milieu. What happens postprandially? We just had lunch, so we do have a blood sugar level surge, and along to counter that, there is a high insulin release as well. So in that kind of a clamp study, wherein we create this atmosphere, GIP, it actually drives adipose tissue blood flow. And that's exactly what is being seen on the screen right now. Now the question is, while the blood flow increase is fine, but what it actually does. So what it does is basically within the first 30 to 300 minutes, which is from about half an hour after meal intake to about the next 5 hours, there is an increased fat utilization, which is with triacylglycerol hydrolysis. There is a decrease in glycerol output, which potentially releases in less release of free fatty acids. The glucose uptake is enhanced, which is reduction of blood glucose and insulin sensitivity as well. And of course, the free fatty acid output that is reduced, which results in free fatty acids reesterification. So if I have to summarize, there is an incretin effect, and which is in response to oral glucose. 2/3 of the incretin effect is being driven by GIP. It is, of course, receptor concentration mediated. We looked at the beta cells of the pancreas and the subcutaneous adipose tissue. At the level of the beta cells, it causes potentiation of insulin release, acting in synergism with its cousin GLP. At the level of the adipose tissue, which is a standalone action, it results in increased storage capacity. But remember, while it does increase storage capacity, it does not create an obesogenic atmosphere because GIP per se, it reduces food intake, and there is no way that it increases energy expenditure or energy consumption. So per se, that does not result in obesity until and unless the energy balance is impaired. So moving on to the last slide that I have, if I just talk about GIP and GLP acting together, at the level of the brain, both are hormones, they reduce food intake. However, the concept of satiety, that is essentially a GLP-1 driven action because of the receptor concentration that we see with GLP-1RAs at the level of hypothalamus. Subcutaneous adipose tissue, based on preclinical models, what we have seen is increases insulin sensitivity, it increases lipid buffering capacity and increased storage capacity and reduces spillover, which is ectopic fat deposition. At the level of pancreas, beta cells increased insulin release, and glucagon is increased by GIP and less decreased by GLP. And at the level of stomach, this is predominantly a GLP-1 mediated action, which results in decreased gastric emptying, which results in postprandial fullness. With that, I hand it over back to Dr. Seshadri It was absolutely a pleasure talking to you, and thank you so much for for your attention.
Thank you, Indranil. Are there any questions for Indranil right now, or can we take it at the end of the session? Okay, thank you. Can we have my slides? Thank you again, Manoj. It's very unfair to have ice cream without me. Next slide. It's always a pleasure to be here. Manoj and Purvi are dear friends, and it is absolutely my pleasure to be with all of you. Can I have my slides? Okay, so while we wait for the slides, let me sort of recap this. Right? How do we know the incretin effect? Remember that it's almost 60 years since we learned about it. Two independent publications, one from Colorado, the other from the UK, McIntyre and et al. And what they showed was that it's very simple. If I give you glucose, if I gave you glucose IV, right? I elicit a less insulin response than if I give it oral. Very simple, correct? Now, if you dissect this out, it's not working. If you dissect this out, then we get more stuff. Right? Let me dissect this out a little more. So, there are three parts to it. One, glucose is able to stimulate insulin secretion better when given orally. This is one part to it. The second part to it, there are other substances that are being secreted by the gut that are sensing the glucose or other nutrients. It's not just glucose, right? It's protein, it's fatty acids, and contributing to the insulin release. And in fact, that is the nutshell of the incretin. Now we know that this incretin effect has three parts to it. One is the role of oral glucose itself. Orally, glucose is able to stimulate its own production well. Second, glucose is able to make the L cells of the intestine secrete GLP-1 and create insulin production. And the third is that the K cells of the duodenum secrete a substance called GIP. Previously, when we were studying it, was called gastric inhibitory polypeptide, but now it is known as glucose, what is it? Insulinotropic polypeptide. Now, the third part, the GIP, is sensitive to not just glucose, but also to fatty acids. And what we now know, and we'll talk about it, is that it seems to be, and Indranil beautifully alluded to it, as the prime driver of this incretin effect. Now, one of the things that we also have learned is that in diabetes, there is a decrease in the incretin effect, which means three parts actually. It's possible that glucose is not able to stimulate insulin. GLP-1 is not able to stimulate insulin. And GIP is also not able to stimulate insulin. What we do know is that in diabetes, it's not the levels of these hormones that are, but on the other hand, it is their action that is altered. So let's park this and then come back to it slowly over a period of time. So what we now know is that by enhancing the incretin effect. Remember, we said that the incretin effect is low, that it's not active. So if you can somehow make these hormones more active or more active at their receptors, we can produce enough endogenous insulin, at the same time not create hypoglycemia that will cause euglycemia. So in the past, we have talked about GLP-1 and we have found two ways to address it. One is by preventing the GLP-1 from getting degraded. That's TPP4. The second, by actually giving GLP-1 at a pharmacologic dose and restoring the ability of the beta cell to secrete insulin. Now we know that this GLP-1, when given a pharmacologic dose, has other activities. It works in the brain, it causes anorexia, it causes weight loss, a whole bunch of other things, right? But this is what we have known so far, and we've done this. Now, let's go back to this part. But what we know is that the GLP-1 being distal at the L cell, it contributes only to 20% of the effect of the incretins. The rest of it is mediated by GI. So a third of it is mediated by glucose. Glucose controls its own secretion of insulin. About 40% of it is done by GIP and about 20% by GLP. It's also quite possible that GLP itself works by restoring the sensitivity of the beta cell to GIP. We'll talk about it because we know that diabetes is a state of GIP insensitivity. Does it make sense so far? Everyone's clear about this? Can we move on? Okay. So, just to understand that while we talk about GLP-1 and GIP separately, I always think about them in pairs. Without Lakshmana, there's no Rama. They are together, right? Or Arjuna and Krishna, Nara and Narayana. So they complement each other's work. So let's look at how this works. This is, in the pancreas, if they work together, there's increased insulin secretion, there's decreased glucagon secretion. Now, if you want to look at this, GLP is brown, GIP is blue, and there are two. GIP actually slightly increases glucagon secretion. This is something we want to know. Second, in the stomach, there is delayed gastric emptying. That's one of the ways that GLP-1 works. Now, many of us think that the GLP-1 side effects, which is nausea and vomiting, is mediated in the stomach. It's not. It's mediated by its action in the brain. So these are centrally acting. Third, in the adipose tissue, there's not much work for the GLP-1. On the other hand, GIP has tremendous amounts of adipose tissue. Indranil talked about it, but let me summarize this. What it does is, it shifts the metabolism, and I'm making a jump a little here, but this is just to help us understand. It shifts the metabolism of adipose tissue utilization to subcutaneous tissue, thus diverting the excess amount of fat that generally belongs in the abdomen into the subcutaneous tissue. Therefore, into an inert space that does not cause problems. So that is how it works, working at the level of the adipose tissue. In the brain, as Indranil showed, GIP is not that very active. On the other hand, you have GLP-1 that works. In the heart, GLP reduces cardiovascular risk factors. So when they work well together, they complement each other. I believe that GLP restores some of the GIP sensitivity required for its action. GIP is a greater stimulator of insulin secretion. Together, they should do well. Let's see if they actually do that. How do you do? And in the past, we have ignored GIP because we've never had a way of working with it. And I'll show you how it does this. But let me introduce a way of putting them together. Now, there are many ways to put molecules together. One is, you can extend the molecule by by adding one to another. That's one way. But if you remember, if any of you go to a South Indian temple, you'll find one sculpture where there's a lion's body and elephant's head. It's called the yari. So there are Gaja yaris, there are Simha yaris, there are a whole bunch of yaris. So think of the various incretins of different kinds of yaris that bring in one body the action of more than one hormone. So these are called chimeras. And exactly what is this is a chimera. Meaning, by placing the amino acid in the right way and then creating a structure, the same hormone, the same protein can cause different effects at different receptors. So tirzepatide can work at the GLP receptor. It can also work at the GIP receptor, right? And depending on the amino acid that is binding, it can cause different effects at different receptors. Does it make sense? What chimeras are? This is coagonism and how it works with each receptor. Make sense? You can go read up the rest. Now, how do we know this works? So, when you give GIP tirzepatide at the GIP receptor, now you must read this graph carefully, and I will spend some time on each of these graphs because understanding these graphs helps us understand the whole concept. Now, if I give you an infusion of GIP, what does it do? And remember, these are animal experiments. I'm not going to go into how these work, but just for us to understand the concept, right? Now, how do I know that a hormone is working at a particular receptor? For example, in the G protein receptors, which is where most of the protein receptors work, protein hormones work, we look at the generation of an enzyme called cyclic AMP. That's really how we measure its potency. So when you measure the potency of the receptor, when you give GIP, it is exactly the same for tirzepatide as for native GIP, which means at the GIP receptor, tirzepatide does what GIP would normally do. Clear? Now, at the GLP receptor, let's say I gave GLP, maybe semaglutide, it doesn't matter. Its potency is a little weaker than native GLP-1. But together, 1 plus 1 is not 2, it's 22. Make sense? This is additiveness. It's not additive, it is incrementation of action. Second, this is again something interesting. I'm going to spend a couple of minutes on this. Don't worry about how mouse models are working, but what we are trying to do is to see if I take away the action of one hormone, how does the other hormone work? If I take away the action of the second hormone, how will the third hormone, how will the molecule work? So remember, tirzepatide has two hormones. It's going to work at two hormones, GLP, GIP. Semaglutide is going to work as one hormone, GLP. Correct? We are clear? This is the experiment. The first experiment, we are going to knock out GIP receptors, which means that the GIP receptors are not going to work. Now, if you look at this carefully, tirzepatide is in blue, GIP is gold, semaglutide is the open circle. When I knock out the GIP, you will realize that semaglutide continues to bring glucose down. No guesses there, because where does semaglutide work? At the GLP receptor. Correct? If I give GIP, the glucose doesn't come down. Why? Because GIP receptor is knocked out. But when I give tirzepatide, the glucose still comes down. Why? Because tirzepatide also works at the GLP-1 receptor. So from the first panel, what we have learned? We have learned that tirzepatide works at the GLP receptor and pretty much works like semaglutide. In the second panel, we have knocked out the GLP-1 receptor. Now let's see what happens. Remember again, Gold is GIP, blue is terzepatide, open circles are semaglutide. Look at GIP. No questions. GIP works when you knock out the GLP-1 receptor. When you give GIP, it's able to bring the glucose down. Why? It works on GIP. When you give semaglutide, how does semaglutide work? Works on the GLP-1 receptor. Glucose doesn't come down. When I give terzepatide, the glucose comes down because it's working through the GIP receptor. So the inferences from these two studies are very simple. Semaglutide works at the GLP-1 receptor alone. Terzepatide works at the GLP receptor and the GIP receptor. Now we know it's coagonist, correct? Understand? Clear? If I can understand it, anyone can. So if we understood these two, then rest is easy. We said it works on both receptors, therefore the glucose lowering should be fairly good. And you will see that in all of these studies that it is able to bring down glucose very well. And you can see that when compared to 1 milligram of semaglutide, you will find that at the 15 milligram dose of terzepatide is actually superior. Why? Greater glucose lowering effect because of its action on GIP. Okay? Now, terzepatide. You would not expect the addition of a GIP to cause additional weight loss, but it does. And the reason can be a whole bunch of things, but the most important thing is that even at the GLP-1 receptor, terzepatide seems to have actions that are fairly superior. Therefore, when compared again to semaglutide, you will see a greater weight loss with terzepatide. That's why, as everyone was talking today, there's such a big gray market for this particular drug. Right? Now, the question is there something else going on? What is going on? And that is the greater glucose loss, the greater glucose reduction when compared to a GLP-1 receptor. Can you explain that? And this is where, playing around with mechanistic studies makes a lot of sense. So here is a study that has looked at terzepatide once a week versus semaglutide once a week. And in some of these patients, there was a hyperglycemic clamp, right? And look at what is happening. I won't spend too much time on this. This is the first phase of insulin response. That is the second phase of insulin response. And you will notice that in both of these, there is a greater insulin secretory ability of terzepatide. Remember, we talked about it, that the insulin secretion, 20% is because of GLP-1, 40% is because of GIP, and therefore, when GLP plus GIP is present, there's a greater pharmacological effect. Makes sense? Clear? Why is there greater glucose lowering? Because of this. What this study showed is exactly that there is a greater whole body insulin sensitivity when terzepatide is given. So the glucose infusion rate that is required to keep it constant is much higher. That means the one thing that I notice in some of these studies is that there is a minor increase in hypoglycemia, not significant in these studies, but it's not zero. Also, very interestingly, we expected it to increase the glucagon, right? Didn't happen. This is baseline. This is week 28. That the total glucagon concentration in terzepatide was actually lower, saying that there's a GLP-1 and a GIP effect. I won't get too much into it. Remember, a lot of people expect that the gastrointestinal side effects to be lower because of the GI impact of GIP. The answer is no. It is as same as a GLP-1 receptor, and I told you why. Because GLP-1 receptors act centrally to cause the GI side effect. And in all these studies, you will find that the GI side effects are exactly the same. Nothing to write home about. Terzepatide versus semaglutide, not really much in terms of GI side effects. Hypoglycemia, I talked to you about a slight increase in hypoglycemia when compared to 1 milligram of sema at the highest dose, numerically significant, not statistically significant. So to summarize, and I hope that I've gotten your interest into this but exciting field, and I'm happy to sit with anyone and talk about it, because more than the promise of the molecule which is there, I think everybody is really excited about this group of molecules. I think what is there is how much science has contributed to our understanding of this. We have ignored the GI hormones for years. So to summarize, 40% of the incretin effect is mediated by GIP, right? GIP, that in diabetes is a space of GIP insensitivity. I believe that the GLP-1 part of any of these partly works by restoring the sensitivity of the beta cell. Remember, just lowering glucose restores the sensitivity of beta cells to GIP. So partly it is by restoring the GIP sensitivity, and the moment GIP is sensitive, then things happen. And lastly, that terzepatide, combination of these two works like a charm. With that, thank you so much. Indranil, you want to come up? Yes.
Can I take the first question to both of you? Thank you. So we are completely realizing the impact of GIP and how the co-agonism is going to do much better. The question that comes to mind very often is, in that case, why did never a combination of GLP-1RA and a DPP-4 inhibitor ever show anything beneficial?
So nobody's really looked at the combination of a GLP-1RA with a DPP-4 inhibitor, and I think we should put it up. So 10 years ago, if somebody would say that should I stop, can I continue a DPP-4 inhibitor in somebody on a GLP-1RA, you and I would both laugh at it, right? But I think in 2014 or 15, we had actually was an op that showed that again, that less than 50% of the work of a DPP-4 inhibitor is on GLP-1. It is the other bits. So the reason we haven't learned so much is, one is the desensitization of GIP that occurs. The second is the lack of our understanding in using GLP-1 or GIP antagonists and querying the system well. It's only the last 10 years we've learned how to query the system enough to understand that. Remember that you're going to, now the next question, and I hope we don't have time to do that today, is you can actually combine a GLP-1 receptor with a GIP antagonist and still get some of these benefits. And I can talk about beta arrestin till the cows come home.
So what a wonderful talk, sir. I felt as if I'm listening to my college professor. So
I'm not old enough to be a college professor.
So my question to you is, we have had some clinical experience in our day-to-day OPD about GLP-1 analogs, and so semaglutide, after a while patient develop tolerance, they start gaining weight, and we don't see them losing weight as effectively as they did earlier. Tirzepatide is one of the very exciting molecules coming up. So what do you have to say about the tolerance developing eventually on these molecules?
Okay, so remember that we are all hardwired to conserve energy. I think this is something that we should all be aware. For example, this work was, I'll use the SGLT2 receptor, SGLT2 as an example. Ella Ferranini showed this beautifully, that by month 3, that people start eating more. That's simply because that the body, an old joke is that after 3 weeks of fasting, Larry's fat cells decided to come out and ask for pizza. This is how we are hardwired, that we are hardwired to conserve energy. Also remember, and I think Purvi knows about my work, my talk about postmenopausal metabolism and how we actually slow down, that our metabolism does slow down. Having said that, these molecules actually have continued weight loss over a period of time because of their action in the central nervous system. The second thing, and I don't know how many of you have heard about these fabulous new studies of the GLP-1 receptor analogs on addiction, on alcoholism. I wish every doctor takes it in a conference before they come into a conference. On other things, simply because there is a big connection between the lateral hypothalamus, the orexinogenic pathway, the anorexin pathway, and how they work on the reward system. For many of us, food is a reward. And it starts from our younger ages. We are told, "Ye acha karo, main cake lata hu. Ye acha karo." Now I wanted an ice cream at the end of this talk. So right. So it works with the reward system. If the reward system is beaten, then we lose. But I think the next bit of this in the next few years, we are going to see a lot more work on how the GLP-1 receptor analogs and the GIP and the co-agonists work along with the reward system. Thank you.
Just one comment. Excellent talk. I think we also, it's in some ways comparable to exercise and how we never use exercise to actually lose weight. And secondly, it's also the way, like you said, like the way we are hardwired. We overcompensate for that, restriction and the basic premise of using weight loss medications is that it helps you adhere to lifestyle change.
So thank you, Purvi. I'm going to extend that and talk about just for a minute. And I know he's going to kill me, but I tell patients that innovation is overestimated, discipline is underestimated. So I have moved away when talking to my patients about, instead of talking to them about weight loss, I talk to them about creating a discipline that will sustain with them for the rest of their life. And one of my philosophies has been now that I am happy to give you the medication early so that when you're weak and you need a crutch, the medication is with you. But over a period of time, you're going to learn to get into the discipline so that even if I wean you off this, you're sustaining with this. So I hopefully I'll have data by the end of this year that I can talk about, but I'm trying to flip the paradigm. We think we should do lifestyle first and then medications later. I am starting to believe that we should probably do medications along with lifestyle first and switch to lifestyle only later. I don't know if that makes sense. Absolutely.
The next session is also on weight loss, so he will pardon me. There are different strengths of Manjaro available, and many patients are happy with an intermediate dose such as 5 for weight loss. So globally, what is the average dose which is used by the patient? Because it need not be 50 milligrams, actually.
So of course, tirzepatide or Manjaro as we call it, this is the same dose. So we start at a dose of 2.5 milligram once weekly. Give it for 4 weeks and then go up to the 5 milligram. In a person with type 2 diabetes, if you are initially treating this for blood sugar control only, if that's your treatment objective, the 5 milligram dose is quite good because it's with 5 milligram, you have actually a superior result than what you have with injectable semaglutide 1 milligram. And it's almost comparable to what you have with semaglutide 2. Of course, that's not approved in India. When it comes to the additional benefits of weight loss in a person with type 2 diabetes, possibly you might have to go up a bit high. What we have seen globally, of course, we haven't done those kind of prescription audits, but we do see that people often going up to 10 or 12.5 milligram if there is a secondary benefit of weight loss, which the physicians are targeting.
Absence of diabetes with overweight and obesity, even 5 will be.
We will talk about.
So I'll just quickly add to what Indranil said, and I urge all of you to look at the Surpass AP2 combo study, which was more of a Chinese regulatory study, but also had Indian sites. And our site had contributed. If you read that paper, which was published in Nature, what you can see is that in at least the Asian subjects, there wasn't a huge difference in both A1C and weight benefit when you move from 10 to 15. There was some benefit, but not. So I personally believe that, you know, your need when it comes into the market to go from 10 to 12.5 and 15, one would depend on tolerability, and the second would depend on the cost if there's going to be a difference between this trend. So let's wait and see, but not a huge difference between 10 to 15, right, is what we've seen in those studies. But again, if the tolerance is there, try and give them the full benefit and move it up there.
Absolutely, Dr. Chawla. And just for the information of the entire audience, we have looked at the entire SURPASS data, which was the development program in type 2 diabetes. We had a lot of pre-specified subgroups by age, more than 65, less than 65, BMI, more, less, sex of the patient, person. We have looked across economic strata by region. Irrespective, the drug does seem to have a good role in both in terms of A1C control and weight loss.
Sure. So I don't know whenever they get it here, but I could ask in the markets where it's available, is there a difference in the cost between 10 mg and 15 mg? Where it's available, wherever it's available, is there a difference in the cost? Not in Dubai, at least from what I know, right?
I don't think so, but I'm not the best person who can talk on the price. But I don't think there is much of a
Okay,
difference.
so an appeal that don't keep the price too different when you get it here as well.
So at least here, you can't have two doses at the same price. So there will be a price, may not be significant, but
Yeah, but there will be a minimal price difference.
there will be a price differential.
Thank you. I think we've had a great session, and I must say that the queries coming on understanding GIP well, I'm told that there was a workshop. I'm aware there was a workshop earlier. Some people took advantage. Many more could have taken advantage of the learnings of GIP, which is an emerging concept. But I think everybody here has gained a lot from this new concept coming in, and we surely await the drug to come in. As Krishna said, many of our patients are getting it from gray market and going either grayer or bolder with the cost there. So let it come here and let us get the benefit. Thank you so much. Both of you will ask for a group picture between the moderator, the speaker, and the speaker. Thank you. Thank you. So with that, we move on to the next session. And as both Jyoti and Purvi took up the questions and took up the time, we'll cut time from the next session. So, so it gives me great pleasure to invite the Sutradhar for the next conversation on drug, diet, and diabesity, a discussion on weight-centric approach in type 2 diabetes, none other than Dr. Hemant Thakkar. Dr. Hemant Thakkar is the Director and Head of Department of Medicine at Bhatia Hospital and Additional Director of Medicine at Jaslok Hospital. Well, he's somebody who is extremely eloquent with words, and you will witness that. And of course, I'm sure many of you read his article every now and then in the Times of India. I can go on and on. I've spent a lot of time in his company and enjoyed his company, and I'm glad that he's here to be the Sutradhar for this conversation. Dr. Thakkar.
Hello. Good evening, everybody. Purvi, Manoj, thank you for having me here. And, I'm going to continue what was kicked off by our previous two speakers. Weight, an accent on weight and how you can improve sugars, etc. And what better way than nutritional and specific nutrition for our diabetics. Remember, I have two great panelists who can bounce this concept amongst themselves. And I'm not going to allow any of you to sleep. I have prizes for people who interact with us well. So I'm going to order and request the prize givers and request the prize winners to take active interest. Can I have the first slide as we call our speakers on stage? Ladies first, Purvi, please let me welcome you on stage. Purvi is here despite the fact that she had a medical emergency at home, and I want you to give her a big applause for leaving whatever and coming to the stage for academics. And of course, my dear friend, Dr. Jyoti Dev, who is
one of the largest heavyweights as far as knowledge, diabetes, everything is concerned in the country and of course South India. So let's have the first slide. We know that drug, diet and diabesity, it's a discussion on weight-centric approach in type 2 diabetes. And when you look at weight, diet and diabetes for drugs use, for diet use to attack diabeticity, next slide please, you have to think a little more on what we are dealing. Next slide please. This is our disclaimers and one more slide ahead. Remember the projections for metabolic disease burden in India, and if you see the number in millions, diabetes, pre-diabetes, and if you put the two together, it will be a tall skyscraper. Hypertension, generalized obesity, abdominal obesity, and hypercholesterolemia. All these are linked. One piggybacks on the other, cholesterol, abdominal obesity, etc. And the next slide. The prevalence of diabetes and diabesity is that 1 in 4 Indian in the population is either overweight or obese. Globally, the World Health Organization has said more than 90% of patients with diabetes are overweight or obese. When I studied diabetes, it was called maturity onset obese diabetes. And the last is that the prevalence of obesity-related diabetes is expected to double to 300 million next year. Next slide, please. Now, given all this, we know that the biggest stumbling block is high BMI. And the attributed risk factors for diabetes complication is high BMI first, high BMI second, and high BMI all the way. And it is responsible for almost 31% of deaths and 46% of DALYs, high body mass index. Next slide, please. Given this, I'm now going to show you the portrait and profile of a typical case presentation of diabetes. 50-year-old male, known case of diabetes for the past 5 years, works as an auditor in a finance company, sedentary lifestyle, look at his height, look at his weight. His diet is 2,500 kilocalories, a little more than what we had for lunch. BMI is 30. He has already steatosis of the liver. Luckily, no retinopathy, creatinine normal, but his BP is 140/92. Fasting sugar is high, so is PPPS, and the poor guy is only on metformin with an A1C of 7.4. Next slide, please. Now, I'm now going to ask my expert on the right, Dr. Jyoti Dev, what should the nutritional management of this auditor be?
Thakkar sir, so can you go to the previous slide? So we are discussing a case when there is a person who is an auditor. So that means he is sitting most of the time in front of the computer. Like many doctors, we are also sitting most of the time. And sitting is the new smoking. We are expected to stand and go around at least once in every 30 minutes. That is a new rule. And he is obviously having obesity. The blood pressure is more than optimal. So we need to probably recommend a diet which can probably result in a reduction in the body weight, which should be significant. It should also reduce the hemoglobin A1C and other multiple parameters. So when we are prescribing medicines for a patient, many a time we are forgetting or we are ignoring or we are not getting the time to advise them on lifestyle modification. Usually we tell them, oh, go for a healthy diet and please exercise daily. So just 2 or 3 sentences. But apart from that, if you go by the guidelines from the RSSD or from the American Diabetes Association, you should be very specific with the nutrition advices. And here we are there to discuss on a diabetes specific nutrition formula. Because when you go by the ADA or if you recommend a Mediterranean diet, next slide.
Next slide.
Yeah, next slide. The proportion of carbohydrate, the proportion in the calories to be provided by the
Next slide.
fat or the protein, it should be 45% carb. Next slide. 45% carb, and then approximately around 30% or 35% of fat, and preferably mono unsaturated, because unsaturated will be safe. And then protein should be around 15 to 20% with sufficient amount of fiber, providing both micronutrients and macronutrients. So answering specifically to Hemathakasa's question, I will be advising a prescription I will be providing, and that prescription will have the advice on a balanced diet with an aim for reducing the body weight, because I should be very specific and that should be a smart advice. It should be time bound, realistic and achievable advice on weight reduction, which is possible, which is definitely possible with a diabetes specific nutritional formula, which has got resistant carbohydrates, because usually we have the simple carb in the diet, and a resistant carbohydrate will not result in a sudden spike in the carb. So it will reduce the spike. Yeah.
You've talked so well about weight loss. I want to briefly highlight the weight loss goals. In pre-diabetes, sustained weight loss can delay the progression from pre-diabetes to diabetes. And if you look at the weight loss in diabetes and obesity, even 3 to 7% of baseline improves glycemia and other intermediate cardiovascular risk factors, and a sustained loss of more than 10% usually confers greater benefit. So the targeted weight loss goal is about 5 to 7%. Next slide, please. Now, since we know that even a 5% weight loss can have a significant impact, what do you think is your view? I'm going to ask Dr. Purvi this.
I think great discussion that we've started. Even if you had not shown me the parameters and just the weight of that patient, I would have, probably guessed those parameters. Because today weight is very well established as not just something that is associated with diabetes, but it drives diabetes, right? And it drives many other comorbidities also, besides the mechanical problems and the sleep apnea, etc., etc. And any amount of weight loss is extremely beneficial in reduction in the prevalence of those comorbidities and also the mechanical aspect of being overweight or obesity. Now, as far as metabolic parameters are concerned, and I think it's a great goal to have in the beginning, because any patient that comes to you who's overweight and obese and you start talking about more than 10-15 kilos, it kind of demotivates them. So here's our best chance at least helping the patient initiate some weight loss or think in the right direction as far as weight loss is concerned. So even 5% weight loss is very well associated with improvement in metabolic parameters, whether it's blood glucose or so 0.5% reduction in HbA1c, 5 millimeter reduction in blood pressure, 40 milligrams per dl reduction in triglycerides, and this is an overestimation, although we've seen it in trials, but yes, mildly increase in HDL also. And we all know that HDL is probably most impacted by a good physical activity or exercise.
Wonderful.
So 5% weight loss is also critical to begin with. But that sweet spot, we'll come to that later.
Somebody in the audience wants to put in one line on weight loss. What is your experience? Fastest finger first. Go ahead.
Congratulations.
So I think his wife threatened him. His wife threatened him that if you don't lose weight, you won't fit into our wedding outfit, which we sewed 5 years ago. And she's nodding. So he's given his impact on that. Let's have the next slide. So weight all the way. For his wife, it was W-A-I-T, wait all the way, but he did it all the same. Next slide, please. Hey, somebody's sleeping there with the slides. Or give me the slide changer. No, I'm not going to say this. I want now somebody, and Dr. Jyoti Dev is the right person. What are the benefits of weight loss in diabetic patients? And I want you to tell me, looking at the look ahead and the direct trial.
Well, Dr. Puru has already discussed about the benefits of even 5% weight loss. And if it is more than 5%, next slide please, if it is 10% or more than 10%, then the benefits are much more. So look ahead and a direct, next slide please, look ahead and direct trials are the two trials which can be considered as pivotal clinical trials. And these are clinical trials in people with overweight or obesity, with diabetes, and not on any drugs. And these are not on any weight losing drugs. So in look ahead, as you can see that the potential role of weight loss in achieving diabetes remission, that is what they have looked for. And you can see that 7.3% at year 4 compared to 2% for the diabetes support education group. So they have compared the two groups. One is patients on intensive lifestyle modifications and the other on just diabetes support and education. And the results were phenomenal. And looking into the direct trial, a similar one, but here the diabetes duration was shorter, less than 6 years duration, and none of the patients were on insulin. And here again, they looked at the diabetes remission possibilities. At 1 year, it was 46%. At 2 years, it was 36% remission. And at the end of 5 years, it is still around 10% remission. So what is the lesson that we have learned? Next slide. So with weight reduction, higher the percentage of weight reduction, higher the chances of even diabetes remission, and all the parameters are getting reduced or getting eliminated. There is reduced chances of the complications. So the results of the weight loss in next slide, in look ahead trial, many patients were on diabetes specific nutrition formulas. So they were having a meal replacement in the intensive lifestyle intervention arm. So people were given in the intensive lifestyle arm, instead of a main meal, instead of snacks, they were given meal replacements with the diabetes specific nutrition formula. So compared to the control arm, there were improvements in lipid parameters, in hemoglobin A1C, in the postprandial glucose, and even depression. And in a meta-analysis, apart from improvement in life, quality of life, because quality of life is the most important, because whenever you lose weight, there is a improvement, there is a robust improvement in the overall quality of life. And the last parameter, I believe, sir, is most important, and that is cost effectiveness. Studies have shown that there is a reduced requirement of hospitalizations, and there is a reduced requirement of overall cost, because most of the long-term complications of diabetes are preventable when there is a substantial weight loss. And this is again, look at a trial, strong correlation with the number of meal replacement per day. So you can, at the bottom you can see MRs is the number of meal replacements per day. 1 replacement versus 2 replacement versus 3 replacements. So you can replace all the major meals, or you can replace one major meal depending upon your target. Remember the SMART goal. SMART goal means achievable, it should be realistic, and always in clinical practice, remember, whatever you tell your patients, it should be time bound. In the next 1 month or so, we can target 1 kilogram or 2 kilogram weight loss, which is achievable and which is realistic. And that is what we have learned from these 2 pivotal clinical trials, not involving any drugs, but only diet and lifestyle modification.
Thank you, Dr. Jyoti Dev. Remember, this discussion is not about rocket science, where you have a GLP-1, a GIP-1, a third one, you have artificial intelligence and all that. We're talking about the golden key and the golden rule, which we knew from the beginning, nutrition. It is just juxtaposing the different ingredients of nutrition. Before I go to Dr. Purvi, is there somebody from the audience who wants to talk about his experience? Asking questions will come later. I'm doing the asking. Last chance with this. Nobody? Okay, prizes are going. Dr. Purvi.
So, sir, just before
your experience, yes.
So I think Look Ahead and Direct Trial is a landmark trial, and it's a very, very encouraging one. Forget about the diabetes remission and all those things that we saw. I think one basic lesson that we all learn is that it's extremely easy to do it. The direct trial was conducted in primary care, which means each of us, everyone, even without a proper weight loss clinic, you can still give diabetes specific formulae, because that's the key to help patients lose weight. And today, with the numbers that Dr. Thakkar just told us about, I think it's imperative that we create this army of physicians addressing this grave problem, which is burgeoning, and hit it hard right in the beginning itself.
Somebody from the audience who is awake, I'm going to ask a sine qua non.
Yes.
Should we aim for weight loss for all obese patients with type 2 diabetes and pre-diabetes? Yeah, you raised your hand. You're first. Go ahead. Any comment? Very nice. I like the term pleiotropic that you used. Please take down, he's in for a prize. Purvi, your turn.
Yes, sir.
Weight loss should be recommended for all adults with type 2 diabetes and pre-diabetes. Can you make a comment on this?
Absolutely. Today it should be, and it is being recommended for everyone with pre-diabetes and diabetes. There's nothing like healthy fat. Or nothing like, these people are just prosperous. It's a matter of time that all the comorbidities will come in. So it's best that weight is targeted right in the beginning, as soon as you start feeling it and as soon as you are having discussions with your physicians. So excess body weight is definitely associated with the risk of cardiometabolic, complications. And to start losing weight is the first, of course, 5% with immediate benefits, and then 10% and more is definitely associated with diabetes remission also.
Great. Dr. Jyoti Dev, you have a comment, or should I give you the next question? So let's talk about physical activity recommendation. Again, a sine qua non, but we don't follow it. We write A, B, C, D, all the drugs, and at the last line we say lifestyle modification and complete it. We don't enlarge on it. I want Dr. Jyoti Dev to enlarge on it.
Yeah, okay, sir. Before discussing this, one comment on the previous one. So never forget that some other factors are necessary in the prescription. Despite weight loss in the Look Ahead and the other clinical trials related to obesity, we have observed that with just weight loss alone, the LDL levels are not improving, and these clinical trials have not shown any cardiovascular benefits. So there was no reduction in this CV mortality or morbidity. So what is the take-home point? Never forget controlling the blood pressure, and you have to continue with the statins in people with diabetes. Okay, moving on to the newer recommendations, and this is something known to you, but for doctors also we should remember this. And ADA has got a recommendation, the RSSDA is coming up with the recommendations, and overall it is 150, and now the recommendation is up to 300 minutes per week is also good. So earlier it was only 150 minutes of physical activity, aerobic activity, moderate to strenuous aerobic physical activity per week. And you have the pregnancy over there, 150 minutes per week. And in children and adolescents, there is a different recommendation. So when we are treating children with type 1 diabetes or below the age of 18 years with type 2 diabetes, the physical activity recommendation is 60 minutes per day. It's at least 1 hour per day. Don't forget about it. And they don't have any time. They have tuition, they have to go to the school, college, and then the recommendations on muscle strengthening exercise, it is 2 days a week. And when you consider the aerobic activity which is spread over 7 days, there shouldn't be an interval of more than 2 days between the 2 days of physical activity. So the maximum allowable is only 2 days of interval in between. Look at the last one in green, more the better. I think you can use more poetic words for describing this. More the better. More than 300 minutes per week is also good if we can do that. But do a physical activity which is doable and which we can continue. Going to the gym is fine because we are just discussing not just for the patients, we are discussing for doctors as well. Because the morbidity, mortality, even including the cardiovascular risk among the doctors are very high. And many of us are overweight and obese. So apart from the usual drugs and the prescription medications, we have to definitely we have to engage in the recommended physical activity, which is absolutely essential.
Thank you. Somebody from the audience, you have another point to make extra. Go ahead.
So, physical activity need not be exercise in a gym. It can be simple walk in your compound.
Very good.
Or you
Very
can
good.
just abandon the lift and climb the stairs and climb down. And I would like to know from the audience, how many of them have seen sunrise and sunset on the same day?
Look at that. So that's a
Good
very
one.
nice way of putting it. Any kind of walking. In fact, today in modern offices, people don't have desks and chairs. They have standing desks. So you can keep walking about. So that's an important point. I'm now going to go to my... Go ahead.
So just one small point. We are just coming up with a recommendation on, for primary care on primary prevention of pre-diabetes and diabetes. And, even 4,000 steps a day is good enough to be healthy and to aid increase physical activity in life.
See, she's being so generous. Make a beginning.
Because sometimes I think that 10,000 can be daunting and then patients don't end up doing anything, or even physicians don't end up doing anything. So 4,000 is a good aim to begin with, and that can always be, built on further.
So we've beaten around the bush for a while now. Let's get into the bush, the most important thing. You exercise, you try and lose weight by so many means. But what happens to your nutrition? Is there a diabetic specific nutrition in weight management? Yes, there is. And what is the role? Purvi, you can go ahead with this.
Sure. I think this is one of the simplest modalities or tools that we have today to aid weight loss. First of all, it's fixed calories. It's great combination of carbohydrates, proteins, and fats, along with fortified, minerals and vitamins as well. So it's a complete meal in a package and gives you the correct amount of calories. So it's the easiest tool, even if you're not, qualified or, you are not in the know-how of aiding patients to really get into intensive programs. This is a great way to begin, and it should not discourage you from starting any patient on weight loss. So
That's
yes.
a beautiful way. Remember, you and I don't have time at the clinic to say, itna moong, itna chawal, itna fanala, this, that. You have something which somebody over the years of experience has put together. Use that. You don't have time, you have a heavy OPD, but you have enough time to specify and prescribe the diabetic nutritional specific package. Go on. You have something to add, or should I ask you?
Sure, and it has, very, very creative ways of using this formula. Just remember that you have the tools, and now it's up to you how well you can use it in your patients to get to the magic target of 5% or 10% or whatever is considered and agreed upon with the patient that you want to aim at.
Dr. Jyoti Dev, you want to add something which will add some more flavor to beautify this nutrition?
Yes, some more flavor will be from my experience. I have been using it for more than 18 years now.
Look at that.
So my patients are very much convinced about this, because when we are discussing about nutrition, they are usually very happy. And this nutrition is something which can even increase, because our discussions were on GLP-1, and almost all the studies have shown that a diabetes-specific nutrition formula will also increase the GLP-1 levels, YY peptide. So these hormones are also increased, and there is a feeling of satiety. I think the only caveat here is we should be smart enough in advising the patients. If a nutritionist is available, well and good. So even in the absence of a dietitian in the group, somebody should be trained enough so that the patients know how to use it. Because there are multiple ways of using it. This can be used for increasing the body weight, or this can be used for reducing the body weight as a hypocaloric or as a hypercaloric. Hypercaloric. So this can be used as a meal supplement for increasing the body weight, or this can be used as a meal replacement. So you should know how to advise these patients, and over a period of time, every month or so, you should be measuring the body weight, and you should be making sure that you are reaching the target. Should I discuss this? Yeah. So this is a study from G and the group, and you can see that 3 different formulas are being they're compared: diabetes specific nutrition formula along with motivational interview. That is the first one. The second one is similar one without motivational interview, and the third one is usual care. And this is an algorithm called TDNA, that is Transcultural Diabetes Nutrition Algorithm, which is a fantastic one introduced in 2010. And this is based on the culture of a particular country or a particular ethnicity. This can be modified. And this is based on the body weight, this is based on the age of the person, and it is again based on number of meal replacements to be given daily. Next slide. So you can see the differences in the weight reduction, the BMI. Next slide, please. The waist circumference, phenomenal improvements with the Transcultural Diabetes Nutrition Algorithm. And this is another study where those patients, they have only reduced less than 5% of the body weight. They were switched over to the low-calorie diet with a substitution of the meal with the diabetes-specific nutrition formula. Next slide. So in those patients who are failing on a traditional regimen, when they are switched over to a diabetes-specific nutritional formula, look at the magic numbers over there in terms of body weight reduction. Phenomenal improvements, and the hemoglobin A1C reduction is far, far, far better than any newer drugs which are used in the management of diabetes. And it's similar improvements, modest improvements in all the lipid parameters such as total cholesterol, triglyceride, HDL. Next slide, please. So a diabetes-specific nutritional formula is far better, and we have evidence from global as well as Indian on hemoglobin A1C reduction, reduction in the postprandial glucose levels, phenomenal reduction in the body weight, and reduction in the systolic blood pressure and multiple other parameters. So this is something which has to be advised either alone or along with your usual therapies.
So diabetes specific nutrition. Don't get carried away by the fact that Dr. Jyoti Dev is saying, give these packets instead of meals. You have to decide. Your dietitian and you and the patient's wife has to decide whether you can substitute one meal with that. Begin with a meal. The most important question when the patient is finishing his consultation, Sahib, khawa pivanu su? And that's the most important question. So even if you are able to substitute one meal, which could be the culprit meal, with the diabetic specific nutrition, you've done your job, because you haven't wasted time talking about proteins, blah, 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 carbohydrates, but you have given something which is time tested. Before I go to the next question, anybody in the audience who has used diabetic specific nutrition and would like to tell us about it? Very good.
Fantastic.
He's talked about substitution as breakfast.
I think that's very important in the Indian setting, because most of our patients indulge in, locally traditional dishes like upma, poha, etc. And these are all high carbohydrate breakfast items, and we always struggle to give them protein options.
So please give him a breakfast prize. Purvi, you'll take this entail with the next question.
And
Indian evidence, role of diabetic specific nutrition in diabetes management.
like I said in the beginning, we have to get very creative with our use, and Dr. Jyoti sir really, belabored on that point, because he said we can use it to gain weight, we can help to our patients to lose weight with it. So it's basically how we have the tools in our hands and how we really prescribe that. Now, I really wish I was part of this study because it's such a lovely study from Dr. V. Mohan and group, the Indian evidence for diabetes specific nutrition in diabetes management. And mind you, we did there was a disclaimer that we are not talking about the GLP-1 drugs, we're not talking about bariatric surgery, but trust me, today diabetes specific formulae are used in tandem with all these other modalities. And this is something that will not go away even if you have undergone surgery or even if you are using any of these modern medicines for weight loss, you will still use a diabetes specific nutrition formula. And let's talk about the Indian evidence that we have. So Dr. V. Mohan's group tried this in patients over 12 weeks where they used the diabetes specific formula and they found fantastic results, not just in terms of glycemic reduction, but also with lipid reduction. And with keeping up with the times, they also did CGM studies because we know the time in range is the new metric in glycemic control that we are trying to learn or study in our patients. And beautifully you can see that the MAGE or the amplitude of glycemic excursion is so well reduced with using diabetes specific formulae as compared to usual care or compared to just the control arm where they were eating at libitum.
So is there somebody from the audience who has some documented CGM A1C evidence who wants to chip in? No. Of using diabetic specific
We have
nutrition?
that.
Manoj, you are not
You
audience.
are not audience.
All right. So Dr. Jyoti Dev, I want you to take over and tell me how diabetic specific nutrition and the weight relation that you get, how can we incorporate this in the weight management program?
So we can use this as Purvi was discussing now. We can use it for increasing the body weight. We can use it for reducing the body weight, and you can also use it for maintaining an ideal body weight and also A1C. So this can be given even in the absence of diabetes, but this discussion is confined to diabetes. So when you are comparing with an usual diet recommendation, a diet recommendation such as a keto diet, which is, I don't believe is a healthy diet, it is focusing only on one parameter, such as weight reduction. Whereas a diabetes specific nutrition formula is focusing on multiple parameters, including acute as well as long-term cardiometabolic benefits. So acute benefit when I'm providing a diabetes specific nutrition formula will be a reduction in the postprandial glucose levels because of the resistant carbohydrate. When I'm using a continuous glucose monitoring device, the 1 hour, the 1.5 hour and the 2 hour glucose spikes will be minimized or even absent. And this is well documented with CGM including in our clinics. And this is how you can advise in normal weight, uncontrolled diabetes when it is more than 7. So be very specific about how you are replacing a meal. So replacing a meal means 1 to 2 diabetes specific formulas per day to be incorporated into meal. In the normal weight, you need not reduce the body weight. And you can use it based on your clinical judgment. Here, the main reason you are using it is for improving the lipid parameters and not for the patient to gain further weight and for the patients to have a replacement instead of the usual snacks. That requires 1 or 2 scoops. For replacing a main meal, it is 5 to 6 scoops. So you have to be very much convinced and knowledgeable on how this can be either supplemented or replaced. So supplement means when somebody is having underweight, for example, underweight, the BMI is only 18 or 19 and they want to gain weight, or somebody is on a GLP-1, or somebody is on the dual agonist or the upcoming triple agonist, they are very much bothered about shrinkage of the face. You can use this for increasing the body weight, but that is not actual body weight. And for underweight people, apart from the usual diet, you can add on to the diet, and that is called a supplementing. And that also depends upon your clinical judgment. So there are 3-4 ways by which this can be used by the patients. And one comment on your, because your experience you have shared on replacing the substitute the breakfast. So many of my patients have a concern, oh doctor, I am replacing every lunch with glucagon. That means ensure diabetes formula. And these people who are overweight and obese, many of them will miss a lunch. They will miss a breakfast because that is so delicious and that is one of the pleasures of life. So what I usually tell them is you can replace breakfast on a day, lunch on another day, and dinner on another day. And if you are so
Staggered.
okay, then replace all the 3 meals on a day.
That's
So,
it.
yeah.
Go step by step. Let him buy it from you. Don't sell it to him. Begin like insulin. You use short acting for the largest meal. Let him choose. नहीं sir, I think I'll be able to in office. वो stock market ऊपर नीचे होता है, हमको time नहीं है, ग्लूसरना ले ले. So let him choose it. And from one you can go to another. Till you reach ideal body weight, till you get A1C, etc., etc. Anybody in the audience has a say? My audience
There's
has
a
all been.
prize.
Yes, go ahead. Go ahead.
Yes, sir.
So one meal replacement can be made adherent.
It's also
And it is there.
aspirational.
Right.
I
So
think it is
I'm-
there. It is there in this diabetes-specific nutritional formulas, such as the Ensure Diabetes formula. All these are actually taken care of.
in
It
the
is in
next
palatable
conference,
proportion.
which is in Ahmedabad, which Dr. Sabu is hosting, we're
Yeah.
going to have a table in the evening. There'll be no bhajia, gathia, pakoda. On one side, it will be that. The other side will be the snap. Let us see who gets snapped up. Dr. Sabu, small little suggestion from us. Okay, last question.
Just one quick point. The diabetes specific formula is so well fortified, even with the right amount of protein, that most of the times, because our patients have been protein deficient or do not take the amount of protein that is needed, they are able to, there is better satiety, and easily they can sustain 3 to 4 hours post one meal replacement. They are able to sustain without eating a snack or another meal in the middle.
What an important point.
That is an
Protein, yes, protein supplementation. Extremely important. I'm going to briefly ask this question. Is diabetes remission a myth or is it a clinical entity? Carry on.
It is absolutely a clinical reality, but definitely choosing the correct patient is for trying out or enrolling them in a program is very, very important. It should not be a commercially driven program where it is not really explained to the patients the entire premise of diabetes remission or the principles behind diabetes remission. So how, when, and for whom are actually the key, but it's definitely achievable, and identifying the correct individual is very, very important. A1C,
ABCDEF.
yes, and this is the, I think it's right there on the slide. I don't need to get into this. But I think there's one point I also want to make, that we have the tools here. We talked about using them creatively. We use them for different situations. Now let's just focus quickly on using it in different populations. So best is we can actually use them for the elderly also, because their nutritional intake is very, very compromised. They almost always end up eating what they like, which may not be ideal for them with diabetes or even without. And these can be very nicely used to fulfill their nutritional requirements as well.
Dr. Jyoti Dev, a model of obesity management.
Next slide. And it should be accessible, advise, agree, assist, arrange, and this discussion on diabetes-specific nutritional formula. I think Dr. Anil Virmani has raised a very important point. It should be palatable. And that requires advice and assistance from the doctors and from the team. And one point that I would like to highlight is different flavors are available for the diabetes specific nutrition formula. It's only not only vanilla flavor, but chocolate flavor is also available. So initially you had to assess all those parameters and advise based on the assessed parameters, and the subject should agree upon. Then we need to assist, and this assistance should be on a continuous basis, and then arrange all the parameters required for continuing the intervention.
So
this is
at the
counseling.
recent board meeting, which was held in people who manufacture diabetes specific nutrition, two suggestions have come. Besides vanilla and chocolate, they're going to make it pizza flavor, pav bhaji flavored, and uttappa flavor. Okay, anybody wants to put in their 2 bits from the audience for diabetic specific nutrition, which should be married with physical activity to produce the effective low birth weight child? So I'm just coming to medical therapy. If you see here, questions will come to last. Now, this metabolic surgery versus metabolic therapy and medical therapy for weight management. Purvi, you want to touch upon it?
So, like I said, it's not about just today we have pharmacotherapy for weight loss specifically, and even in our country where we don't have approved drugs for weight loss, I think there is enough happening with
Thank you. So she has told us that we've heard enough about weight loss drugs. This is a natural symposium of natural ingredients, of common sense therapy, of well constructed ideas with the proper ingredients to get you a meal supplement. We are not here to promote bariatric surgery. We are not here to promote drugs which give you Munjaro in your heart. Munjaro means fatigue. So we are here to talk about that despite everything, you can have DSM. You can have it post-operative, and not post-bariatric, but any post-operative, and you can have it as a focus any time of the day. I'm going to return back to our case, which we began with. Dr. Jyoti Dev, would you like to summarize? Are we happy with the patient's progress, or is there something else we should look for?
I think I am very happy with this progress.
May I share one quick tip? So all those who are using GLP-1 receptor agonists in their clinics, I think as the patient progresses with the use of it, we know at 3 months and 4 months, they are actually able to eat very, very little. Okay, so then the question and the challenge becomes for the physician that in that small quantity that they are eating because of the extreme reduction in appetite, we need to push in the right amount of nutrients and the right formulation. I use it in my patients. I use the DSN or diabetes specific formula even in these cases. And now it becomes even more important because they need the right amount of nutrition in that small quantity that they are able to eat.
Great. So next time somebody prescribes a pen of any one of these Superman drugs, you must put 10 boxes of diabetes specific nutrition. Now, you want to summarize on what this guy should do, Dr. Jyoti Dev?
Yeah, this guy, as you can see, he has stopped the medications and the A1C has reached 6.2. Next slide. And this is with the diabetes specific nutrition formula given over a period of time, and the steatosis has also reversed, and it is now normal, and this is possible. So with weight reduction, it is possible. We know all the parameters can be normalized or reversed with weight reduction. And remember, don't forget the medications to be given along with a diabetes specific nutrition formula. The statins need to be prescribed, and even for those patients, I have so many patients on GLP-1, liraglutide and semaglutide, and there again, I give a diabetes specific nutrition formula because in diabetes, if you look at the literature, there is 50% occurrence of B6 deficiency, there is a 90% occurrence of vitamin D deficiency, selenium, zinc, and all these micronutrients are there in a diabetes specific nutrition formula. So it's not just proteins alone. It is all the macronutrients and micronutrients required for a person with diabetes. So in any person getting treated for diabetes, irrespective of the body weight, for normalizing the glucose, for reducing the glucose variability, and for reducing the hemoglobin A1C, reducing the body weight or maintaining an ideal body weight, and for multiple other parameters and reducing the long-term risk of cardiovascular morbidity and mortality, I believe and strongly support the use of a diabetes-specific nutrition formula.
Look at that. In 3 hours' time, all of you are going to be with spirits, spirits of knowledge and spirits that evaporate. Whatever you do, what will be common is the diabetic specific nutrition, that is the soda or the water. You will add soda or water to either the GLP-1, I meant the whiskey, or to the Ozempic, or to the Monjaro, whatever you use, it's always going to be admixed. So this is actually the cornerstone of treatment, nutrition. If you don't have time to gauge and measure all the nutritional components, use something that has been scientifically approved. Purvi, may I close this discussion? Audience, anybody wants to say one last thing? No, I think everybody is hungry.
So I would like to
Go
share
ahead.
my own life experience. I was diagnosed with diabetes with a HbA1c of 9.8. My weight was 130. In 28 months, I have reduced 28 kilos at the rate of 1 kilo a month.
We'll give you one large chocolate cake
no,
with sugar.
I don't want
Please
any
see that
cake, sir.
comes. There is a young lady there. I think he talked about keto diet. He's going to talk to you over the next DSN coffee break, which has. I'm not going to go into intermittent fasting because Manoj there is making signs that the stage has to be evacuated. Thank you, folks, for listening. Thank you, panelists, and thank you, the organizers, for having us.
Thanks so much for the insightful discussion on the weight-centric approach in managing type 2 DM. We have highlighted the crucial role of weight management in improving patient outcomes. Now, it is my pleasure to introduce our current session focusing on the advancements in artificial intelligence in diabetes care. Please welcome our chairperson to guide us through this exciting topic, Dr. Rakesh Parikh, founder, Metabolic Society Jaipur, co-founder DTech, member National Executive RSSDI, and Dr. Pradeep Gadge, professor of diabetology at SL Raheja Hospital for Diabetes and All India Institute of Diabetes, Mumbai.
Good afternoon. I welcome you all for this afternoon session, which is on AIDs. And for setting the stage and introducing the topic, I invite Dr. Vinay Mulekar. Dr. Mulekar, okay. So, do we have the CV slide for Dr. Mulekar?
Can you speak? So thank you all of you. And today's very exciting topic, what we say is automation of insulin delivery. And so here this entire symposium will be into two different parts. The first part we will look at what is the clinical outcome, because as a clinician you want to see hardcore clinical outcomes, and then we will look at whether as a clinicians how we can work together to make this therapy available to more. So just wanted to briefly show you in type 1 diabetes. So this was the editorial published by Dr. Anju Virmani where she referred to multiple studies. And if you look at the second part which says ICMR registry data, lot of patients with type 1 diabetes are developing complications. So that is not the outcomes that we are interested in. And you may say, okay, that may be single center studies and all. So this was a interesting SAGE study, which was an international study, around 4,000 patients across 240 centers in 17 different countries. And they wanted to look at what are the outcomes in type 1 diabetes. And they divided this data across the different geographies like Asia, Eastern Europe, Western Europe, Latin America. And when you look at it, you can see one common theme is that no one is doing great. So the question is that, okay, what is that? There is something that we can do. What is there something that is lacking here? What is a common theme? And the common theme was that the outcomes are not drastically different across the geographies. Now, I always want to pose a very challenging question. And my challenge is, who is responsible? Is it a doctor? Is it a person with diabetes? Or is it the tools and drugs? So in our first lecture by Dr. Bansi Sabu sir, he will tell you who is responsible. If we change one thing, I know you will say all are responsible, but if we change one thing, can we get outcomes across the geography? In the next thing, we look at, okay, that's great, we know something is great. So that is where Professor Partha Kar is going to share his exciting story where NHS is the first country in the world where they have changed the scenario of type 1 diabetes. And actually in this article, a very beautiful, I would say, opinion expressed by one of the users. She said, this technology gives me freedom to get on with my life and live without the fear of what might happen in few hours, days or years. I think that is the important message. So with this, I would like to hand it over to her. Cheers. Thank you.
Thank you, Dr. Mukhekar. I would like to invite Dr. Bansi Sabu, who is the first speaker of this session. He is Chief Diabetologist and Chairman at Diabetes Care and Hormone Clinic, Ahmedabad, and he is IDF Southeast Asia Chair Elect. Over to you, sir.
Thanks, Chairperson, for kind words. Thank you, Medtronic, for this opportunity. Thank you, Manoj, Purvi, and WCPD, Congress, Organizing Committee and Scientific Committee for this wonderful opportunity. So first, very important question that how many of you are using or have used advanced insulin delivery system, AID, in your clinical practice? That's the most important thing. Unless you used it, as today morning in our session, Partha was saying that who is the best advocate? It is the doctor. If we start advocacy, because the persons with diabetes is not in our meeting, he or she is not going to talk. It is the doctor who has to do this advocacy, and we have to teach, we have to educate, we have to tell that this is the new technology which is available. Unless we explain the patient, we motivate them, they are not going to use it. Only thing which we always discuss, the cost. Again, before some time we were discussing that cost is a challenge, but 20% of our patients, 20% of the public, they're quite affording. We discussed that cost is a challenge for using CGM, cost is an issue for using GLP-1, cost is a challenge for using pump, but still, I always say that those who can afford, at least give them the best option. Before I start my talk, just before some time, I just talked in last, I think in technology meeting also, one of our rural patient came from a Mehsana district, which is a very small place. And then a young girl with father had come and the sugar was well in control and everything. We explained what exactly type 1. And the father was asking what is the best treatment, because we were explaining here for multiple daily insulin injection, continuous glucose monitoring, all those blah, 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 with self-monitoring of blood glucose. Patient asked, the relative asked, family asked, what is the best treatment? So I explained that, yes, this is the best treatment available, but I can understand it's very costly. The father told, okay, but what is the cost? Then I told it will cost around some 6 lakhs rupees. Every month you have to pay around 20,000 rupees for maintenance. The father told, okay, I will try my level best to get it. What is, the different logistic question when he was asking, and thanks to Medtronic that in India, they provide us 2-week free trial also for the patients. And we had asked the patient to use that 2-week free trial on that particular day. And after 2 weeks, the patient had purchased. So, you were thinking that this patient will not buy. It is in our mindset, we think that patient is not affording. We think that this patient will not be able to afford it. But you don't know the relationship between that father and girl, what father wants best for her child, for his child, that we have to understand. So I think as a doctor, it's our ethical duty to explain that what is available, what should be given, and what should be offered. So that's what I want to tell. You may have the patient which may not be affording. You may have the patient to whom you want to give free insulin. You may have the patient, but we should educate. We should give him what is the best option which is available. Let patient and family to decide also. So you should become the part of that family. What I'm going to talk is AID, that advanced insulin delivery system is the fundamental right for everyone with type 1 diabetes. We know what is fundamental rights. So this is from Wikipedia. We have taken the definition of it. Right to live is a justice, fair, and I'm sure Partha will talk all about, he knows much more what is the right of a person. But the best glycemic control system in the universe, this is again a very physiology slide, and for everyone to have the best glycemic control system, you have the body have a mechanism by which you have maintained with a person without diabetes will be always in a good glucose control. So these are some important terminology. The sensor augmented pump. Before some time, when we were using pump and sensor separately, but then the sensor augmented pump which was available to us, we had used it. The advantage was that those having a low glycemia, it will predict, and there was a sensor augmented pump came with a prediction also with a low glycemic sugar, it will also stop automatically. Then overnight closed loop system had come. It was not available to our country. A hybrid closed loop came. It was not there, but we were lucky that we got advanced hybrid closed loop system which is available to us. This is insulin pump over a period of time in last 100 years, after 1920 and 21, when insulin came. I always say in type 1 life, 2 very, very important things which had come after insulin. One, the insulin discovery itself was the most important. The 2 more important is an insulin pump and a continuous glucose monitoring. They had really changed the life of persons with type 1 diabetes. We know that insulin, once it came, it was very crude, then it was purified, then human insulin, and then premix, then co-formulation, ultra long acting, short acting, ultra short acting, all analogs, everything had come. But these are the 2 most important discovery for the changing the life is responsible. Is one is continuous glucose monitoring, another is insulin pump. And now with the insulin pump also advanced over a period of time, and now what we have is an advanced hybrid closed loop system. This is what the 2024, the American Diabetic Association, in their standards of medical care, standards of care in diabetes, in chapter 7 in diabetes technology, they are saying it's a evidence A that AID system should be offered for a diabetic patients to youth and adults with type 1 diabetes. So what's the treatment of choice with evidence A for all type 1, whether adults or children should be on AID, and when it should be started, either at the time of diagnosis, but there is some controversy for that depending on the patient's caregiver, need, insurance, how you educate, different things you can talk in between for that. Now, these are the multiple AID systems which are available in the world. Unluckily, we have only one, but luckily, we have the best one. So, I mean, this is what we don't have many choice. That maybe you may have that, at present, there are 5 different AID systems. These are available in different parts of the world. But luckily, we have the best one. Now, what's the difference between that? One, which I found the difference is with Mini-Med, we have the continuous glucose monitoring with Guardian 4, while others are Dexcom, where
continuous glucose monitoring duration can be for 10 days. Here it is for 7 days. That's the only thing which I found, which is differentiating with otherwise all other benefits are there with Minimed 780G, which is an advanced hybrid closed loop system which is available to us. This is a cross-sectional study with a Steno-Diabetic Center, Copenhagen, Denmark, and they had divided 4 different types of patients with a continuous glucose monitoring. Patients who is on multiple daily insulin injection, patients who are on a sensor but it is not integrated sensor with insulin pump. So insulin pump and sensors are two separate. Sensor augmented insulin pump, it means the same pump is also showing you the continuous glucose monitoring, and then automated insulin delivery system, this advanced automated insulin delivery system, and with 561. And you can see the time in range. I'm sure those who are here, they know the concept of time in range. And particularly for type 1, those who are on continuous glucose monitoring, we want them to have more than 70% of the time in range. That is what 70 to 180. We will not would like to have a patient to go in hypoglycemia for more than 5% of the time. That is, if they are going, you have to change the therapy. And hypoglycemia is the biggest barrier for them to have a good control of diabetes. So these 4 varieties of patients, when they are compared, you can see the time in range was with AID, with automated insulin delivery, it was 72.1% in compared to the patients who are on multiple daily insulin injection. And those who are on MDI, it means they are minimum, they are checking their sugar 4 to 6 times in a day. So that's what they have to do. So it was 72.1, but here you can also see the risk of hypoglycemia. The hypoglycemia is 1.7%, that is less than 70. They are going in a day. It is very, very less, which is acceptable. This is the data which Pratik had published with 100,000 real world users. It means from all over the world, the people from Europe, Middle East, Africa, he collected over 3 years from data to clinical evidence. And this is the data of 100,000 patients, real world user. At present in India, we may have roughly around 1,500 patients who are using it. We'll be showing some of the data from India too. And this is the all users. And again, they have divided into the patients who are below the age of 15 years and all those who are above the age of 56 years. And what they found that the patients who are in roughly all of them are having time in range more than 70%, and that is what we need for our type 1 diabetic patients. All for any type 2 also, we want them to have more than 70% of the time in range. And what is more important is the hypoglycemia, which you can see 0.4, 0.5 and 0.2. So whether they are below the age of 15 or whether they are more of the age of 56. So in any age group, what they found, the overall outcome is around 70% of the time they are remaining in time in range. If I take with the optimal setting of basal target of 100 milligram per deciliter, this range will further improve. This subgroup analysis with the 78 to 82% of the time, they are in time in range. So this is the real world data who are using 100,000 patients, and patients they had used Middle East, from Europe as well as from Africa. Somehow at that time, the India, it was not available, so we don't have the, in this particular paper, the data. What is more important is the consistency of glycemic outcome. And I'm sure those who are treating type 1 diabetic patient, sometime when we use MDI and we are aggressive enough, the next report you may find around 7 or less than 7, and we are very happy. But after 3 months, again, when we get the report, HbA1c comes 7.2. Again, after 3 months, sometime it becomes 7.5. And then patient gives also explanation. You also have explanation that in between something had happened and patient could not achieve or maintain A1C of less than 7. But the importance of this AID and putting this every month, it means they are continuously monitoring and see the reports. Every month you can see the time in range between 75 to 73%. So consistently, with every month, with every 15 days, every 7 days, this report is more than 70%. So every day the time in range in these persons with type 1 diabetes was there, this consistency of glycemic outcome. It is, if you say the country-wise, from the different countries also, it had shown almost similar data. So it will not be affecting whether the any countries there, whether it's Africa, whether it's Middle East, whether it's Europe, there was no change. You can see consistently, and every month they were getting the report of more than 70% of the time they were having similar or better HbA1c around the year also. The historically what we do, First, we start with the patient with a multiple daily insulin injection and sensor. So, I mean, any type 1 patients coming to you, what first thing which you do is we explain what is exactly type 1. You have to be on insulin therapy. There is nothing, no other choice is there. And you try to put patient on continuous glucose monitoring. Sometimes in India, it's not. We ask the patient to do the self-monitoring of blood glucose. And multiple times, you have to do the self-monitoring of the blood glucose. Ideally, it should be not less than 4, but sometimes 6 or 7. We normally ask the patient 4 times in a day and 6 to 7 times as and when required, or at least once in a week minimum they have to do. And then we explain the patient for sensor. So actually, we are doing 4 parts, but normally it should be with 3. You start the patient with MDI and sensor, and simultaneously you start educating the patient for the continuous subcutaneous insulin infusion pump. That is what CSII. Again, the India in Medtronic, they give you the 2-week, free trial, and that is what the CSII with sensor. So it's not the AID which we give at that point of time, but we give the experience of pump to that patient along with continuous glucose monitoring, and we ask the patient for taking 2-week a trial for using insulin pump, because there are a lot of logistic questions when they have that, how he will use, where he will use, what will happen when he will sleep, what will happen when he will lie down, what to do when he goes for swimming or in school, what will happen. All those questions are there, and those all logistic questions can be solved while using that 2-week a temporary uses with the trial. So that goes away with that. With the ADAPT study, which is an advanced hybrid closed loop system in an adult population with type 1 diabetes. Now this ADAPT is for not children, which are adult type 1 diabetes. And again, to tell that 50% of our type 1 diabetic patients, which are detected in India, we are the highest in the world to have highest number of type 1 below the age of 19, that is 24,000 children below the age of 19 added in the group which we already have type 1, which is as per IDF, we are having highest number of type 1 which are there. But 24,000, almost similar number we also get in adult population too. So I mean, in adult also we get similar number of type 1, and we sometimes they are misdiagnosed. Sometimes we see that they are started only on twice daily premixed insulin. Some of the time they are LADA or slow growing type 1 diabetic patients, and they are given even oral anti-diabetic agents too. But this study, ADAPT study, with an advanced hybrid closed loop system in a type 1. These are the patient in a similar way. Ask the patient for multiple daily insulin injection, put the patient on sensor and then on AID to evaluate the safety and efficacy of Medtronic advanced hybrid closed loop system in a suboptimally controlled type 1 diabetic patients with comparison with MDI therapy, because it has to be compared with some standard of care, which is multiple daily insulin injection with intermittently scanned glucose monitoring, and that's more common using a scanning with a continuous glucose monitoring. These were the 14 centers, this randomized controlled trial. All of them were above the age of 18 with A1C of more than 8, and they all were doing minimum or more than 5 scans per day. So if your patient is either doing more than 5 scans, that is good enough to monitor their sugar, and at the same time to take the correction dose also. And this is the patients who are on continuous glucose monitoring, not they are checking with the self-monitoring of the blood glucose level, the secondary endpoints, all these things. I have less time. So the study period was, they were compared with Minimed with MDI. After 6 months, they were all started with 780G system. And you can say 1.4 significant A1C reduction. So I told you the MDI is the standard of care. At present in India, it's 2 times sugar, which is what ICMR guideline, which I am against, and I told that it cannot be. It has to be at least minimum CGM for them. If you do the CGM scanning 5 to 6 times, still their A1C is around 9 or 8.5. They are not able to achieve and see the results with putting the patient on a continuous subcutaneous insulin infusion pump, particularly advanced hybrid closed loop system. And you can see persistently the report 7.3 for all these patients. Significantly more participants achieve the glycemic treatment goal in the patients who are put on this advanced hybrid closed loop system. The patients who are compared, no difference in total daily insulin dose. So the dose of insulin was not decreased or increased. The improved glycemic control was observed with Minimed 780G system. The diabetes treatment satisfaction questionnaire, this is very important, that has improved. There's a significant satisfaction which improved by putting the patients on continuous subcutaneous insulin infusion pump with advanced hybrid closed loop system. So this is not a routine pump therapy, it is ASCL. That's what we want. The improved glycemic control observed with that. The hypoglycemia is the biggest challenge. You know, when the patient is even used, why these patients were having HbA1c of more than 8? Why their average A1C was 9? Even they were scanning, they were using continuous glucose monitoring, but still the hypoglycemia is the biggest factor which is responsible for them not to achieve a tight glycemic control. We have seen that people can do, but then the risk of hypoglycemia from DCCT data, we know that it's very high if you are using multiple time insulin and correction dose also, but this is one of the reasons for them not to achieve a tight glycemic control. So their quality of life also significantly improved with the hypoglycemia peer survey decreased significantly. This is one more a pivotal trial results which is using 780s in type 2 diabetes. In type 2 diabetes, where you would like to use a long-standing diabetes with 25 years, where the patient is already on basal bolus, maybe on metformin now, maybe on SGLT2 along with it, but that patient required because the dose is very high, and we had also used some of the patients, and we will be showing some of the data in ATTD Asia. This pivotal trial had also shown in a real-world data to achieve a time in range more than 70% of the time. It is almost 80% of the time, 80% time in range they were achieving. This is one paper which is V. Mohan published from all across the country, all those patients who are from here, the initial phase in 219 patients from our country. He had shown almost the 75.4%. So I had shown you the real world data of 100,000 patients with Pratik had published. We are almost comparable or almost same. That same 75% of the time they are in time in range. So the India, whether they are from Africa, Middle East or from Europe, we also have the similar time in range. The longitudinal outcome users for these 29 patients with the time in range between 75 to 80% of the time, and again it is persistently every month we get the same time in range for them. This one more paper which today morning Abhishek Kulkarni paper talked about, Manoj had talked. This was published in SPAD 2023, a glycemic outcome of Minimate, and this is the outcome between comparing a children below the age of 15 between European children and Indian children, and you can see again it is comparable whether they are European type 1 below the age of 15 or the Indian. This is one paper which we had published in last ATTD, long-term clinical outcome of the Minimate 780G advanced hybrid closed loop system in India, a modeling study where we had talked about the long-term clinical outcome were estimated using IQI score diabetes model. I will not go in more detail, but this is what is the impact of this long-term diabetes complication. And this is very important because sometimes we explain the patient also in the same way that, you know, your long-term complication, the cost of therapy for treating the complication will be much more higher in compared to what you are treating. You are considering that 6 lakhs rupees immediately you have to pay 20,000 rupees per month will be the cost. But still, if you calculate for your 10 years, 20 years, 30 years, 40 years, even for 50 years till you live, it will be low if you will be treating their complication, whether it's a kidney problem or the retina, for all those things. And this we have done in a paper. Then conclusion that finding indicate a potential long-term benefit with advanced hybrid closed loop technology, need to further explore its cost effectiveness with healthcare cost data from India. This is one more paper which we have to be presented in ATTD Asia. Automated insulin delivery does adjust to physiological change in Ramadan fasting. So some of our patients who are type 1, they were never doing any sort of fasting because now they are on automated advanced hybrid closed loop system. Me, Jyoti Dev, Manoj and Vinay had helped us, and some of our patients who are doing the Ramadan, we have done this, and no hypoglycemia because the risk of hypoglycemia for them was significantly low because of this, and they could do even the fasting also. This one more paper, a time in tight range achieved with automated insulin delivery, results from multi-center retrospective from data, and we had shown that 75.92% time in range. But what we had done in this, how many of them are remaining in time in tight range, that is between 70 to 140. So we wanted to know that, you know, 50% of the time, if they are in TITR, that is the new concept, that if you can remain in this tight range between 70 to 140, it was 50% of the time they were in tight range, that is TITR, and the switching to patient from automated insulin delivery system to a patient after AID, what was the significant difference? You can see here the patient achieved HbA1c 8.77 to 7.1 with a 44%. They were in time in range. They improved to 75.92. Jyoti is going to publish this paper in ATTD Asia. So AID appears superior to other insulin treatment modalities with continuous glucose monitoring and conventional insulin therapy. AID system increased time in range across short-term and long-term intervention benefiting both children and adults. I had shown you the data both from children and adults. AID is the fundamental right of everyone with type 1 diabetes. Now, is even right when we are talking, it's a right for everyone to have it, because this is the only one which shows the data of improvement. Even if you put the patient on continuous glucose monitoring, it is not, as I had shown you, the most of the patients who are on CGM, still their A1C is around 8.5 or 9. They may have now less prick. For convenience, they may do use the continuous glucose monitoring. We all need to work together to make it reality, and that is what we need it. It's like a more of an advocacy to put the patients on a continuous glucose monitoring along with AID. But with the fact that what Partha is going to show, and he has done already in NHS and even in the USA, more than 100,000 or 150,000 children who will be now using advanced insulin delivery system. Why can't we? Even we have a lot of patients. We have 20% of them are affording. If we teach, we educate them, I'm sure many of them would like to have this AID system. To know more about it, we have ATTD, which is coming to Asia. This time it is in Singapore from 18 to 20 November. And we also do a diabetes technology meeting in India. That is in 9th to 11th May in 2025 at Jaipur. So we do a pump workshop, a pump school there. And in ATTD, an advanced technology, a meeting which is coming to India, Asia, which is in Singapore in month of November. With this, I once again thank Medtronic for supporting this meeting and supporting this symposia. And thanks to Manoj and Purvi for this wonderful opportunity. Thank you.
Thank you, Dr. Bachisabu, for this excellent presentation. It was convincing enough that access to AID is the right for a type 1 patient. But how do you achieve that? And for that, we have cost constraints. So now, questions will take later, but then to continue the topic, we have Dr. Partha, who has achieved that in NHS, ensured that every type 1 patient has access to CGM as well as the advanced hybrid closed-loop systems. He has graduated from Kolkata. Currently, he is working in NHS UK. There are several other accolades to his credit. He is also an activist. So if you follow him on Twitter, then you realize that he fights for the rights of type 1s as well as against the inequality in UK. So over to you, Dr. Partha.
Thank you very much. So what I will do is, as they say at this time of the evening, आपको थोड़ा कहानी सुनाते हैं कि what happened in the NHS. I'll make it a very short presentation, and then I think we got some people living with diabetes to talk about, and then we'll sort of go from there. So, first of all, this was in 2017. So we're talking about 7 years back. 7 years back, there was no Freestyle Libre in the country. The uptake of CGM was around 4%. Pumps in children were 27% and adults were about 8%. There was no specific focus, and that was the story in those days. This was the inequality of usage. So even in the NHS, even though it's supposed to be equal for everybody, that wasn't quite the case. As you can see, your deprivation mattered. So if you were coming from a lower economic condition or the color of your skin, you would have different access to technology. I don't think, so the best science, I always say, the best science in the planet is the one that you can get into people's lives. And here is some data, can you do better is not a strategy. So you need to have accountability. So where have we got to in the UK? So we tried to build a concept of a community. We have talked about communities of doctors, communities of people living with type 1 diabetes. We tried to, as Banshi said, how do you introduce that into people's lives? We worked together, collected data as communities. So it goes back to the point, how do you make these a reality? And one of the biggest challenges you always will face, people saying, oh, India, I don't think India can afford this. Well, as I've said in a session earlier today, India is the same country which has put a rocket on the moon, has got the fastest rollout of 5G in the whole world, has got some of the most richest people in the world in this country, and it's got a stronger economy than a lot of European countries. So if India can do all of that, India can do this too. So the question is, where do we, so we have got all these projects that we are running, and a lot of that is about enabling people with type 1 diabetes to have a much bigger say. So you saw the data in 2017. So let me tell you where we are in 2024. That number is now 98%. 98% of type 1 diabetes, this is not children, this is across all ages. 0 to 99 now have access to a CGM. CGM, continuous glucose monitor, is now basic standard care of type 1 diabetes and is up to nearly 40% of people living with type 2 diabetes and on insulin. This is, if you got type 1 diabetes, on the day you're diagnosed, not only you get insulin, you walk away with a CGM. It's taken us 6-7 years to get there. Don't forget our uptake rate was 2% to 3% 7 years ago. Pregnancy, type 1 diabetes pregnancy, we've got now 99% coverage. The important things are type 1 diabetes pregnancy, for the first time, due to the use of continuous glucose monitors, have shown that you have got lesser admissions of babies into neonatal care units. You got lesser baby size. The baby size being big as in problem in diabetes pregnancy for the first time is reversed, and there's lesser fetal malformation. So as a country, this is what we have achieved. But it's the point I always make is that it's taken us a long time to get there. It's taken us 7 years to get from there to here. And that is a very important thing I would like to everybody to take away, that these things take time to achieve. But the benefit you get by giving people better access to technology is there. And that's what has happened. So is it possible to do it? This is inequality data based on where you live, your postcode, takes time. Again, as you can see, there is no gap. So the closer the gap is of all the lines, there is no difference in who gets it. Everybody gets it in the country. Doesn't matter where you are, which part of the country you live in, now you have access to it. And this is something I wanted to share. This is about pregnancy. Again, in the UK, we battle with a lot of things, racism, etc., etc. But what we've been able to do by challenging people is to say, it doesn't matter whether you're white, black, Asian, mixed, your uptake, your offering has to be the same. And that's what we've been able to achieve. That happens by regular challenging people, regularly challenging clinicians, why you're not giving basic standard care. I'm not going to spend time on this, but I'm just going to give you a very simple example. I come from the UK, and one of the things you always hear about is that I have been approached by a lot of people here that they all are desperate to, we want to go to the UK. Yep. So I used to study here. I've done my medical schooling here, my schooling here, and I went to the UK in 1999. Would I go now? If I was qualified now, the answer is no. Because I think India now provides pretty much everything you can get over there, if not better, in a lot of circumstances. That's my first observation. As I've said already in a session earlier today, the only similarity between 1999 and 2024 is the presence of Shah Rukh Khan. I can't think of any other difference. That's pretty much it. He was doing DDLJ and all those movies in those days. He's now doing Jawan. He's got older. He's still here. But apart from that, India fundamentally is a different country nowadays. And I think that's very important to sort of recognize. The reason I show you this is that beyond diabetes, I do a work leading nationally about tackling racism and helping international medical graduates to come from this country. And this is what we showed, that referral to your regulatory body, which is the IMA, like body here, getting post, consultant post, all of these depend on the color of your skin. Why do I show you this? It's because it is a problem that we have been tackling in about people of different colored backgrounds also getting access to technology. But that's what we do. We challenge people, we talk to them that it's not the color of your skin that should be different. I'm going to give you a final few things to say. There are 4 groups of people you will meet in life when you're talking about implement. You heard from Banshi about what you need to do. And all the, everybody in life, all the women in this room will know this example. Let's talk about sexism. The 4 groups of men you will meet in your life. There's the first group who will go like, we totally believe this is wrong and I'm with you, right? You met 5 few of them in life. There's a second group of people who will go like, is it really true even in 2024? And you go like, come on man, just look around. You know it's happening. There's a third group of people who are completely oblivious to it. They just don't know it's happening. And there's a fourth group of people who genuinely believe you should be cooking and being in a kitchen and you shouldn't be working, right? That's the same thing with anything in science. You bring out any new papers, you'll meet 4 groups of people, always the same. The first group of people will tell you, I love technology, I love it. A lot of you are here. The second group of people will ask for some evidence, which Banshi showed you. Here are the evidence base. The third group of people not even aware that there is technology around because they're not aware of the benefits that it gives to people's lives. And the fourth group of people will tell you, I don't believe in technology. In my time, in the 1960s, I used to get people to count their diabetes by their fingers, and that's the way I will do it. It's the same thing, and it's a question of how you challenge each notion and each people to move things along. So my view is that we have technology everywhere in our lives. Who remembers going to the bank to put the money in? To the bank, standing there, having to pay. Who remembers this? You have to go to the bank and line up to withdraw your money. Remember that? How many of you do that now? Very rare, but it does happen. The point is, technology is everywhere, and it should be the same in health. All you find with continuous glucose monitors, AID system, is just about making people's lives better. If you don't have type 1 diabetes, you will not understand living with it. It's a 24/7 problem. Whatever you can do to make things a bit better, which is why where we are in the NHS, we say this is standard care. So as of the most recent data, 50% of our children and young people now have a hybrid closed loop of the population. And we expect 60% of the whole population, including adults, to have it within the next 3 years. So we don't want to see people with type 1 diabetes not on a CGM and not on a closed loop unless they specifically say, I don't want it. And there are people who don't want it. But generally speaking, that's what we want to be. This is what's happened, my final slide, to show what's happened across the country. HbA1c level, this is the population data. One thing we're blessed with in the NHS, this is every single type 1 diabetes patient's data in the whole country. As you can see, for the first time, technology landed, everything got better. Achievements of HbA1c across the population. So our diabetic ketoacidosis rates have dropped since we have explored the technology, including AID. Our HbA1c has got better. So this is the population benefits that we are seeing. This is what's happening right now about closed loops, which is now going to be common standard care for people with type 1 diabetes in the UK. And I'll finish there. So I think I always want you to take away this. You have the story of the UK or the England NHS. There's a couple of things I want to say as a pro and a con. The pro, that is possible to be done. I've been spending the last 1 year talking to people like Rahul and Bansi and Manoj and all these people trying to see what can we do in India. I don't believe in this concept that India is a poor country. That's nonsense. I think what we can do, we can do, and we are doing a lot of good work, and there's about getting people, community together, right? As I said at the very beginning, if you can put a rocket on the moon, you can afford stuff. That's as straightforward as that, okay? The other side of it is that the size of the UK is less than the size of the state of my state, West Bengal. So it's volume, but it can be done. That's the point, and we are very here to try and help you, anybody possible in any way, to share what are the jumps, what are the education we need, because one of the biggest barriers to adoption of technology is clinicians, us ourselves, because we're not sure about learning something new. My appeal to all of you would be, technology is coming whether you like it or not in the world of diabetes. It will be driven by people with diabetes. So learn about it, learn about continuous glucose monitors, learn about AID, and I wish you all the very best in taking things forward. Thank you very much.
Now we will be having some real life experiences by patients with diabetes who will be coming on the stage and sharing their experiences.
Vinay, who are the people with diabetes? There are some people. Okay. So, Manoj, are you sitting here? Yeah, please come. Please come.
Can I request Ansh, Joel, and Deepak Bhaiya sir, can you please join us on the stage, please?
Thank you. Thank you for coming. First, I will request every one of you for a clap for the people that have come here. Thank you. Should I start? Yes. Ansh? Yes. So how were you managing your day-to-day activities before using this automated insulin delivery device?
Hello. So before using the pump, I would have to check my glucose 7 times a day, and I have to take 4 times the bolus and 1 time the basal. But now I only have to check it 2 times, and it has been very easy now. And before, if I had to go down, I have to eat something before. If I have to play something, my parents had to constantly check and ask me if I'm okay, or if it's not hypo or anything. And at 3 a.m., they had to wake up at night and check my bolus to ensure that there is nothing wrong, like hypo, or my readings are not high. And if that was the case, then I had to take some bolus at that time or eat some sugar. So
multiple times you used to check your sugar, and with activities also you used to check. Any other question you want to add?
No, I've got a question which is for Joel. So obviously we're hearing about what it was before. So how has your life changed? Has it changed, first of all, after you've gone on to automated insulin system? And if you believe it's changed, in what way do you feel it has changed for you on a personal day-to-day situation?
So for me, I feel that the pump has been incredible in terms of me living a normal life. I would add to the previous question that what I used to do before, in the terms of taking the insulin, I used to just go according to what the doctor says. So as a routine, I used to take so much units in the morning, so much units for lunch, and so much units for dinner, and not understanding how it connects with the carb that I have. So it used to be like a routine, but then so it never used to match the carb units, the carbs that I used to have for breakfast and lunch. So it was difficult to understand that. With the insulin pump, it used to automatically check my sugar levels and give me the insulin that I need. And so I didn't have a tension on whether I took enough of insulin, or did I take less or did I take more. And that really helped me. So if I have to go out for meetings or go out to meet friends or anything, I didn't have the tension of what my sugar level is going to be throughout the day. I could just get up and go and know that the pump would be there by my side to control the sugar levels.
Thank you.
Yes. Yes.
No, so I got diagnosed with diabetes about 3 years ago, and I'm the first person in my family to get it. So it is not hereditary; it is something that happened just to me. So I had no idea of diabetes. I had no idea of carb counting and insulin and anything. So I never used to do it. Only after I got the diabetes and I spoke to the doctor really helped me to understand what is the correlation between the carbs that I have and the insulin that I have to take.
Thank you.
दीपक भैया.
Speak in Hindi.
Oh yes, please. So आपको भी पूछता
मुझे तो
हूँ.
कुछ फर्क पड़ा नहीं है. जब से
What
लगा
can
है,
you do easily after automation? ये पंप लगाने के बाद में आपको लगता है कि बिफोर पास्ट और ये लगाने के बाद में कुछ फर्क पड़ा है?
नहीं, पहले बड़ा टेंशन होता था. जब भी शुगर का चेक करता था, मुझे डायबिटीज 35 ईयर से है. आज 35 साल बोलेगा तो बहुत बड़ा टाइम हो गया, लेकिन मुझे याद नहीं है कभी भी मेरी शुगर कंट्रोल में होती. अभी मैंने 6 महीना पहले ये लगाया है, और नॉर्मली कभी भी चेक करेगा तो इट्स ऑलवेज अंडर कंट्रोल.
सो बहुत बड़ा फर्क है. 35 साल से शुगर कभी कंट्रोल नहीं थी और अभी पंप लगाने के बाद एकदम एक्स्ट्रा ऑर्डिनरी कंट्रोल.
ये वरदान है हमारे.
वरदान हो गया. बिल्कुल बिल्कुल, बहुत बड़ी बात कही आपने. कंप्लीटली चेंज कर दी लाइफ.
चेक किया है ना, कभी भी नींद में से भी उठ के चेक करेगा तो इट्स ऑलवेज विद इन द कंट्रोल, विद इन द लिमिट्स.
And you have the data also to show the time in range कितना रह रहा है?
I'll be having some data.
That's great.
मैं पूछूं?
Yes.
So on the topic of need, the question for Ansh. What's your view about your sleep quality? Has it got better? Doesn't matter? Sleep, has it made any difference to your sleep? Do you feel less disturbed, more disturbed? How would you put it?
it has obviously gone very better, because before at 3 a.m. If they had to check, then I had to wake up, then I had to check, and if it was high, then I had to take bolus, or it was low, then I have to eat sugar, then wait 15 minutes and then eat something so that it doesn't happen again. But now, because of the auto correction, if it goes high, the pump automatically gives small short boluses so that it comes in range, and if it is seen that it's going down, then it cuts off the basal to prevent any low from happening. So sleep has been
And relevant to that, right? If you think about the days before you have the automated insulin, next day morning, what's the impact of that? Do you feel like you are more alert, less alert, tired? How does it feel? What's apart from the not waking up in the middle of the night? How does the next day feel to you?
So next day is more energetic for me because I have like normally I sleep at 12 and wake up at 7. So when I don't have to wake up in the middle of the night, so I get more sleep and the energy.
And how old are you? How old are you?
I'm 15.
You must be the only 15-year-old who wakes up at 7 every day. Please.
Yes, that's very important.
Yeah, I think it's like he said, it's a blessing for us. Otherwise, every 3 a.m. we would put our alarms and we would go out and check, and then we had to treat him either ways. If it was high, then wake him up, and because it's a pen shot, he has to take it himself. After the pump, if we need some help, we can also bolus him. And similarly, if it was low, then you give him sugar, wait for 15 minutes, give him 15 grams. So our sleep has become great, and not only sleep, I would just like to add that that's been the great time for us, because now we don't have to be. Earlier we used to be around when used to play, because we used to fear that it would go hypo. But now we can see his sugar levels wherever he is in the school. He's gone to a school picnic into a different city, and we can always see what his sugar levels are. And we also know that he has the pump with him, so it will not allow him to go hypo. So it's brought a lot of peace for us as well.
Great. So one thing I just wanted to make one comment is that when we did the nice work around closed loops, we asked parents, what are your feedback? And that was a big driver in us getting approval. And one of the comments which always stays with me is one mother saying, we had more sleeping and less beeping. And that was always stuck in my mind, which was a lovely way to put that was the big change that had happened in the parents' lives, if that makes sense. Sorry, Panch.
Very true. So I just want to show Deepak here.
नहीं करता हूँ, डॉक्टर साहब ने जो मुझे बताया ये डोज लेना है तो ये डोज लेता हूँ।
बराबर। सभी आप कार्ब काउंटिंग नहीं करते हैं, तो फूड बोलस को कैसे मैनेज करते हैं? जो बोलस ले रहे हैं वो कैसे? डॉक्टर साहब ने जो बताया फिक्स डोज कर दिया, और यदि उससे कुछ ज्यादा खा रहे हैं, कम खा रहे हैं?
नहीं, मैं अपना लेवल में खाता हूँ।
लेवल में खाता,
कुछ भी उल्टा सीधा खाता ही नहीं।
और अभी कॉफी एक्स्ट्रा लेते हैं तो उसके लिए कुछ एक्स्ट्रा डोज बोलस लेते हैं, जैसे कॉफी ली या कुछ लिया
चाय लिया तो 2 पॉइंट
कुछ ऐसा एक्स्ट्रा। डॉक्टर साहब ने बता दिया सब,
वो सब जो डॉक्टर साहब ने बोला है वही करता हूँ।
बिल्कुल, बहुत बढ़िया। दीपक भैया के लिए सब ताली बजाइए। 35 साल से डायबिटीज with 84% now in time in range. Great. Yes, sir. Next, sir.
Question for Joel. So you've told us, and I'm sure you agree with everything that's been said. Life has been better, good, on a new system, sleeping better. What else do you want from the system? If you had a magic wand and you wanted the company to deliver something else for you, not cure of type 1 diabetes, we still haven't got there. That's always 10 years away, as you all know. But what would you like the insulin delivery system to do for you? One more thing that would make life even better.
I would think on a practical point of view, the app that is there on the phone is right now it is good, but it just only shows you the details. Maybe if you could control the device through the app, would be a good thing. And also, personally, I don't know about them, but I feel that the pump may not be suitable for the climate of India. I say this because I have noticed when it's humid outside, it loses signal a bit. Okay, so like when you are sitting in an AC room and then you go out to a humid climate, it loses signal for a few seconds. I've also noticed this firsthand when I was in this year in May. I went to Goa. It was really hot and humid, and the pump did stop working for maybe like a day or so in terms. So that is my personal opinion that I hope I can say. So
Dr.
that is
Partha
what,
and Dr.
but
Bansi, can you take some questions from the audience
Yes.
also?
So this is the question which we want to ask to the audience. If you want to ask anything, but one common question.
एक बात बोलनी थी
बिल्कुल. नहीं, हम एक बार ये सब आपसे भी पूछेंगे. बताइए आप. बताइए.
एवरी 6 महीने में मेरे को एक अभी जैसे इतना मैंने बताया आपको, मेरे को 35 साल से जो डायबिटीज है, तो वेरियस प्रॉब्लम्स आए हैं. आँख का प्रॉब्लम है, थोड़ा कान का प्रॉब्लम है, पर पता नहीं क्या क्या प्रॉब्लम्स है. तो ऐसा हुआ कि एवरी 6 मंथ्स में मैं रेटिना के लिए इंजेक्शन लेता था आँख में, एवरी 6 मंथ्स में. तो 3 महीने के बाद ऐसा होता था कि ब्लड दिखता था, टीवी देखता था तो दिखता था कि बराबर ऐसा क्लैरिटी नहीं होती थी. अभी जब से ये पंप लगाया है, मुझे अभी ऐसा लग नहीं रहा है कि मेरे को वापस इंजेक्शन लेना पड़ेगा. हो सकता है लेना पड़ेगा, लेकिन बहुत टाइम के बाद. पहले हर 3 महीने में 4 महीने में लेता था, अभी 6 महीना हो गया, अभी तक मेरे को लग नहीं रहा है कि मुझे जरूरत है उसकी.
ग्रेट.
एक वो भी बात वो मेन है. एंड दैट इंजेक्शन यूज टू कॉस्ट मी अ लॉट. इट यूज टू कॉस्ट मी 40,000 per injection per time. So that thing I think
So
I
it also shows the cost effectiveness of the pump
बहुत
therapy.
बड़ा, हाँ.
आपने ये भी बता दिया cost effective है ये therapy.
एक्सपेंसिव है ना वो.
So one
अभी
question which
I am ये इतना एज है मेरा 65 है मैं. I am about to retire now. तो मुझे तो सब पैसा सोचना पड़ेगा ना.
सही बात. Thank you. The common question, you know, most of the time clinicians feel that they could not motivate. So I think if you want to ask them that how their doctor have motivated him or her to take the insulin pump therapy, if anyone wants to ask. No, they have to ask them that, you know. Or any other question?
Actually, Dr. Partha, I would like to ask you, with your experience, so we have a lot of, not a lot, but at least few celebrities, and especially women, who do not want to even try the insulin pump. They're okay with managing everything else, even learning how to count the carbs, and few of them have been diagnosed quickly late in the day, so it's not a skill that they are just ready to acquire, but they are ready to do that, but not
Yeah, I mean,
come across.
Yeah, absolutely. So I think it depends. There's two things about it. One is, do they have any role models to look at who are managing that? Okay. So, for example, one of the topmost models in the world does the ramp walk with her pump on her, right? So that's Kate Moss's daughter. So depends as to who you want to see and what you want to project. The second thing is, I think pumps are becoming smaller and more discreet. Pump companies are very aware of it. And I think a lot of work is going on trying to hide as much as possible in that sort of thing. The third thing is, I would say that people say, look, I want to go for a swim, or I don't want to have it outside when I'm wearing lesser clothes or that sort of environment. I think it's important to say that if you're on a pump which is on a tube, you can take the pump off for a certain period of time. So if you want to go for a swim, you can take your pump off, reconnect it. So I think it depends on the information. I would say that a lot of our celebrities in the UK and otherwise, it's a slightly different society. So they're much more open about it. So nowadays, because CGM is so common, it's not a problem. It's not seen as something extra. But you still have people, and especially younger women, all who are in that sort of domain, the celebrity world of acting and stuff, so I don't want to wear it. And finally, some people always struggle with, how do I hide it if I'm doing a role where I have to take it off? So we just need to give them the education. You can do it with the background insulin as your backup. You can take it off for an hour and a half because the insulin can still last. And it's about those sort of modulations. Or you can wear something, if it's a little pump where you can hide it, put it on a part of your body. So it's very possible. A lot of it is education. A lot of it is also about informed choice. And I don't think everybody has that necessarily.
I think as Dr. Partha said, we must insist in our country that insulin pump is a standard of care, and a newly detected type 1 diabetic initially definitely should be given a trial of Medtronic. which I have done in my practice, at least for 1 or 2 weeks, and that really impacts. So the ones who are studying and who are about to earn, they always say, yes, madam, I'll go for the pump once I go into job. And believe me, it just, the HbA1c just stands at 6.5 for most of them. And it impacts life, as people have said. It impacts life in a large way, and we have to tell them that your HbA1c and your quality of life, the complications, everything is averted with this insulin pump. It's worth the money, and it's literally a one-time investment. Please go in for it. And we'll have to motivate them, reassure them, reinforce it on them.
If I can have the privilege of the final question here. Joel, sorry, I forget. You single, you married? Are you single, are you married?
I'm single at the moment.
At the moment. What happens when you find a girl? Have you thought about it? And I'm just trying to understand. Do you think?
Manoj, I didn't know you'd taken on the role of matchmaker as well. This is new.
So, I've been so inspired of being a holistic doctor that I'm looking at the entire process for Joel.
Excellent news.
So, Joel, do you think, about this conversation of you having diabetes and being on the pump, does that cross your mind when it comes to relations moving ahead? Don't scare the young boy.
Actually, it has been a lot of help. I am single, but I'm in a relationship. Thinking of getting married maybe next year, that is whatever. So when I talk to my significant other, my partner, she doesn't understand diabetes. So I have to, whenever I meet the doctor, I try to show her my reports and say this is this and this is what needs to be, this is the target range. And then also I have given her the app so that she also can see what my sugar levels are. So then if I have to explain something that, oh, my sugar level should be between this during the day, then when she looks at the app, she'll start to understand, oh, okay, fine. Then if she looks at the app and says that it's gone high, then she'll tell me, oh, why is the sugar level gone high today? What did you eat? So her understanding is getting better and my understanding getting better. So we have this open dialogue and conversation, and it helps her to understand that living with diabetes and maybe thinking about marriage in the future with someone who has diabetes is not a deal breaker in the sense, or if she thought of it before, she definitely doesn't think of it right now. So it really help in that way.
All the best.
Yes. Last question.
Automated system. I still want to know which part of your life is still challenging with the idea in the school, exactly when you're playing actively or at home playing with friends, or in any particular time in the life in the whole day where you're still finding challenging with this.
Now he's not finding any challenge.
It's finding challenging to find what the challenge is.
So while Ansh is thinking of that answer, just to give you a bit of time more to think about it. So one of the big things is about people living with type 1 who are in the public space coming out and saying they have type 1. This is very important because it gives a faith and a belief and all that sort of thing. So I don't know if any of you have seen the movie Kalki. Yes. Do you know the connection between that and type 1 diabetes? No, she does. There's some people who knows. So the little girl who plays the role of the little girl with Mr. Bachchan, and so she's got type 1 diabetes and she's very open and talking about it nowadays since she's received the fame. It is very important to put that in the public domain. So for us in the UK, that has been a big plus. Actors, politicians, everybody coming out and saying it's type 1 diabetes and I live with it and I can do this and I've achieved that. And that is also important with the question that Manoj said, is cutting the stigma across society. It's like it's absolutely fine. And nowadays technology can let you lead a completely normal life. So that's something. Ansh, you got plenty of time to think about your answer now.
Or I open it to even to Joel and आपको भी. If you think even using this.
थोड़ा जोर से बोलिए.
मैं बोल रहा हूँ कि आप 780
मैंने आपको जैसे बोला.
हाँ.
मेरा कान और आँख सब affected. तो थोड़ा जोर से.
उनका ऐसा सवाल है कि अभी आपको कोई चैलेंज है ये पंप के साथ में आपकी लाइफ में, जैसे कोई पहले जैसे था, अभी कोई ऐसा कोई स्पेसिफिक कोई चैलेंज है, अभी कोई ऐसा कोई लग रहा है आपको, जैसे रात को सोने में काफी लाइफ कंफर्टेबल, बहुत
कंफर्टेबल हो गई.
एंड अंश के बारे में उन्होंने पूछा तो अंश के पापा यदि आंसर करना चाहते हैं दैट क्वेश्चन के, एनी चैलेंज व्हिच यू फाइंड with pump, particularly with activities or school or evening time while playing or while going for swim or any other thing which you feel?
I think life definitely has become easier for me. think he's been telling me that it's only about his cannula changes every 4 days. Otherwise, and his sensor changes.
So few expectations which we were discussing, you know, the one expectation can be that cannula instead of working for 3 days or 4 days, if it can work for 7 days, that could be an expectation. The
New
other thing is
expectation.
like the CGM which is working for 7 days, if it can work for 10 days or 14 days, you know, to change that continuous glucose.
And he had some new expectation as well. Maybe he could.
On every time you have to calculate the carb, if that goes away, those could be the expectation.
So, like auto correction होता है वैसे, some sugar thing can also go in the pump. So if it is low, then the pump can give sugar to the body, so that I do not have to take it when in between my.
But do you get hypoglycemia with this pump also?
Yeah,
Anytime?
sometimes.
Sometime? What time? What is the sugar level at the time?
65.
65. So it goes up to 65. But less than 5% of the time?
Less than 1%.
Well, less than 1%. That is expected. So,
Dr. Bansi, before we
एक
close.
और बात
Yes,
बोलनी थी,
sorry.
एक बात बोलनी थी. I've been working since I don't know how many years. 8 to 10 hours a day I'm working. मुझे तो कुछ फर्क लगा ही नहीं है. पंप लगाया तो ऐसे लगता है कि कुछ नॉर्मली चल रहा है.
अभी एकदम नॉर्मल हो गई लाइफ. अभी भूल गए डायबिटीज को आप. बहुत बढ़िया.
Diabetes है ऐसा पता भी नहीं चलता.
Very good.
So, Dr. Bansi, before we close it, I agree with both of you that cost is not a problem probably. The problem is of our priorities. So, we Indians are known for the most extravagant and lavish weddings, but then we don't spend on healthcare. We may not spend on weight loss. The same applies for type 1 also, especially in parts of North India. People spend on weddings and everything else. Now, here I recall one analogy that you always give of car. And if you give that example to the patients, it helps them to realize that probably pump is better than a car.
Exactly.
So maybe you can tell it for the others advantage. Like that example is probably convincing. Analogy here.
नहीं, उन्होंने ऐसा बताया है कि जैसे पेशेंट को एजुकेट करने के टाइम पर कभी कभी हम उनको ऐसा एग्जांपल देते हैं कि इसकी कॉस्ट जो आप गिन रहे हो वो एक्चुअली सही में बहुत ज्यादा नहीं है इन कंपेयर टू अपन कई चीजों में एक्स्ट्रा खर्चा करते हैं. जैसे शादी में खर्चा करते हैं बच्चे की एजुकेशन में करते हैं या घर में नई कार लेके आने में करते हैं. उसके सामने इसकी इतनी कॉस्ट नहीं है. तो जब हम पेशेंट को कई बार समझाते हैं,
पहले ही बोला कि ये एक बून है. बून के लिए तो पैसा का सोचा नहीं जाता है ना कभी.
आई एग्री. लेकिन ये आपके लिए हो गया, लेकिन ये हमको तो हिंदुस्तान के हजारों लाखों पेशेंटों को समझाने के लिए
वो ठीक है.
जो आप तो बॉम्बे से हैं, इतने पढ़े लिखे हैं, इतना समय आपने सर्विस की है, आप समझते हैं. लेकिन हमारे को तो एक अनपढ़ भी, एक गांव से भी आया हुआ बच्चा, उसके पेरेंट्स को समझाने के लिए कभी कभी
मैं
डिफिकल्ट.
हमेशा जो कंपनी का जो आदमी है जो मेरे साथ टच में रहता है, मैं तो उसको हमेशा बोलता हूँ कि कॉस्ट बहुत ज्यादा है. जो डेली जो रिकरिंग कॉस्ट है ना, दैट इज वेरी एक्सपेंसिव. एक बार 6 लाख रुपया खर्चा कर दिया, ठीक है, दैट इज ओके. लेकिन वो जो रिकरिंग कॉस्ट है ना, दैट इज वेरी एक्सपेंसिव.
So
तो
with
आप
this,
कुछ भी बोलिए.
a big round of applause for Deepak Bhaiya, Ansh ji, Joel, and to Dr. Manoj Agarwal and to Medtronic.
एक मिनट, मैंने डॉक्टर साहब से भी बात किया था एक बार. मैं डॉक्टर साहब ने क्या बोला, इंडिया में एक्सपेंसिव है, यूएस में तो इंश्योरेंस की वजह से मिल जाता है.
बिल्कुल सही. एक अभी बहुत अच्छी बात किसी ने कही कि आपके देश के अंदर तो ये इंश्योर्ड है, अमेरिका के अंदर, यूएस में, यूके के अंदर फ्री दिया जाता है. तो बहुत अच्छी बात की कि हिंदुस्तान में केवल 3% लोग टैक्स दे रहे हैं. यदि हम सब टैक्स देने लग जाए तो शायद हिंदुस्तान गवर्नमेंट भी आप सबके लिए कर पाएगी. तो जैसे यदि हम जो पेशेंट के लिए देना पड़ रहा है उसके लिए हम सब रिस्पॉन्सिबल है, तो नहीं मिल रहा है उसके लिए भी हम रिस्पॉन्सिबल है. विद दीज वर्ड्स, thank you once again to all of you for sparing your very valuable time with us. Thank you Manoj, thank you Medtronic, and we would like to have one photograph. Thank you.
Thank you.
Very good.
As we conclude our insightful session on the AID symposium, we now turn our attention to our next topic, the teenagers. Please join me in welcoming our chairperson to lead this discussion, Dr. Suresh Purohit, founder, Sugar Doctor Medicare, Mumbai, Dr. Shardul Kothari, consulting diabetologist, Diabetic Specialty Clinic, Mumbai, affiliated to Somaiya Super Speciality, Sushrusha and Lions Hospital, Sion, and Dr. Aarti Ulal.
Good evening, everyone. So it's a very interesting topic for today, and we are going to talk about teenagers. So when I first heard this term, I was also a bit surprised. What is it? It's a combination of the two words seniors and teenagers. So how the elderly people who are more, want to be like teenagers can adopt to the newer technologies. So we have 3 lectures for this, and our first speaker for today
is Dr. Anil Veermani, who is a very senior consultant endocrinologist and is very well known in the field of diabetes and endocrinology. So now we are running short of time, so I will hand over or invite the speaker to start their presentations.
Can I have the Yeah, thanks to Dr. Manoj and Purvi for this excellent extravaganza. So from children with type 1, we'll move to elderly with type 2 diabetes. And not working? Okay. The topic is the drugs of choice in type 2. How should we approach the elderly? No disclosures. Well, age apace comes at last to all. As a wise man said, that the only way to avoid aging is to die young. And question is, who is old? If you look at the definition from National Institute of Health and the CDC, it's a large and a heterogeneous age span. Young old is 65 to 74, old is 75 to 84, and old is more than 85. So they have divided into 3. What happens with aging? What is the physiology? Peak body mass is attained at around 30 years, and since after that it starts deteriorating gradually. There is a slow progressive decline in the glomerular filtration rate from 30 years, even if the kidneys are normal or patient is not having any comorbidity. There is increase in the glucose intolerance because of the increasing peripheral resistance, falling beta cell function resulting from sarcopenia. And this prevalence of sarcopenia is around 13 to 24% in the age group of 65 to 70 years and shoots up to almost 50% in those who are more than 80 years. And sarcopenia and cognitive impairment go hand in hand. There is also increased incidence of atherosclerosis leading to hypertension and cardiovascular disorders. But the most important thing is with aging, there is reduced ability to afford, procure, chew, eat, and digest food. And all these factors affect glycemic control. So it's very important to know, classify the elderly according to the functional categories. Category 1 is functionally independent, no problems in the activities of daily living. Category 2 are functionally dependent. Subcategory A those who are frail, and subcategory B, those who have dementia. And category C is the end of life care, where the expected duration of life is less than 1 year. It is very important when you are trying to treat or manage these patients to classify them accordingly. Now, frailty in the elderly is characteristic of 3 or more, of which the most common and the first manifestation is exhaustion, then weakness, slowness, physical inactivity, and ultimately weight loss. Now, the diagnosis of frailty should not be used as a convenient way to withhold potentially effective treatments, but as a facilitate patient-centered care. That's important. Now, what are the special features of type 2 diabetes in elderly? Chronic hyperglycemia, progressive loss of renal function with age. Most of these patients, 25%, have heart failure, especially after the age of 65 years. There are various complications like MI, stroke, retinopathy, neuropathy. There is cognitive decline and reduced adherence to dietary recommendations. 2-hour post-glucose load levels, but not fasting, have shown a close association with increased risk of Alzheimer's, and the mean amplitude of glycemic excursions have closely been associated with mini mental status examination reports. So the management of type 2 diabetes in elderly is challenging. It is complicated due to the clinical and functional heterogeneity of old persons. There are various risk factors, as I said: aging, complications, comorbidities, hyper and hypoglycemia, and lack of social support. Then there are geriatric syndromes like depression, disability, malnutrition, urinary incontinence, falls, and cognitive impairment. There is pre-frailty and frailty, quite common, 40% and 15% respectively. And unfortunately, there is polypharmacy and increased risk of drug-drug interaction, ultimately leading to increase in mortality. Now, there are various medicine-related problems in the elderly. Polypharmacy is often there, inappropriate prescribing, not recognizing medicines as a contributing cause of certain signs and symptoms, presence of renal and liver disease, prescribing high-risk medicines such as insulin, sulfonylureas, and warfarin, those who are living alone, and cognitive functional impairment, and various sensory deficits like vision and hearing, etc. Now, medications, if you look at the medications prescribed commonly and leading to emergency hospitalization in patients with more than 65 years, insulin and oral anti-diabetic drugs are among the top. And it has been shown that severe hypoglycemia accounts for almost 20% of all hospitalizations of type 2 diabetes in the elderly. So what are these geriatric syndromes leading to factors which cause hypoglycemia? Of course, poor cognitive function leading because of sensory deficit and greater rate of decline increases the risk. Then there is impaired metabolic and clearance processes, especially altered drug eliminations, reduced clearance of insulin, etc. Counterregulation of hypoglycemia is impaired. Of course, polypharmacy I talked about, and presence of multiple comorbidities. So what are the basic recommendations for cognitive impairment? Because it is very important to first know what you are going to deal with. So at the time of diagnosis and at regular intervals, patient more than 70 years should be screened for presence of cognitive impairment using an age and language validated screening tool like mini mental state examination score. In fact, in US, now they have made it mandatory that all doctors crossing the age of 70 years should undergo a psychological evaluation. Regular screening for cognitive impairment and mood disorders is recommended, especially with residents with diabetes who are at high risk of undetected disease. Optimal glycemic and blood pressure control in elderly with diabetes can help maintain cognitive function and improve learning and memory. Prevention of recurrent hypoglycemia is very vital to prevent dementia. How do we and when do we test? Category 1, as I said, should be just like what we do in the adults in general. Category 2, those who are frail, they should be only when they are clinically indicated using simple procedures. In dementia, again, especially when antipsychotics are started, and in the end of life care, you need not monitor them regularly with A1C. Prevention of hypoglycemia is more important. So should we give high quality care to elderly? What is the rationale behind it? because screening and early diagnosis can prevent progression of undetected vascular complications. Overall improved metabolic risk can decrease cardiovascular risk. Improved screening for maculopathy and cataracts can reduce visual impairment. An integrated approach to management of peripheral vascular disease and foot disorders will obviously reduce amputations. The next question is how intensive should be the treatment with the elderly? And this was a wonderful study, the Japanese elderly diabetes intervention trial, and it showed that except for coronary revascularization, there is no significant difference in fatal or non-fatal events between intensive and conventional treatment. Another paper from BMJ, treating intensively may do more harm. They said that the benefits of taking diabetes medications are so small that they are outweighed by the minor harms and risks associated with treatment. The benefit decline with age, and by after 75 years, it is mostly harmful. While someone with type 2 diabetes who begins treatment at the age of 45 and reduces A1C by 1% may gain up to 10 months of healthy life. If the diagnosis comes at the age of 75, they may gain as little as 3 weeks. And whether giving insulin or 10 to 15 years of pills and therapy is worthwhile or not is a question to ponder. But there is a caveat, and this responds to those who have an A1C of 8.5% or less. Higher glycemic levels need to be treated, at least to bring it to 8.5%. That brings us what should be our goal. As I said, those who are healthy, category 1, the goal is same as the adults, 7% or less. Those who are having multiple comorbidities, we should be happy with 8 to 8.5%. And those who are at the very complex or end stage, we should not be bothering about the A1C. But as I said again, the aim is to prevent hypoglycemia. Of course, the basic lifestyle management applies here also. Healthy eating, being active, regular monitoring, encouragement for problem solving, reducing risk, and healthy coping. We must remember certain basic principles of medicine prescribing. Start with the non-medicine options first. Start with the smallest possible dose of medicine, preferably those with low hypoglycemic risk, and slowly up-titrate the dose. Use the lowest possible number of medicines to avoid polypharmacy, overtreatment, and cost of care. Simplify complex insulin regimens. Medicine plans have to be discussed in detail, not only with the patient, but the attendants also, the caregivers, including the risk of hypoglycemia. But most important is proper legible documentation of the treatment plan is mandatory, not only for the quality of life for the patient, but also for medical legal purposes. And at times, be prepared to de-intensify medicines depending on the risk-benefit ratio and the glycemic goals. Comprehensive review of medications the patient is taking is a must before starting any new medicine or stopping. Ascribe any new symptom due to medicine unless proven otherwise. At any change of functional status and ability to swallow as a part of the annual comprehensive review. Now, if you look at the RSSGI 22 guidelines, the latest guidelines, the population with the elderly population diabetes is increasing. They have put a strong emphasis on cost effectiveness and simplification of management strategies, motivational counseling, cognitive enhancement, social support, and tailored patient-centric treatment, and improving the subjective well-being and the quality of life being the prime goals. Physical activity, exercise, again, we know all the benefits, but stress management is important. Good sleep hygiene. We can use de-stressing mechanisms like meditation, music, social networking, grandchildren befriending, and all that. Sleep hygiene is very important, and miscellaneous steps, avoiding excess alcohol, self-medication, pollution, smoke, dust, and weather extremes. As far as the oral drugs are concerned, the drugs, metformin remains the first drug. Sulfonylureas, especially the short-acting ones, can be used in low dosages. We can use maglitides, alpha-glucosidase, pioglitazone, again in low dosage with caution. DPP-4 is a wonderful drug in elderly, weight neutral, renal and cardiac friendly, except for vildagliptin and chronic liver disease. SGLT2 inhibitors, according to RSSGI, recommended up to the age of 70 years, but I don't agree. I think that needs to be updated because now we have sufficient data to show that SGLT2 inhibitors in patients more than 75 years and those with frailty can lead to a decrease in cognitive and physical impairment, decrease in endothelial dysfunction, oxidative stress, and decrease in frailty. However, there is increased risk of genital infections and UTI in the elderly, so we need to take care. It's very important in patients with sarcopenia, the SGLT2 inhibitors should be used with caution because if you're decreasing the fat mass, the muscle mass is likely to go down also. Injectables have to be given very judiciously, starting low, going slow should be the mantra to advise to avoid adverse effects, and there should be careful education, monitoring, regular follow-ups, and that is the key to successful therapy. Now, this is a very busy slide, how to simplify insulin regimens, but I will just give you tips. Change timing of bedtime to morning. The basal insulin, if the patient is taking in the night, bring it up in the morning. Prandial insulin is more than 10 units. Reduce it, add non-insulin agents. If it is mealtime insulin is less than 10 units, discontinue insulin, and basically avoid, do not use rapid and short-acting insulin at bedtime. These are some of the important tips for insulin therapy. What is the role of technology? Let's see. CGM, insulin pumps, smart pens, and of course, the automated insulin delivery system that we have been talking about. They are very good. They have potential positive outcomes. They can reduce frailty. They can reduce risk of hospitalization, reduce cognitive impairment, etc., and improve the quality of life. But there is a caveat that you have to examine the patient, look at his age, limited digital literacy, cognitive decline and physical impairments can be a barrier to applying this technology. So it has to be considered after a careful and a comprehensive assessment of each individual, looking at multiple domains, including social setting and living. Training and education of the family members is very important. What about control in the end of life care? Is it futile or is it fundamental? Unfortunately, there is paucity of data as far as this age group is concerned or this cohort is concerned, but we must remember that hypoglycemia is the basic problem that occurs in these patients, so we have to be very careful about hypoglycemia. In type 1 diabetes, of course, insulin should be continued, but in type 2 diabetes, you have to make a shared decision making along with the caregivers and forget about A1C and be more alert about preventing hypoglycemia. So the take-home message, risk of diabetes increases with age. Management of diabetes in the elderly is challenging, primarily because of multiple issues, heterogeneity, medical, social, etc. Aggressive management has not shown any additional benefit. Management should be individualized. Regular monitoring of medication is very important to improve adherence and decrease drug-drug interaction. TPP4 inhibitors have shown to be overall benefits. Age per se should not be a limiting factor for using cardiorenal protective drugs like SGLT2 inhibitors and GLP-1 receptor agonists. And education regarding identification and management of hypoglycemia is vital. So friends, getting old is mandatory, but feeling old is optional. Thank you.
Thank you, Dr. Virmani, for the lucid presentation. Only one question from my side. What's your take on using combination OADs for elderly? Because lot of
as I said, you use single drugs, monotherapy, the lowest possible dose, that is better. Let the combinations be there for early onset diabetes where we want to have immediate good glycemic control to get the legacy effect. If you use a combination at the age of 70, 75, there is nothing, no benefit of any legacy effect that we are looking at. What we are looking at is to reduce complications. So the combination drugs will not, should not rather be avoided. That is, unless you have control on 2-3 drugs and you want to give an FDC, that is a different thing to avoid polypharmacy or to avoid number of drugs, number of pills. That is a different issue. If person is well controlled on 2 or 3 drugs, maybe 70, 75 years old, and he is in category 1, then of course you can give him the combination.
Thank you, sir. For our next talk,
we invite Dr. Abhay Sahu. He's a renowned endocrinologist in Bhubaneswar. He has multiple publications, posters, papers, and he has presented all this in national and international conferences. Over to you, Dr. Sahu.
At the outset, I'm actually thankful to Dr. Manoj and Dr. Purvi for inviting me for this beautiful August gathering and conference. So I have been assigned the topic bone health in elderly. So once we are discussing both health, as actually my previous speaker has already given hints that once someone is elderly, automatically a lot of bone diseases associated with age comes to play in the critical role. So once we are discussing bone health, it's of course critical concern for elderly, as aging can lead to decline in bone density, also they increase the risk of fracture. And osteoporosis, as we know, it is one of the most common disease which classically occurs in old age people. And not only osteoporosis, there is actually a lot of diseases which occurs in old age people. So I thought I will do some case-based presentation, so that will be easy and interesting for our audience. And this is, people see what are the factors specifically influencing the bone. Then first is most important thing is nutritional, that is calcium and vitamin D is utmost important. Adequate intake of calcium and vitamin D is utmost important for maintaining bone density. And again, those are elderly people, they should consume adequate amount of calcium and vitamin D to maintain that. Another most important thing is physical activity. So to maintain your muscle strength, so that this physical activity not only maintains the muscle strength, it helps in actually improving the bone density. We use certain medications that has detrimental effect on the bone. That is like someone is using steroid for other diseases, someone is using anti-epileptic drugs. There are certain drugs which has actually bad effect on the bone. So if you are using that, probably you have to take some additional precautions or measures so that we can actually protect our bone. Another is hormonal changes. Like we know that post-menopausal women, they are actually prone for developing osteoporosis. We know that once the body estrogen and progesterone come down, automatically there is significant increase in the bone loss, and that is one of the most important factor for particularly elderly people. And third, as I have discussed, the physical activity not only improves the muscle strength, not only improves the bone, again it helps in reducing the fall, because muscle strength improves, the fall reduces. Once the fall reduces, the fracture risk will significantly reduce in particularly elderly persons. So if we'll discuss what are the different type of bone involvement, we know osteoporosis I have already discussed. Then another most important challenging thing is osteoarthritis, because everybody say age-related change in the body. Osteoarthritis, multiple fractures, Paget's disease, osteomalacia, rheumatoid arthritis, various tumors, hyperparathyroidism, CKD, and different medications. So these are different, actually, how the bone is getting involved in that, the different settings or different setups. So let us discuss certain case. She is a 69-year-old female having pain in the lower back. She has lost few centimeters over last decade. Patient is telling by herself. And medical history says actually that is a premature menopause. You see at the age of 39% has developed menopause. So that is another important thing, that once someone is having premature menopause, probably the risk of fracture, the risk of bone involvement will be much more high. Since last 1 to 2 years, she's having actually pain in her legs and walking difficulties when running and walking upstairs. Also sometimes having cramps in the legs and hip muscles. So once you will see the investigations, everything is normal. Calcium, you will see calcium is 9.2, phosphorus is 2.4, serum ionized calcium is normal, serum PTH is normal, and vitamin D is also normal. So This is a typical case what we will get in osteoporosis. This is a typical case of osteoporosis where all hormonal evaluation will be normal, but patient will having actually bone loss. So classically we will see this is, we know that this is a systemic disease where there will be bone mass will be lost, there will be deterioration of the microarchitecture, and there is enhanced fragility fracture and also predisposed to different fractures. This is the normal, as I have shown normal bone. If it is osteoporosis or severe osteoporosis, the bone will be like this. And classically, we diagnose osteoporosis from actually DEXA scan. If the T-score is less than minus 2.5, it is more than minus 2.5, it is osteoporosis. If it is less than between minus 1 to 2.5, it is osteopenia. And if it is less than minus 1, then probably it is normal bone. So this is the T-score which actually plays a critical role for particularly diagnosis of osteoporosis. And if we see the male and female involvement, probably this is a female dominant disease. 1 is to every second female will be having osteoporosis. If we take male, probably 1 in 8 male will be affected, and 10% even normal population has actually showed some sort of osteoporosis involvement. These are the basic actually risk factors. As I have discussed, age is one of the major risk factors. On top of that, if someone is having early menopause, family history of osteoporotic fracture, these are also prone for actually osteoporosis. Again, certain endocrine disorders like thyrotoxicosis, Addison's disease, Cushing's, chronic renal failure, prolonged immolation, they also play a critical role. Lifestyle changes like smoking and alcohol, these are the two important things which plays a critical role in reducing the bone mass. And again, as I have discussed, long-term use of steroid, the various actually Tylantins, heparin, warfarin, they also can cause reduction in the bone mass. And the most important thing is majority people are asymptomatic. They don't have any symptoms. And if you see, they have actually, they might develop some backache, bone pain, or kyphosis or scoliosis or some sort of height loss. And this is like kyphosis what classically happens in them. And what are the indications? Who are going to screen in those groups? Probably those who are having women more than 65 years, postmenopausal women, male more than 70 years, having fragility fracture, history of fragility fractures, or certain disease conditions which warrants that you can go for this BMD thing. If you are having taken some medications, and also if someone is already on therapy for particularly osteoporosis, they also needs annually for particularly BMD checkup so that we can see whether there is improvement is there or not. So these are the indications. And there are various ways how we can measure, but the gold standard is actually the which DEXA is the gold standard. If we compare DEXA, quantitative CT ultrasound, probably DEXA is much more precision, much more reproducible, and also monitoring to response will be better with the DEXA, and it is very cheap. It is hardly 1,000 rupees is sufficient for particularly doing a DEXA even in the private setup. So it is easy to monitor from DEXA, and probably now it is easily available in the tier 2 cities also. And this is the prac scoring. Classically, we do from the prac scoring, we do the we can assess the risk for particularly for the this osteoporotic fracture risk. And there are certain, these are the certain baseline investigations for particularly if you are doing getting a osteoporosis, these are the certain baseline investigations one should do so that you can rule out certain secondary causes of osteoporosis from particularly from that. So this is second case, again 69-year-old male, having walking difficulties, hip joint pain, cramps in both the pelvis. Patient is a vegetarian and actually having a, since last 1 to 2 years, he's having pain in the leg, walking difficulties, running and also walking upstairs. So sometimes having cramps. And here you will see the investigations, all actual biochemical investigations, protein, albumin, everything is normal, but calcium is low. Ionized calcium is low, and percentage alkaline phosphatase is significantly increased, and PTH is also high. PTH is 268 is high, and 45 hydroxy vitamin D is low. So this is a classical case of osteomalacia in adults. So this is osteomalacia, it's quite typical case. But here I want to show if you are doing a DEXA, this is the left side. Even if in DEXA, you can get a low bone mass. So don't get confused that this is a case of osteoporosis. Your calcium is low, vitamin D is low, PTH is high. This is a case of secondary hyperpara. So, and if you are doing a bone scan, probably you will get multiple optics or multiple optics in a bone scan. So that actually gives a clue that if probably you are dealing with a metabolic bone disease, it's not osteoporosis. So this is the thing what you will get. So only calcium and vitamin D replacement will sufficient. You give adequate dose of calcium and vitamin D, that will take care particularly for those cases. Third case, this is a diabetic, hypertensive, hypothyroid. Patient is working as a teacher, having multiple trauma, history of OH intake, but people see the all investigations, everything is normal. There is nothing is there. Patient is having significant knee pain. So classically, what we see in the patient is obese, typical knee pain. So this is a case of osteoarthritis. You will see the plain X-ray. There is significant. There is bone space is significantly reduced. Joint space is reduced. So there is narrowing of the joint space, subchondral sclerosis, osteophytes. So it's a typical case of osteoarthritis, what we classically got in elderly people. So you have to, you will see this might be a primary osteoarthritis, secondary to, because those who are obese, they might have certain additional disease that can produce osteoarthritis. So for primary, old age itself, or some those who are obese, they can produce osteoarthritis, but for secondary, there is some degenerative joint disease, it can produce or that leads to osteoarthritis. So in both the cases, the most important thing is that they need imaging. What we do classically, a simple X-ray is sufficient. Of course, you can go for scanning, you can go for CT MRI to know what is actually the joint architecture, and anything additional thing is there, you can go for CT and MRI. The investigations classically is all classically you will get everything is normal in primary osteoarthritis. If there is some secondary additional disease, you might get something. Otherwise, it's an investigation, everything is normal. And usually they don't, there is nothing they can respond. You can give some sort of painkiller or calcium and vitamin D, but usually in the long-standing case, they need some sort of surgery for particular osteoarthritis. So you have to, this is one of the, again, old age bone involvement in that. Another most important thing is patient is having fourth case, 50-year-old person, low backache, pedal edema, weakness, fatigue, pain in the leg, drilling, and is a known case of CKD. So what type of bone involvement can happen? Here we know that renal osteodystrophy, that is actually, it might be a secondary hyperpara can leads to involvement of the bone, or there might be a adynamic bone disease, which actually the uremic toxins, they can directly act on the bone and they can cause the problem. So if you see, it is actually secondary hyperparathyroidism. Even if tertiary hyperparathyroidism can happen in them, and secondary hyperparathyroidism can cause significant bone loss, and that will be, it looks like similar to osteoporosis. And another important thing, as I have discussed, it is the adynamic bone disease. So this is secondary hyperpara. You can have bone pain, astralgia, pruritus, or bony deformities. They increase the risk of fractures, and there will be marrow fibrosis in those groups. And if you see the adynamic bone disease, this is the uremic toxins. They are responsible for adynamic bone disease, where you will get, there will be PTH will be normal, but still there will be bone thickness, the osteoid thickness will be normal or reduced, which distinguishes from the osteomalacia. Usually the PTH is normal, and there will be bone-specific alkaline phosphatase found to be low, and calcium might be normal or slightly elevated in those group of patients. So this is adynamic bone disease. In both the cases, there will be involvement from the kidney point of view. So this again, these are the old age problems or old age bone involvement. And this is the classical finding in the finding. You will see the bone histomorphometry, there is decrease in the bone formation and resorption, low PTH, diabetes, hypothyroid, all predispose for the adynamic bone disease. And usually there is, I have classically discussed that uremic toxins, sometimes the aluminum accumulation itself is actually one of the important cause, acidosis, then corticosteroid use, all those actually plays a critical role for particularly in CKD patients or those who are having post-transplant patients. So this is the, they can, in adynamic bone disease, I have shown that you can have calcification of the femoral arteries along with bone involvement. So this is one of the, again, different calcifications, ectopic calcifications that does happen in particularly in those group of patients. So my last case is a patient having pain in the knee, low back, backache, pain in the thigh for the last 8 months, occasional head reeling, headache and buzzing sensation in the ear. On examination, patient is having, everything is normal, but patient is having fixed flexion deformities, patient is having kyphosis, genuvarum and tibialis vara. And what baseline investigations we did, here we are getting ivory vertebra, and also there is a picture frame like vertebra. So classical, typically which is seen specifically in Paget's disease. So this is, we know that there is increased number and size of osteoclasts. It has three phases. One is osteoclastic phase, then osteoblastic phase, and then the burnt out phase. Classically, the patient may have bone pain, headache and hearing loss, pressure on the nerves, hip pain. There is joint cartilages getting damaged, so that leads to arthritis. And sometimes there is some vascular steal syndrome that happen in the skin. So sometimes there is typical, they can produce like transient ischemic attack. And sometimes the edge of the size increases. There occurs bowing of the limb with of the curvature of the spine. And these are the certain typical pictures of particularly osteoporosis, this Paget's disease. So usually it is treated with basically either oral or IV, particularly pamidronate, zoledronic acid, along, or sometimes calcitonin is given for short course of time. So as I have shown, these are the certain actually classical bone involvement in elderly. So the classical most important recommendations is consider calcium and vitamin D supplementation, specifically with dietary intake if it is insufficient. Regular checkup, particularly bone testings, helps in the monitoring the bone health and guides the treatment decision. And lifestyle modification, which encourage smoking cessation and so limiting alcohol intake, particularly that actually has negative impact on the bone. So maintaining bone health in elderly requires a combination of proper nutrition, regular exercise, lifestyle adjustments. Proactive measures can significantly reduce the risk of osteoporosis and its fracture and ensures better quality of life in elderly people. Thank you.
Thank you, Dr. Abhay. Any questions from the audience? So I think we'll have the next speaker. Next speaker is Dr. Amit Kumar De. He is consultant physician from West Bengal, Kolkata, and he specializes in diabetology, obesity, and metabolic disorders. Over to you, Dr. Amit.
So good evening, everyone. At the outset, my sincere thanks to Dr. Manoj Chawla and Dr. Purvi Chawla, and many congratulations to them for this fantastic conference. So I'm going to keep it very short, very crisp. We're going to talk about how technology and digital interventions can change the life of people in the elderly age group in the geriatric population. We had a fantastic session in the beginning with Dr. Partho, who said there are 4 types of people and how they respond to technology, but it's here to stay and we need to look at it, how it's going to change. So if you understand metabolic health, the topic that was given to me is about metabolic health. It encompasses multiple diseases and it leads to a lot of pathophysiological processes like endothelial dysfunction, atherogenic dyslipidemia. There's a lot of inflammatory change happening, and predominantly when you talk about metabolic disease, we're talking about diabetes, hypertension, obesity, metabolic associated steatotic liver disease, all in all, metabolic syndrome. So now, what is the impact of the metabolic disorders in the elderly population? There is a higher prevalence, and that is because of 2 age-related changes. One is, of course, the physiological decline, which happens, leading to reduced insulin sensitivity, decreased muscle mass, and increase in fat accumulation. And also the increased comorbidities that increases with age, with a higher risk of cardiovascular disease, stroke, and mortality. All in all, what this does is that it reduces the quality of life and it increases both the physical, the psychological, the social, as well as, most important, in a country like India, the economic burden of the individual and the person's caregiver. So now, if you look at the whole spectrum of the digital interventions and how it is emerging in the aspect of metabolic health, we are talking about telemedicine, which is a very important aspect of digital health, and of course, AI-driven tools to manage the health outcomes. But when you look at digitalization, we need to look at 3 very important aspects when we talk about its success. One is its accessibility. That's very important. And along with the accessibility, we also need to talk about its availability and affordability. Second, it's whether it is really impacting and bringing in improved outcomes. And of course, as I said, the affordability. The burden of metabolic disorder is directly proportionately increasing in the elderly age. Like, for example, 25% of the people with diabetes are 65 years and above. 75% of people aged 65 years and above will have hypertension, and there is a existence of obesity in 40% of the individuals in the geriatric age group. So geriatric problems and metabolic problems go hand in hand, and this is a burden that needs to be taken care of. So what are the digital health technologies? And this is an example, and this is a summary slide. As you can see here, first is of course the non-wearable, which are like your pulse oximeter, the blood pressure cuff, the weighing machines, your glucometers. Then comes the wearable, or which gives you a continuous monitoring. So this is where your wristbands and your Fitbits and even your continuous glucose monitoring comes. Then comes the one which is connected. So that's where the connected glucometer comes, which involves a Bluetooth technology and certain bit of connection. And then there is the another aspect called digital therapeutics, which are. So first let's look at the apps. And most often we are aware of certain apps which exist in the market. And there are studies on this that has shown that especially the weight management part can be done very well with terms of bringing changes in the physical activity, diet, and monitoring exercise, and also helping them in count their carbs, in calorie intake, and helping them in maintaining their body weight. The second one is telemedicine. And during the COVID times, we have seen the utility of telemedicine and telemonitoring, and we know how effective it can be. The question that we need to understand is how familiar and how comfortable are we as clinicians or healthcare providers with this technology of telemedicine, and how comfortable is the user? One very important essence of technology is that it has to be user-friendly. If it is not user-friendly, both the provider and the user will end up with fatigue. So that's an important point we need to remember. So when you're looking at people in the age group of 65 and plus in the geriatric age group with cognitive decline, the user-friendliness is very important in terms of the telemedicine platform. Now, there are the wearables, which is also, of course, important, which can help you in monitoring your heart rate, sleep patterns, the physical activity, and more. Again, it should not be leading out to some kind of a technology burden or a technology burnout, but a simple user-friendly device, which even a 65-year-old or a 70-year-old person can use, who's suffering with extensive Parkinsonism, would probably qualify being used in the geriatric age group. The importance of digital therapeutics is very important. And this is an evolving concept, and it's an evolving technology, and we need to understand this also very clearly. So it is predominantly software-driven interventions which are designed to prevent, manage, and treat medical complications. In a way, trying to bring certain kind of primordial or primary prevention and not just tertiary prevention. Now, this is important. When we talk about people in the elderly age group, we always think about damage control. But with the help of technology, you can actually have certain bit of primary prevention before even the damages occur. And that's where AI and tech can help you. So one commonest example is the use of digital therapeutics in behavioral mental health or in cognitive behavioral therapy. What are the benefits of using these digital health technologies in managing chronic conditions? We are talking about metabolic health. One is, of course, it can be accessible and it can be convenience, right from your doorstep, right from your home. You can have a layer of personalization and precision provided the data is being captured thoroughly and you're having a full insight and analytics of the data. There is always enhanced patient engagement because it involves a behavioral change in the individual. But again, as I said, it has to be cost effective for it to be powerfully impacting. So now, if you look at the whole spectrum of digital technologies which are available, the health and wellness, which is predominantly looking at these apps, which are mostly looking at preventive health. When you talk about patient monitoring, you're looking at continuous glucose monitors and even remote blood pressure monitors, which are actually bringing you therapeutic change. Then there is the care support, which requires connected care. So that is the Medication Management Act. So there comes the question of polypharmacy or pill mixing, which can be addressed, which Dr. Virmani was referring to in the previous talk, and the telehealth platforms. Digital diagnosis is something that we will be having, which will be predominantly powered by data analytics, and of course, artificial intelligence. This is where actually you can have a real-time assessment and analytics to have the primordial and primary prevention in a patient who has not yet developed a complication, irrespective of his age group and duration of the disease. And of course, digital therapeutics, which I just showed. So apps which are delivering structured education exercise program or cognitive behavioral therapy classifies as digital therapeutics. And this is personalized treatment. So the mobile health apps, the telemedicine platform, and the AI-driven interventions, if you can classify, these are the three places where you will find maximum interventions happening in the elderly with the help of digital platforms. What are the benefits? As I said, the first and important benefit is personalization. And that personalization is more going to be patient-centric, and that is the key. It has to be with the patient, the elderly individual at the center. Because often when we talk about best practices, what is best practice for us, for the patient, may not always be the best practice for the patient, because a lot of factor comes in. And of course, improvement in glycemic control, that is something which we have seen from the continuous glucose monitoring devices. And this behavioral therapy is going to bring in a lot of engagement in the patient and understanding of the disease. If you look at managing hypertension, you have the blood pressure monitoring, which can be Wi-Fi enabled for remote monitoring, and you have the virtual consultations, and that is the future where you can have AI-powered and data-powered virtual consultations with the patients that will enhance telemedicine as we go forward. What will it bring? Of course, if you're using digital intervention for hypertension management, it will bring an improvement of the blood pressure management. It will reduce in the hospital visits, and it will exclude white coats hypertension, the basic reason for which we do ambulatory blood pressure monitoring, and it will improve their adherence and satisfaction. Likewise, you can find a lot of wearables to be used in obesity management. You have the fitness trackers, the smart watches, and you also have the body composition monitors, which we use, which is of course a non-wearable device, but it also is one of the digital intervention that you can use for obesity management. These wearables can give you real-time feedback. This is very, very important. It will constantly act for motivational, and it will also make the patient accountable for his or her action. That brings the change. Now, if this has got a good interoperability, it can be integrated with the digital health platforms, and that can give real-time data-driven insights to the clinician and the healthcare provider through a closed loop, and that solves a lot of problems, which is a need gap in obesity care of weight regain and not being able to comply to the treatment. But then what are the challenges and the barriers? I mean, it's not always green everywhere, and there are a lot of gray lines that we need to look. Most important is the digital literacy. And this literacy is not just amongst the patient, but also amongst us, healthcare providers. The accessibility to technology. So we have to be very realistic. Somebody in the rural area might not have a 5G connection to have a real-time data sharing. So we have to keep that in mind. And adherence. And we must also make sure that we're not overburdening the patient with technology so that they suffer from technology burnout. We talk about virtual AI chatbot, and in all my talk, I try to give you guys something which we keep on developing and improving. And this works on the concept of just-in-time adaptive intervention. What does this mean? It means that when you make the right behavioral prompt to the patient at the right point of time, you're supposed to be getting a motivation in that individual, and that brings you a long-term clinical outcome. So you will find that in terms of predictive analytics, so artificial intelligence will be used in a big way in terms of predictive analytics. So you have your glucose monitors, you have your insulin pump, you have your retinopathy screening, you have the CGM Guardian Connect. These all have artificial intelligence. It can give you personalized healthcare recommendations. And this is something, a tool which we developed called Madhu AI, and I'm going to give you an example how you can use it for elderly patients. And it can give you a lot of personalized patient education as well. And of course, AI-driven solutions being a real-time monitoring and a personalized care, it can give automated monitoring and feedback. Feedback to whom? Not just to the patient, but also to the healthcare provider, again, closing the loop. What are the benefits? It will bring precision and accuracy in treatment, a real-time precision care, efficiency in healthcare delivery, also making it more cost-effective, and increased scalability. That's the biggest advantage of technology. You can scale it up to n number of times. So if most of you would be familiar with what we have, Madhu, I'll just give you an example how an elderly patient can benefit with Madhu. So the biggest problem that an elderly patient faces is pill mixing and polypharmacy. So this is something which we have just released it today, and I'm happy to release it here. You can upload a PDF in Madhu, which is a WhatsApp integration of AI. And this is for an elderly patient. So this is a prescription which I uploaded, and I'm just giving this is an instruction I'm giving on WhatsApp at Madhu that I'm a 61-year-old patient, and can you help me understand the prescription? So this will take a little time. Just allow it a couple of minutes to generate the response. I won't be able to forward. So you can see the response which has come. So now it took the whole prescription And it has, first of all, summarized the prescription into the name of the drug and its essential generic name. It has given also about the dosage of the drug and what the purpose of the drug is. So now you have a geriatric patient visiting a cardiologist, a nephrologist, an orthopedic surgeon, etc., etc., and then comes back to the diabetologist. There is going to be pill mixing and overlapping of drugs. So this will give a lot of insights to the patient. Now, you might ask me that the patient may not understand English. So let me ask Madhu to convert this into my regional language, Bengali. And what it's going to do is that it's going to summarize this whole thing, and you'll just see that come up on the screen in maybe about a few seconds. You will see that the whole thing has been summarized in Bengali or in any language that you want to work in. I mean, Peter tried this in German, some people tried it in Korean, Chinese, it works. So this is the power of using AI technology. It simplifies a lot of those problem gaps that we're trying to solve. Most importantly, what this is doing is it's giving me why this drug has been prescribed. So for example, most of the time our patients may think this medicine is number 8, the statin is at number 8, means it's not very important, and the pantoprazole is at number 1, which means it's very, very important. So at least I understand here the importance and the rationality of why my doctor has given me this. This would probably have a lot of impact in the cognitive understanding of complex prescriptions, especially in the elderly age groups. So this is just one example. So the integration now needs to come. It's not only digital, we need to have a phygital mode, so physical plus digital. So you will have to have a hybrid care models where interoperability with seamless integration and integration of data, that is very important. Data and tech literacy at all levels, healthcare provider, doctor, and patient, and a collaborative approach amongst the healthcare provider. This is going to bring us this integration. It needs policy regulations, data privacy, approvals, regulatory standards need to be taken in. And this is possibly what we will see in the future. An elderly person will definitely get AI-powered diagnostics. As I said, it will require a lot of AI integration, and that's where precision care is going to come in, which is going to actually be advanced predictive models for metabolic health. Do not be surprised if you're using an Apple Vision Pro, which is a virtual reality. In rehabilitation and mental health, it works in cognitive behavioral therapy with immersive virtual reality experience, and you can have a similar telemedicine 2.0 with a much more AI-powered and much more user-friendly experience for both the user and the provider. We have a community called Doctors AI, and these are some of our visions at Doctors AI. What we're looking at the future in healthcare is personalized medicines with genomics and AI integration. So that's nutrigenomics, pharmacogenomics. Again, that's where precision care comes in. We feel and we hope, and this is one of our mission, to increase the adoption of wearables, not just across the medical fraternity, but also across the user fraternity. There should be greater focus on preventive care in the elderly. Just because they're old doesn't mean they're damage control. We can have preventive care programs for them. Most important, improve literacy on digital health amongst healthcare providers. That's one of the key roles of Doctors AI. So I'll invite all of you, please join us at the Doctors AI Global Summit, which we'll do. It's a virtual summit. We have a very small registration amount of 500 rupees till 15th of September as an early bird registration. We'll request all of you to please join us. It's going to be a 2-day of talking about AI and tech across the healthcare spectrum, not just metabolic. Thank you very much.
Thank you, Dr. Amit. And as you said, adapting to technology is the way forward. All of us, healthcare workers and patients, whether elderly or young, have to do that. Any questions from the audience? Then we'll wind up the session. Back to the organizer.
Yes, sir. Yes? Can I have? Okay. This one? Yes. So that's where technology burnout can be. This one? Yeah? No, it's not. But again, all the images which you see here are all AI generated images. Each of the images which you have seen in this presentation. Yes, technology burnout. Yeah. But then that's where again AI comes to the rescue, where you can have speech to text conversation, and that thing can be auto-populated into the electronic health. Thank you very much.
So we can close this session now. So speakers, you can come on the dais for a picture.
Thank you, Doctor, for the insightful session. I would now like to welcome our chairpersons, Dr. Rakesh Sahai, Dr. Debashish, and Dr. Ketan for our next Endo Diabetes Symposium.
So, good evening all. Let me invite Dr. Ashur Rastogi, who's an associate professor in the Department of Endocrinology at PGI Chandigarh, and he has more than 120 papers published in various indexed journals. He's won several awards, including the best research paper from on the PGI Research Day 2021, the B.R. Srivastava Oration of RSSDI, the A.R. Seth Award, the Endocrine Society of India, and the Young Investigator Award at American Association of Clinical Endocrinology in Philadelphia. So he has many more awards to his credit, but
We can leave.
yeah, so I would like to invite him to speak on tricky thyroid situations, I suppose. What was the topic is?
So I'll just, this is more of So I'll just give you 6 cases that can tell you. And I like your participation into this. Elegant. Yeah. So T3 is 1.6. I have just given you the reports also. The normal range is between 0.9 to 1.7. T4 is quite high. Normal range is still 11.9 and TSH is quite low, 0.001. So what is the diagnosis? Sorry? Boss, आप तो बता ही दोगे. So whatever. देखते हैं सब acute thyroiditis है नहीं है. So she was started on methimazole. That is expected because she was having low TSH. The problem is that something is glaring in the report that T3 is high normal, but it's not increased. It's only the T4 that is increased and TSH is low. Okay. So we have to carefully see what is the background history and what was missed before starting methimazole. In this patient, when she was asked, she had fever.
And she had fever around 4 weeks back, and probably it was some viral URI. TPO was not done in this case, so TPO should have been done. The TPO was negative, history of some viral URI. So we got a technetium uptake, and technetium uptake was suggestive of 0.5% uptake only. And you can see this is the uptake, almost negligible uptake in the thyroid. So these are the salivary glands, and below that, hardly any uptake is seen in the thyroid gland. That suggests that this is not Graves' disease. This is not hyperthyroidism. So it is thyrotoxicosis without hyperthyroidism. So this is likely to be subacute thyroiditis. Because what happened in Graves is, you can see the Graves, the uptake is 30.4%. Both of the glands are taking lot of uptake of technetium, which is very characteristic of Graves' disease. So what is said that if you are having a technetium uptake of 1.55% more than that, it's likely it has a very good specificity of 87% to diagnose hyperthyroidism. So remember, even simple TFT reports can lead you or mislead you to overtreat these patients, and this patient does not require hyperthyroidism medications. So this is the chapter that we wrote in one of the thyroid textbooks, just to differentiate subacute thyroiditis from other causes of the neck pain and hyperthyroidism, that is sporadic painless thyroiditis and acute infectious thyroiditis. So whenever you see a patient of thyrotoxicosis, remember that SAT possibility, that is subacute thyroiditis. Usually these patients have high ESR, though normal ESR may be seen, but normal ESR, if the patient is having neck pain and hyperthyroidism, then it's very unlikely that patient is having SAT. Antithyroid antibodies like TPO in our patients was negative, so it is usually seen in patient with SAT, and low radioiodine uptake is very characteristic. If you are having a technetium uptake less than 1.5% or 2%, it is suggestive of SAT. So what you need to do in this case that I showed you, no role of any antithyroid drugs, just clinical course is self-limited. Yes, you can give some NSAIDs, paracetamol for neck pain. Yes, if the patient is having some features of thyrotoxicosis, like our patient had tremors or palpitation, you can give beta blockers. So that's the only treatment that the patient needs. Otherwise, she doesn't need anything. So now we'll go on to the second case. Interesting, another case, a 35-year female. She presented to an endocrinologist. She was having primary infertility, and she was having on and off menorrhagia. Her BMI was okay. She was relatively lean, and she was known case of hypothyroidism for past 10 years. What is glaring in this history is that she was on levothyroxine of 175 microgram. She is lean. Her weight is hardly 50 kgs, but still she is requiring 175 microgram. So what is odd is, this is the present thyroid function test. You can see still even on 175 microgram of levothyroxine, her TSH is high, 35. Normal is less than 4.5. T3 is low normal. The lower range is 0.9, and T4 is 4.8, that is lower than the lower limit of normal. So that suggests that this patient is not properly controlled, even on very high doses of the levothyroxine. So once we took the history, so 10 years back, she was started on 25 microgram, but gradually the dose was increasing. Her weight was not increasing, but the dose was increasing over the years. So what do you think is missing in this story? Why she is requiring so high a dose? Okay, so one thing definitely is, the first thing is compliance. The compliance was checked, even the preparation was checked. So she was taking the medication properly. She was taking in fasting condition, and exactly possible. So why uncontrolled hypothyroidism? Requirement of very high doses of levothyroxine to normalize TSH. So first is maladministration, as Dr. Abhay was saying. So patient definitely has to take levothyroxine medication empty stomach, especially if some people take coffee in the morning, that should be avoided, and certain medications, especially many of these patients take PPIs, pantoprazole in the morning, along because it is taken fasting. That should be avoided. But what was important in this patient was malabsorption syndrome. So this patient was also having celiac disease. So remember that levothyroxine is absorbed in the first part of duodenum, even the second part of the duodenum, and celiac disease predominantly affects this part of the gut. So if patient is having celiac disease, the dose of levothyroxine would be high. Another condition is achlorhydria and lactose intolerance. If the patient is on some antiepileptics, it might increase the metabolism of thyroid drugs, so patient might require higher doses. And last is, remember that I mentioned that this patient was having primary infertility. So she was receiving IVF treatment and she was on this GnRH for this, and that can increase estrogen concentration, which can increase the overall T4, but in this patient the T4 was low. So you can have a free T4 which is low in these patients, so they would have uncontrolled hypothyroidism in these patients. So she had multiple reasons for increasing dose requirement. One was PPI, second is drugs, and third is she was TTG IgA positive and she had celiac disease. And that was the main reason for uncontrolled hypothyroidism. So in few of the patients, when we see that these patients can have malabsorption syndrome, they say that I am very regular, the preparation is fine. Then we do thyroid absorption test in these patients. So in thyroid absorption test, what is done is that we give this levothyroxine to these patients. Usually it is given early in the morning and in the empty bladder. And then we collect blood samples for free T3, free T4 and TSH at 30 minutes, 45, 60, 90, 120 minutes. And then we collect the blood samples. So usually by giving this levothyroxine, usually it is given around 1.6 times the body weight into 7. So suppose patient is on 50 microgram daily of levothyroxine. So what you do, you just multiply by 7. So 350 microgram of levothyroxine is given to a patient and you take the blood samples of this patient for this free T3 and T4. So you can have many things. If TSH normalizes, that means whatever drug you are giving, it is absorbed and it is normalizing TSH. So that means there is something else other than the non-compliance thing. If the inadequate free T4 rise is seen after giving so much dose of levothyroxine, then it suggests that possibly patient is having malabsorption or celiac disease. Because even after giving so much dose, TSH is still high. And if the free T4 rises after giving this post-thyroxine, but no change in TSH level, you should have to consider the dose adjustment. That means patient require much higher doses of levothyroxine. Third case, another interesting case. This case is a pregnant woman who comes to you with a 10-week gestation and she has this TFT report in her hand. Her TSH is low, it is 0.01, T3 is 1.21 and her T4 is 11.2. So seeing TSH, the physician advised to start antithyroid drugs and she was started on propyl thiazide. So what do you think? This is the right treatment? Exactly. So we got the answer. So probably we should know what is the normal range of thyroid function test in first trimester of pregnancy. The normal range at gestational age less than 16 weeks is TSH can be from 0.04 to 3.19. Even 0.05 is the normal range of TSH in first trimester. You can have high T4 also and range can extend from 10.9 to even 17.9. So never over treat your patients of pregnancy if they are coming with thyroid function test report, and that is all because of SCG. So any abnormal TSH value should be evaluated along with total T4. Another case, a 25-year-old female who presented with a 4-year history of tremors, palpitations, and episodic diarrhea also along with weight loss. That means she was having symptoms of thyrotoxicosis. She had gradually increasing swelling in the neck along with headache, which was for past 2 years. T4 was high, T3 was high, but TSH is not low. Now what is the cause? What is the diagnosis? Sorry? Some tumor, definitely it can be some tumor, that tumor secreting TSH. TRH, that is also a possibility. So tumor secreting TRH. So let's see. Extremely rare. Thyrotoxic. TR beta mutation. So important is that this patient is thyrotoxic. Again, she also has a goiter. So she has a goiter, she is thyrotoxic, but TSH is still high. So it can be RTH or central hyperthyroidism. So as he rightly mentioned. So this patient was having tumor. You can see the pituitary is showing a large cellular mass in the pituitary, and the only treatment for these patients is optimize the patient and remove the tumor. We did surgery and it was suggestive of the tumor cells showing a lot of cytoplasmic TSH positivity was seen on immunohistochemistry. This patient was published. And after surgery, you can see post-op day, her TSH gradually reduced and T3, T4 also reduced. So this is a patient of TSHoma. So TSHoma causes secondary hypothyroidism by secreting TSH. Not all patients who are having TSHoma will have hyperthyroidism because this might be inactive TSH. So TSHoma is important that it occurs both in male as well as in female. In surgery is the first line of treatment. Just two more cases. Another case, he was a 51-year-old male who had persistently high TSH despite increasing dose to 300 microgram of LT4. His T3 and T4 was not done during titration and he was clinically euthyroid. Just TSH was being chased. His TSH was 30, 40, 50 and dose of levothyroxine was continued to increase. When the T4 and T3 was done, the T4 of 15.3 that is high and T3 is again high. What is the diagnosis? No. This is supraphysiological again LT4 requirement to normalize TSH, but it is leading to increased free T4 and T3. So this is a patient who was relatively euthyroid and this is a patient who is likely to have resistance to thyroid hormone. So this is RTH. So you can have these kind of possibilities. You continue to give levothyroxine of 300 microgram, but still the patient TSH is not being controlled. So this is RTH. Sorry? This patient is euthyroid. We did not to treat anything. Just wait and watch. So these patients later on can develop osteoporosis. So that is the thing in these patients of RTH. This is the last case regarding, I'll just show two pediatric cases. This is an 18-year-old female who presented with acute abdomen 3 years back before coming to our hospital. She underwent oophorectomy for this acute pain. It was a torsion of the ovary. She remained undiagnosed and untreated because she was maybe by gynecologist for the ovarectomy was done. But 1 year back, she had headache with vision loss and MRI was showing cellular and supracellular mass and she was referred to the neurosurgeon. This was the mass in this patient. So remember this, she had two things. One, she had an ovarian mass, torsion, it was removed. Again, then she developed a cellular mass. She was sent to a neurosurgeon, it was removed. On examination, what was problem is that she had severe short stature, -5 SDS, dry skin, delayed DTR, but she had no goiter. She had palpable mass at the umbilicus and she had very low T3 and T4 and very high TSH. You can see of 1104. Anti-TP was positive. So this is a USG of the abdomen and you can see a large multicystic ovary, very large big ovarian mass 3 years back. So this is simply a case of primary hypothyroidism with multicystic ovaries. Unfortunately, it was removed. Patient also had a thyroid of hyperplasia, so it was a cellular mass. So what she required, just because she was hypocortisolic also, she required hydrocortisone and levothyroxine and gradually dose was increased and she was fine. So this was reduction in the size of the cellular mass just by levothyroxine. And you can see this abdomen imaging, there is no ovarian mass now and that is because of levothyroxine. So this is the last case. This is a child, 2.5-year-old child who presented with progressive enlargement of breast. So it was probably precocious puberty. She also had vaginal bleeding at 2.5 years of age. Her height was less than 3rd centile and she had bradycardia, heart rate of only 70 per minute and B3. You can see the bone age is 2 years and LH is only 0.07. Prolactin is high, T3 and T4 is very low and TSH is very high. So this is the case of, you can see the B3, just 2.5-year-old girl who is having the precocious puberty and she was having the cellular mass. You can see in pituitary there is a large cellular and supracellular mass. So this is again a case of hypothyroidism causing the GIPP or gonadotrophin independent precocious puberty with a cellular mass and delayed bone age. So childhood hypothyroidism can be Hashimoto's, which can lead to GIPP, that is gonadotrophin independent precocious puberty and thyroelectrophore cell hyperplasia. So just need treat with levothyroxine and her breast regressed and her height improved and she was fine. You can see complete disappearance of tumor mass without any surgery, just by simple levothyroxine. So this is the prior MRI and this is the recent MRI. Everything was normal. It just needs a careful evaluation. So this is just, I want to show you that thyroid disorders are very common. Symptoms can be non-specific. Evaluate a patient thoroughly because TFT reports can sometimes very erroneous and you have to dig into these TFT reports. Thank you.
Then we have the next speaker amongst us is Dr. Narsingh Verma sir. Sir is the principal and dean of Hind Institute of Medical Science at area Sitapur, and very importantly, sir is going to talk about pharmacovigilance and he is going to guide what exactly the physician should do. Over to you, sir.
Organizers, especially Dr. Manoj Chawla and Dr. Purvi Chawla, for giving me this chance to talk about the pharmacovigilance and why it is important for the physicians. I will be talking about that. And not moving. No issues. Thank you. So, pharmacovigilance, I will be talking. And what is pharmacovigilance? According to WHO definition, the science and activities relating to the detection, assessment, and understanding and prevention of adverse effects of drugs and drug-related problem is under the pharmacovigilance. And the aim of pharmacovigilance is to the entire life of the drug before coming to the market and even after in the market, that what in the collecting the data regarding the analysis and during the drug development, all the monitoring data that is required so that various ADRs can be detected. So basically the data is required, then the detection of data and the prevention of various ADR is our motive. And if you see risk benefit ratio, this is very, very important regarding the balance of medications. So if you say medicines are safe, no, medicines cannot be very safe, and approved medicines are safe, again, we are not very sure about it, and no medicine is safe, again, not very sure about it. So no medicine is without risk. Definitely medicines have some risk. This must be clear to physicians that medicines should not be used as a first resort. That is why we need risk-benefit balance of medications. And here, if the benefit is more and risk is less, then this medicine is acceptable. And if the risk is more and benefit is less, definitely it is not acceptable. So there are three main subspecialties of the pharmacovigilance. First is the surveillance. Surveillance is towards the risk management and signal detection. Through this mechanism, we try to find out various adverse reactions, and the reports are required, and the drug clinical research with the periodic benefit risk evaluation reports, and on the basis of that, we try to find out that what are the various defects available for the particular drug. And then the operations. Operations focus on collecting and recording information during preclinical development of the drug, and that is included in the first phase and second phase trials as well, and various ADRs are reported, and then various SOPs are developed to find out and how we can reduce them, and finally the systems are there to see that whether the particular drug development has passed all those three or not. Then if we remember this particular learning from the history, I think everybody here knows about the thalidomide disaster, which occurred in 1957. As a tranquilizer, the drug was developed, and the first report of birth defects came in 1959.
and 13 reports of birth defects in 1961. And then the drug was withdrawn, and by that time, the 10,000 infants affected by the phocomelia. So that was a disaster that gave us a lesson that various things are required for the drug development so that a safe drug can be developed. And it is very, very clear because at that time even, the no teratogenicity detected in testes during clinical trials and prior to launch. That is why the more surveillance is required, not only during development, even after the post-marketing. So why it is necessary in public health? It is necessary because of the region 1, that is humanitarian concern. Insufficient evidence of safety from clinical trials, animal experimentation, and phase 1 to 3 studies prior to marketing authority. Definitely this is a region that we need pharmacovigilance. And the second is that we know that clinical development of medicine passes through all these mechanisms. One, before the development of drug, the animal trials and the human trials, but here the human trials require very few numbers. And then the phase 1, after phase 1, the phase 2 trials, again the numbers not very high, and then the phase 3 trials, and after that the registration for the drug occurs, and after the registration the phase 4 trials are there, and then the drug is in the market. Post-marketing surveillance is also required, because by that we will be able to know whether the drug is safe or not. So various ADRs come to us only after the post-marketing surveillance. And you all remember that when the thiocolchicine was marketed, at that time, the various ADRs were not known, but after that, we were able to detect various ADRs. So limitation of clinical trials is that here the number is small and patient number is low, and the restricted population of patient, age, sex, and ethnicity. We do not include all ethnicity and all age groups, and the narrow indications are also there. That is why the limitations of clinical trials are there. We cannot say on the basis of clinical trial that that is absolutely safe. And also, it is short duration of drug exposure. So sometimes it happens that that is not enough, and that exposure is not enough to show the various ADRs. The reason 2 is medicines are supposed to save lives, but dying from a disease is sometimes unavoidable. Dying from a medicine is unacceptable. That is why we need a good surveillance and to find out all ADRs. Reason 3, ADRs are expensive. Cost of the drug-related morbidity is very high. That is why we need good surveillance so that ADR could not happen. Reason 4, promoting rational use of medicines and ensuring public confidence and ethics to know of something that is harmful to the body. We must know it. That is why the surveillance is required. So pharmacovigilance is needed in every country. Every country has a different type of population. That is why the pharmacovigilance of one country is not for the other country. We need it for different populations as well. That is why pre-marketing surveillance is there, and studies are conducted to evaluate first the safety and second the efficacy of new compound in humans, before that animal studies, and then the post-marketing pharmacovigilance is done to find out various ADRs which were not detected previously during the pre-marketing development of the drug. So if you compare the pre-market and post-market safety data, you will find that limitation of pre-market clinical trials are there. In pre-clinical trials and the pre-market clinical trials, everything cannot be found out. That is why the post-marketing safety reporting is more important. And in the post-marketing safety reporting, we are able to find out more ADRs in relation to pre-market. That is why more time is required, and post-marketing surveillance is more important for all the drugs. WHO programs are there to find out that, and the WHO has established various organizations and sub-organizations for this particular purpose, and the functioning of these organizations are there to find out more and more ADR, and strict surveillance is being done. And not only that, in various countries it is required because the different population is there. In India also we have that particular setup, and almost every medical college has this pharmacovigilance reporting, and the basic, this all is done from the center at Ghaziabad, and we have different 4 centers all over the country for the pharmacovigilance program in the particular country, especially in India. And not only that, every medical college, every good hospital and private center do have the pharmacovigilance property. By that, we are reporting various ADRs, and we have been able to strengthen this particular safety procedures. So important terminologies in the pharmacovigilance, the side effect and adverse drug reactions versus adverse events. They are not same. They may look like same, but they are not same. Side effect is a response to a drug which is unintended and which occurs at doses normally used in man for prophylaxis, diagnosis, or therapy of disease. While adverse events are the any untoward medical occurrence in a patient or clinical investigation, subject administered a medicinal product and which does not necessarily have to have a causal rational relationship, while the ADR do have the causal occurrence relationship. That is the difference between the side effect, adverse drug reaction, and adverse events. So not only that, even the medication error can also occur, and the medication errors can be on the part of the patient or part of the other suppliers as well. So that is another thing, that the medication errors can also be included in that. Not all medication errors lead to adverse outcomes, but some of them can lead to adverse outcome as well. So if we see medication errors are having a large number, and then adverse drug reaction and adverse drug events. So it is not only that the adverse events are there, maybe because of some errors while taking the drugs. A validated reason is that identifiable patients and identifiable drug that is required, and identifiable reaction, then only we can say that adverse reaction is occurring, and it can be said that it is because of the particular drug. So serious ADRs, they are there, and they are termed as serious when the life-threatening event is there, or hospitalization is required, or a disability has occurred, or death, or even the medically important event has occurred, then we say that it is serious ADR. Other ADRs are non-serious in nature if they are not doing all these things which are mentioned here. So who should report the ADR? All healthcare professionals should report ADR if they are finding it during their uses of drugs, and marketing authority holders can also report ADR. The patient and the relatives can also report ADR. Sometimes they are reported to the patient as well. Nurses even and other health professionals can also report ADR, and the pharmacist even can also report ADR. Not necessarily that every time doctors should report it, because sometimes patients are reporting that this is happening, and by that we should report them. So report is there, then the events are there, the data entry, then only regulations come that particular ADR is because of the drug. So we can conclude that the pharmacovigilance is used to detect, assess, understand, and prevent the adverse effect of medication. For that very purpose, the pharmacovigilance is required. The need for safety monitoring has evolved around unfortunate incidents in history, with death caused by anesthesia and congenital malformation that occurred, like I mentioned about the thalidomide disaster. So by that we have learned that the safety of drug is more important. In this relation, if you remember in the most popular book of the pharmacology, which has mentioned that every drug is a poison, every poison is drug, depending upon the doses. On that motto, we were able to find more and more ADR, and the reporting has been done. And after that, we have been able to save so many lives because it is occurring because of the drugs as well. So clinicians play an important role in the recognition and reporting of ADRs to national pharmacovigilance centers. The centers are already there. Every medical college had those centers, and even the good private hospitals have those centers, and clinicians must report the ADRs. The purpose of NPCs is to make the clinicians understand their functions, including the monitoring, investigation, and assessment of ADR reports that is required, along with periodical benefit risk assessment of medication via multiple sources, whether the drug is purposeful and it has more benefit rather than having risk. So take home message is that what clinicians can do in relation to pharmacovigilance, that clinicians play an important role in recognizing and reporting ADRs so that NRCs can regard and evaluate these concerns. Because if they are not reporting it, the NCRs cannot find it. And not only that, they can take in the regard actions and to maintain the patient safety associated with the use of medicines. Serious reports should be submitted as soon as possible, while the mild reports we can have some time before reporting or more observation before reporting, but the serious ADRs had to be reported immediately. So thank you very much.
Thank you, Dr. Verma, for a very nice lecture on the pharmacovigilance. We will take questions at the end of the session. Thank you, sir. Now we have this next session by Dr. Brij Mohan, very senior physician from Uttar Pradesh. He has been members of many professional bodies. He has been the past vice chairman, UP chapter RSSDI, past president, UP Diabetes Association. And I think most of you know him, a very renowned figure in the field of diabetes and medicine. Sir, please.
Thank you, Manoj and Purvi, for the opportunity. And thank you, chairpersons, for giving the introduction. My job is to tell you about new fixed dose combinations in India. The fixed dose combinations I am going to talk about is only and only for glycemia control. Not beyond that. That was the topic given to me by Manoj. And this is lay newspaper headlines on 23rd of August 2024. It said that 156 drug combinations have been banned, and it says that fixed dose combinations are like cocktail drugs. Everybody knows that cocktail is more effective than otherwise taking alcohol. And this is what expert committee says, that FDCs are irrational in this regard, and there is no therapeutic justification for ingredients contained in these FDCs. But none of these FDCs which are banned are of anti-diabetic drugs. Now coming to Indian market of FDCs, it is overwhelmed. आज की डेट से नहीं, जब हम लोग पढ़ते थे, डॉक्टर बताएंगे कि कितने सारे एफडीसी उस समय भी आते थे. आज की तो छोड़ दीजिए. India's market of diabetes care is flooded with FDC. Dr. Virmani will agree that there used to be combinations from the student life when we were student. Many variety of FDC was there. More than 50 different FDC in diabetes care. Brand proliferation is there. एक ब्रांड आता ही है, एक कंपनी, तो proliferate होने लगता है. More than 500 different brand names are there, and that is more confusing to the clinician. Now, this is a big question. Are FDCs necessary for Indians? Probably yes. We Indians are different. Asian Indian phenotype. We take high carbohydrate and low protein diet as compared to Western counterparts. High metabolic load due to Western lifestyle. We have changed our lifestyle from Indian to Western. Impaired secretion of GLP-1 is there, and there is enhanced DPP-4 activity. FDCs, what are the guidelines for initial combination? This is only for initial combination therapy, and this is ADA 2023, which says this is level A recommendation that early combination can be considered in some patients at the treatment initiation to extend the time to treatment failure. And this is ACE, and our own RSSDI says that more than 1.5 of HbA1c above the target is indicative of starting a combination therapy from the beginning. Now, what are the advantages of FDCs versus separate medications? Complementary mechanism of action. The drugs can be combined. There is no doubt about it. It gives a cocktail effect, improves adherence and treatment outcomes, reduces medication error by the patient, reduces pill burden, and it is of lower cost. As you increase the drugs, the cost goes up. Better control, maybe reduced complications. And there are trials for that adherence and treatment outcomes are better with combinations of FDC as compared to separate medications. Good FDC, how to choose? They should have different mechanism of action. Similar pharmacokinetics should be there. No additive causing supra-additive toxicity should be there in combinations of FDC. Follow treatment guidelines and that addresses the concerns. That is very, very important. Disadvantages of FDC are there is no dosing flexibility. We all face day in and day out. Drug interactions may be there. Incompatible pharmacokinetics if FDC is irrational, as many of today's FDC used for hyperglycemia management are. Need to discontinue if there is allergy to one of the component of FDC, and difficult final dosing titration is there. That is the disadvantage. Current status of FDC in India. In India, FDC are widely used. Many combinations are irrational. Many, I'm not going to name them. FDCs are produced without any bioavailability study by majority of company of individual component of FDC. Many FDCs were produced in the past by companies without approval by DCGI. That is there in India. Many times international drug regulator expressed their concern about quality of FDC drugs in India. What is the evidence of FDC in India? There is no evidence to back up India's best-selling diabetes drug. This is a report from in 2018, March 9. And this was done to determine efficacy and safety of 5-metformin FDC. And we used PubMed, Embase, and Cochrane Library database. 25 publications eligible for inclusion. Only one trial which involved only 40 patients and just lasted 2 weeks. None of the 25 trials met all 4 WHO criteria for FDC. That is the status of FDC in India. Growth of unjustified FDCs in India. In 2007, there was a directive by DCGI to withdraw 294 FDC, but state authorities approved it. So that is the discordance between central authority and the state authority. That is always visible in all the matters. 2012 report, CDSCO was criticized for neglecting public health. This is 2013 committee where recommendations were not implemented to review 85,000 drugs. Top selling FDC. FDCs dominate 87% of sales, and we all know that because we keep on prescribing FDCs, limited clinical trials of FDC in Indian patients. That is there. Dr. Narsingh Verma was talking about pharmacovigilance. Very poor pharmacovigilance network or framework in India. Not to forget. There are challenges of FDC, lack of bioavailability data, lack of randomized control trials, lack of post-marketing studies, caution by prescriber of FDC. FDC should be used with caution due to following reasons. Trade name of FDC may not indicate names of constituents. That we see day in and day out. And their dosage in FDC may confuse the prescriber. Other healthcare provider like nurses, pharmacists, and diabetes educator may get confused by names of FDC. Prescribers should be aware of individual components of FDC which they prescribe and their potential interaction and contraindication. For example, triple FDC of glimepiride, metformin, and pioglitazone may be prescribed for glycemia to a patient of stable CHF stage 3, where pioglitazone may be contraindicated. So you have to stop that. In case of adverse event, entire medication or FDC may need to be stopped. It is likely that GI adverse events of metformin may be increased due to AGI, and thus we need to stop FDC. What can be done? Measures to promote rational FDC use, good pharmacovigilance. There should be post-marketing studies, good rationale to prescribe proper FDCs, good bioavailability studies of each FDC component. Irrational combination should not be allowed by the government, and active enforcement should be there by the regulator. So the take-home message is double or triple FDC should be used with caution by prescriber. If used properly and judiciously, good FDC can provide better glycemic control than the individual component. They are safer, they are well tolerated, they are economical, and may improve compliance that we see day in and day out. Physicians should take efforts to educate themselves and their paramedical colleague about proper content and dosage of FDC to avoid prescribing errors. So use of FDC widely with adequate medication counseling and surveillance should be done by the prescriber. With that, thank you very much.
Thank you so much, sir. We'll take the questions later on. We have a next speaker who's another prominent speaker from Lucknow, Dr. Ajoy Tiwari, sir. Sir is Director and Consultant Diabetologist from J Clinic and Diabetes Care Center, Lucknow. Over to you, sir.
Thank you. chairpersons. And at the onset, I'd like to thank Dr. Manoj and Dr. Purvi for giving me this opportunity. So I'll be speaking in another 15 to 20 minutes about gliclazide and its combinations. What is the evidence that gliclazide is different from other sulfonylureas, and what are the available combinations, and what are the safety, efficacy, and convenience of using these particular things. So I'll start with this very important paper which was published in the 2024 Diabetologia, and it came from Dr. Kunti, Dr. V. Mohan, and they said that in this cacophony or the din of what we are using, GLP-1 analogs and SGLT2 inhibitors, still glycemic control is central to the management of diabetes. So what they have said and their wisdom is therapeutic strategies should aim for intense glucose lowering to achieve personalized glycemic targets, especially in people with early type 2 diabetes who do not have complications rather than being based exclusively on organ protective effects. So this is the wisdom, and the traditional drugs such as metformin, sulfonylureas, and DP4 inhibitors have proven glucose lowering efficacy in RCTs and are well tolerated in real world settings. Combination therapy can be used to achieve early and sustained optimal glycemic control instead of more common stepwise introduction of additional therapies. So this is the wisdom, and this is wisdom is coming in 2024, despite of what we have been being bombarded by the pharma companies about the newer drugs. So this is pertinent, and I don't say that it is the only thing, but we should not overlook this particular fact. And why this fact is important, because we know the efficacy of different agents, and we know that sulfonylureas give us an A1C reduction of around 1.25 to 1.5, and when we add metformin, we have another 0.69% reduction in A1C. And if you compare the newer therapies like DP4 inhibitors and SGLT2 inhibitors, we have reduction to the tune of around 0.75%. So this particular point is pertinent, and this is very pertinent in newer onset diabetes and early on in the course of disease when we do not have problems. So sulfonylureas are time tested, and they were discovered serendipitously, and the serendipitously is that basically what sulfonylurea, because this was a time of World War II and lot of antibiotics were being discovered just to treat the wounds, and what they found that this particular group, the sulfonamides, they are also causing decrease in blood sugar levels. So this was a serendipitous finding, but this finding was very good for us, and it changed the way how we treat diabetes in next decade or two. So this is a very interesting what a physician can do at his OPD setting. So this is from the International Journal of Diabetes from Developing Countries. So they have said that there could be two possibilities: the maladaptive anabolism, that is the phenotype is overweight, obesity, high blood pressure, dyslipidemia, and the pathophysiology is predominantly insulin resistance. And the choice is GLP-1 analogs, SGLT2 inhibitors, and for predominantly catabolism, that is thin build, cachexia, obviously insulinopenic patients, there we have to go for insulin or insulin secretagogues. And then the eubolism is DP4 inhibitors and AGIs. So the sulfonylureas are at the center of this fulcrum, and they can be used with almost all the therapies. So now coming to gliclazide. So how it is different? So gliclazide, the problem was that it was a European molecule and it was not an American molecule. So we have to understand that all the studies that were with gliclazide, they were basically from the European countries. And it did not get prominence because it was not in the American realm. So this is how it differs from the other two prevalent ones, the glibenclamide and glimepiride. So this benzomide moiety, that gives it a very different outlook. So gliclazide XR inhibits single and reversible binding to beta cell receptor, unlike glibenclamide and glimepiride. So this is the reason why it has lower rates of hypoglycemia. So I'll be discussing the advanced and advanced on trials, which were the two trials with this. And the second point is weight neutrality. So this was the only sulfonylurea, and in the advanced and advanced on trials we found that it did not cause any significant weight gain. And unlike other sulfonylureas, glycoside XR does not activate PAC2. This is the factor which is responsible for the exocytosis of the insulin granules. And the glycoside is highly specific for beta cell potassium ATP, hence does not overstimulate beta cell or cause hypoglycemia. So this is the mechanism which is implicated that it did not cause hypoglycemia. So again, I will use this term, that is a forgotten felon, because it was not in the American realm, so it was not taken up that well. So what are the positives with this? So we have superior glycemic control, preservation of the beta cell of the pancreas, unique cardioprotection and a unique nephroprotection, and excellent safety. So this is from the advanced trial, and they have seen, and if you see that the reduction in A1C from the baseline with the different levels of A1C was from 0.9 to 4.3. So we have significant reductions were observed in those with initial A1Cs over 10%. So this is obviously there that higher the A1C, higher will be the reduction in the A1C with the drug. And the glycoside metformin provides rapid fasting and HbA1c reduction. So this is another slide from the advanced trial. And then the most important factor that is told about sulfonylureas is that the glycemic durability is lost over a period of time. So this was a study which went for around 4.3 years, and what you see that they were able to achieve with a glycoside dose of 120 milligram in A1C of 6.5% over the entire duration of the advanced trial. Then another important thing which is implicated for sulfonylurea is the secondary failure rates. So this is from our own Dr. A.K. Singh and et al. So what they have found that the secondary failure rates comparison of glycoside, glibenclamide and glipizide. So it was 7 as compared to 17.9 and 25.6 with the glipizide. Then very important about the incidence of hypoglycemia in Muslim patients with type 2 diabetes treated. So this was another study by Al-Sifiri, and this is basically to tell the potential of hypoglycemia those who are being treated with glycoside. So if you see what they compared, and they found that the rate of symptomatic hypoglycemia compared with the DPP-4 inhibitor, that was sitagliptin in this study. So we have very good evidence that it causes very less hypoglycemia as compared to the other sulfonylureas. Then advanced trial. So this was the trial on which most of these slides are based. So this was a trial with more than 11,000 patients, and it had predominantly people from the Asian origin. And this particular trial, they went for an intensive arm with glycoside XR and any other SU in the standard arm except for glycoside. So if they were using any other agent, it was, if they were using a sulfonylurea, it was not to be glycoside, but it could be other molecules or any sulfonylurea except for glycoside. So then as regards to the strict weight neutrality, so weight loss was 1.6 kg in glycoside MR based intensive glucose control for patients not taking insulin or thiazolidine. So this was a subgroup analysis. They found that in those patients where no thiazolidine or insulin were used, there was a weight reduction, and that was to the tune of 1.6. And overall, there was just a gain of 0.7 kg in the glycoside group as compared to the intensive or to the conventional arm. So we have a very strict weight neutrality, and that was to the tune of around gain of around 0.7 kg. So that was negligible, and this was over a period of 5 years. Lowest rate of hypoglycemia, this was with Accord UKPTS at glycoside MR, and we were using 120 milligram of glycoside in this particular study. The cardiovascular mortality was reduced by -12%. It was not statistically significant. 20% more patients regressed to normal range of this. So this was a regression from macroalbuminuria to microalbuminuria in this particular study. And as compared to baseline, 57% of the patients regress from macroalbuminuria to normal range of macro. So as regards to the primary endpoint, that was a combination of micro and macrovascular complications. There was a statistically significant reduction of 10% in this particular study, that is the advanced study. So then they followed up these patients with the advanced on trial, and these patients were followed for another 5 years, and then they found that It cuts the risk of dialysis or renal transplant by half over a period of 10 years, thus preventing the number one complication leading to death in diabetes. So 46% reduction in ESRD when these patients, so early intensive control that was achieved with gliclazide and XR in the advanced trial, so it has got legacy effect when it was followed up in advanced trial. The CV safety and negligible increase in requirement of insulin. So this was a comparison in the conventional and in the intensive group and the standard group. So almost similar requirement of insulin in these two groups. So advance on the largest long-term study in the field of diabetes proves significant 46% reduction in ESRD, no beta cell exhaustion, and no adverse CV events in long term. Then very important thing about the gliclazide protects human islet cells, beta cells from apoptosis induced by intermittent high glucose. So this article by Del Guerra et al. In Diabetes Metabolism, and another systematic study by Simpson et al. Found additional antioxidant, hemorrhagical and fibrinolytic properties of gliclazide. Another study reported by Sliwinska et al. That gliclazide can diminish oxidative stress-related cell damage and death as it decreases reactive oxygen species production, elevates mitochondrial membrane potential, and diminishes intracellular calcium in human, normal, and cancer cells. So a potential is there because to reduce the reactive oxygen species. Then the most important thing, that is whenever we are discussing about sulfonylureas, we are always concerned about the cardiovascular safety. So UKPDS found no detrimental effect of sulfonylureas on macrovascular complications or mortality in people with type 2 diabetes. The benefit persisted up to 10 years in patients who had attained better glycemic control. Other trials also showed where treatment were not found to be associated with increased CVD risk of mortality, and modern sulfonylureas are associated with lower risk of all-cause and CV related mortality compared to conventional sulfonylureas. So this is the this is from the meta-analysis that I quoted earlier, that is from Simpson et al. And they compared the various all-cause, risk of all-cause and CV related mortality among sulfonylureas, and you see the best results are with the gliclazide. Then as regards to sulfonylureas in renal impairment, so this is from the safest trial, the safest group, and they have found that gliclazide MR, no dose adjustment in CKD stage 3 to 5, dialysis, avoid low dose and careful monitoring, and the complications are hypoglycemia. Then a comparative study of gliclazide and glimepiride, that is the guide study, and this was the baseline characteristics, and the age was 60 years of these patients. And as regards to the A1C control, it was similar in the two groups, but the gliclazide XR and metformin achieves glycemic control with less risk of hypoglycemia, that is 70% less risk of hypoglycemia with a similar reduction in A1C of 1%. Then combination therapies with gliclazide. So this is a consensus recommendation on sulfonylureas and sulfonylurea combinations in the management of type 2 diabetes mellitus. So this was international task force, and this also came from the Indian Journal of Endocrine Metabolism. So modern sulfonylureas are effective and safe second-line agents in patients who have not achieved pre-decided glycemic targets with metformin monotherapy. The evidence level was 1, and the modern sulfonylureas are effective and safe as initial therapy used in combination with lifestyle modification and metformin in patients with a baseline glycated hemoglobin of more than 7.5%. Again, evidence level 1 and the grade A. Then sulfonylureas may be considered for use in combination with all classes of oral anti-diabetic drugs except glynides. Then again, grade A, and the evidence level is 1. And if not used earlier, modern sulfonylureas may be preferred as third-line agents for the management of uncontrolled diabetes with dual combination therapy owing to better safety profiles than older sulfonylureas. And fixed dose combinations containing sulfonylureas reduce cost, offer convenience, and important patient adherence. The label of evidence is grade B, EL1, and hence FDCs with varying strengths of sulfonylurea metformin should be made available, while sulfonylureas and the drugs may be considered. Then comparative assessment as dual therapy with metformin. So compared to metformin up titration beyond half maximal dose, the addition of sulfonylurea to metformin demonstrates better glucose lowering efficacy, safety, and tolerability. So that's also a very important statement, that if you keep on increasing up titrating the metformin beyond the half maximal dose, that is 1 gram, you won't get much benefits. It's better to add a sulfonylurea. And compared to pioglitazone, sulfonylureas demonstrate good glucose lowering efficacy with significant lower risk of weight gain. Compared to DP4 inhibitors, sulfonylureas demonstrate better and more durable glucose-lowering efficacy. Compared to SGLT2 inhibitors, sulfonylureas show non-inferior glycemic control. However, safety criteria needs to be considered while preferring either class. And compared to GLP-1 analogs, SU shows similar glycemic efficacy with acceptable safety and lower cost. So this is additional when you are adding a sulfonylurea to OHA, the A1C reduction is to the tune of 1.62. This is another study, real world study from India with the HealthClicks data, and they found that the weight reduction was from 0.8% to 1.2% when we adding gliclazide and metformin. Then sulfonylurea is third line in new onset diabetes mellitus. So in new onset type 2 diabetes mellitus, triple therapy with anti-diabetic drugs that enhance insulin sensitivity and beta cell function led to a higher and more long-lasting
Sir,
protection.
please wind up.
Yes. I'm just putting in the last few slides. So this is about as third line agents. So we have got evidence that we are using the three drugs, that is the sulfonylurea, pioglitazone and metformin. We are getting better results. Combination with insulin, we are all well versed with the BITS therapy. So adding it with the antipodal. Antipodal is that you use bedtime insulin and the first breakfast as the insulin. So few of the recommendations from the global bodies for gliclazide versus other sulfonylureas. So we have got the safest guidelines, and they have said that gliclazide preferred over conventional sulfonylureas. Another guideline from Australia, global resource WHO, gliclazide is the preferred sulfonylurea. Gliclazide versus other sulfonylureas, again, we have told that this is not in the American realm, so we have all guidelines from the Europe and Canada and Australia. Our own RSSDI ESI 2020 recommendations, gliclazide can be preferred over conventional sulfonylureas in patients at increased risk of CVD or with CVD. Newer sulfonylureas like gliclazide can be preferred in patients with moderate or severe renal impairment. Then safest we have already discussed, and we have already discussed that in patients with renal compromised patients, this can be given. So finally summarizing what I said, so what we have got the least amount of secondary failure with gliclazide as compared to the other two sulfonylureas available to us. And we have seen that the glycemic control and the beta cell exhaustion is not seen with gliclazide as compared to sulfonylureas, because it has got the least secondary failure rate. And the advanced trial showed no weight gain in type 2 diabetes patients. So that was very interesting, that was only 0.67%, and that was non-significant. And the guide study demonstrated that compared with glimepiride vis-a-vis, we have lesser amount of 70% lower reduction, levels of hypoglycemia as compared to glimepiride with the same A1C reduction. So with this, I thank you for patient hearing. I was the last batsman, so I think I did great justice to what I could do.
Thank you, sir. Thank you very much for this. This is a very important topic. Now, if you have any questions from the audience, very important topics we discussed. Anything? I don't think any questions from anyone, please. Yes, madam, please. Can you have a mic there? Yes.
Regarding the advanced trial, it is said that the reduction of HbA1c, that is high control of blood glucose, delays the progression of diabetic nephropathy. But in that intensive control arm, this perinopral indapamide was also used. So probably the reduction of blood pressure also contributes to the regression of nephropathy.
Yes, I definitely agree with you that adding an ACE inhibitor and diuretic, because there were two arms of the trial. One was with the gliclazide and other was with perinopral and indapamide. So obviously when you're using ACE inhibitors, definitely we are having. So basically, if you see what is the wisdom, that we need not focus only on one aspect, that is the glycemic control. We have to look for other things like ACE inhibitors and ARBs, other factors also, the lifestyle management, sedation, smoking, as we have seen is steno trial, and we have seen that in steno trial we got better benefits as regards to the cardiovascular mortality and other things 8 and 12 years after these trials were initiated. So obviously that is very right that this perinopral indapamide could have contributed to that.
Yeah, but it was a 2-into-2 factorial design, so probably the design was such that we were looking at the glycemic
benefit also, independent of the benefit on the of the effect on the blood pressure. So I think there's another question. You have any other questions? If there are no further questions, I think we had a long day and everybody is looking forward to the evening, to the cocktails.
To those combinations.
Dinner. So thanks to all the speakers who have done a wonderful job. With that, we'll request the organizers to present the mementos to the speakers, and we'll wind up there. Yeah,
And
over to
also,
Gaurav.
if all the speakers could get on the stage for a group photograph, please. Thank you all for joining us for the final session of the evening. We look forward to seeing everyone at the gala dinner tonight. The event continues tomorrow, and I wish everyone a safe journey and enjoy your evening. Thank you so much.